और डॉक्टर उसका इलाज सही ढंग से ट्रीटमेंट करने के बाद भी सही नहीं हुआ। डॉक्टर वहाँ के रूम के बाहर मरीज को खड़ा करके पेशेंट से बात नहीं अच्छे से करते थे, ना रिपोर्ट से ही दवा चलाते थे, बिना मरीज के बातों को सुने। जिला अस्पताल के डॉक्टर ने जब हार मान ली तो बीएचयू से ले जाने को बोला। फिर बीएचयू ले जाते ही डॉक्टर्स ने जवाब दे दिया कि ये नहीं बचेगा। ये बातें भाई ने डॉक्टर से सुन लिया था। फिर वहीं के जूनियर डॉक्टर ने दिल्ली जाने को कहा। हम लोग तत्काल दिल्ली आए और फिर यहाँ हॉस्पिटल में आने पर बच्चा वार्ड में एडमिट किया गया। क्योंकि बच्चा वार्ड में केवल महिलाएं रह सकती थीं, इस वजह से मुझे वहाँ काफ़ी सारे मरीजों के बीच रहना पड़ा। फिर डॉक्टर संगीता मैम के नेतृत्व में भाई का बेहद अच्छी तरह पूरा ट्रीटमेंट हुआ। ट्रीटमेंट के दौरान डॉक्टर संगीता मैम ने वार्ड में बराबर आकर भाई को अपने बच्चों जैसा प्यार देती और भाई को हंसाना और मोटिवेट करती थी। डॉक्टर संगीता मैम ने भाई को ऐसा प्यार और समझाया कि बच्चा तुम बिल्कुल ठीक होकर दौड़ते हुए जाओगे। यह बात बीएचयू से बोली गई, जो डॉक्टर ने बोला कि ये नहीं बचेगा। डॉक्टर संगीता मैम द्वारा सकारात्मक एनर्जी, मोटिवेशनल और अच्छी ट्रीटमेंट पाकर वो ठीक होने लगा और ये सारी बातें निगेटिव थिंकिंग वो मन से हटाने लगा। चूँकि भाई केवल अकेला न महसूस करे, इसलिए मैं उसके बेड पर रहती थी। साथ में हमेशा रहने के कारण और मास्क नहीं अच्छे से लगाने की वजह से मुझे इन्फेक्शन हो गया। डॉक्टर संगीता मैम द्वारा जब रूम में आकर मुझे समझाया करती थी कि मास्क लगाया करो, तुम अभी अभी ठीक हुई हो और लापरवाही ना करो। मेरी लापरवाही के कारण मुझे यह बीमारी फिर से हो गई। फिर जांच के दौरान मुझे दिल्ली में जब मैं 5 महीने तक रही, उस वजह से मुझे इन्फेक्शन और बढ़ गया। जिस प्रकार बच्चा वार्ड में डॉक्टर संगीता मैम ने सभी बच्चों को प्यार और समझाना और ठीक हो जाने का एहसास दिलाना बहुत बड़ी बात है, क्योंकि मरीज खुद घबराया होता है और जब मरीज से डॉक्टर पूरी तरह बात समझ लें और मरीज को हिम्मत दे तो वो वहीं ठीक होने लगता। और मैं देखी डॉक्टर संगीता मैम ने बच्चा वार्ड के सभी मरीज को प्यार से बातें और समझाया करती थी। उस वक्त हम लोग होपलेस होकर यहाँ आए थे। मैम ने भाई को समझाने के साथ साथ मुझे और पापा को भी बहुत हिम्मत दिलाई। हम लोग डॉक्टर संगीता मैम को बच्चों का भगवान मानते हैं। मैम ने भाई का इलाज बहुत अच्छी तरह से किया। मैम ने हम सबको बहुत हिम्मत दिया। जब हम दिल्ली से यूपी आए, मैम ने बराबर कांटेक्ट करती रही, चूँकि कोविड की वजह से यहाँ पे दिखा नहीं सकते थे, इस वजह से मैम वीडियो कॉल पर भी बात की। जब सही तरीके से सही समय पर इस रोग का इलाज हो तो ये रोग से लड़ा जा सकता है। अब डॉक्टर संगीता मैम की सलाह से दवा हुई और भाई मेरा अब बिल्कुल ठीक होकर यहाँ आया है। फिर यूपी आकर मुझे यह बीमारी होने के कारण मेरा जिला अस्पताल से दवा हुआ। दवा कुछ डबल डोज डॉक्टर देते थे। दवा के साइड इफ़ेक्ट से पैर में झुंझुनाहट होने लगी थी और दवा मेरी गलत चलने लगी। फिर दिल्ली आकर यहाँ पे सभी डॉक्टर ने यहाँ पे मुझे हिम्मत दिया और मोटिवेट किया। फिर यहाँ पे दवा सही ढंग से चली और मैं बिल्कुल ठीक हो गई हूँ। अब मैं बिल्कुल ठीक हूँ और आप मरीजों लोग ध्यान रखें कि खाने पीने में लापरवाही न करें ठीक होने के बाद, क्योंकि शरीर कमज़ोर रहती है और यहाँ पे लापरवाही होने से बीमारी होने का डर रहता है। मेरे लाइफ में बहुत डॉक्टर से मिले पर यहाँ पर लगा कि सही में ईश्वर के समान डॉक्टर हैं। धन्यवाद।
भगवान स्वरूप बैठे हुए सभी डॉक्टर्स और अभिभावक बंधुओं को मेरा प्रणाम। ये मेरा बेटा आर्यन है जो यहीं से ठीक हुआ। इसके पहले मैं कुछ अपनी बीती हुई कहानियाँ बताना चाहता हूँ। मैं, मेरी बीवी, एक लड़की और 2 लड़के थे। कुछ समय पहले बीवी अचानक बीमार पड़ी, पास ही के नर्सिंग होम में लेकर एडमिट किया, ट्रीटमेंट किया। टाइफाइड था। लगभग 20 दिन तक भर्ती करने के बाद स्थिति उसकी और ख़राब होती गई। जब उसकी जांच हुई तो पता चला कि उसकी दोनों किडनी सूख गई है। फिर भी बीएचयू में दवाइयाँ हुई, नहीं बचा सका, एक्सपायर कर गई। उसके कुछ दिन के बाद बड़ा बेटा वो भी बीमार पड़ा। पता चला कि उसको बच्चों की किसी के संपर्क में आने से टीबी हो गई है। आजमगढ़ में दवा चली, लेकिन दवा सही ढंग से नहीं चल पाई, लोग समझा नहीं पाए, न बता पाए, ठीक से जांच नहीं हो पाई। पेट सूज गया, पेट में पानी आ गया और 2.5 महीने के बाद वो भी एक्सपायर कर गया। घर की स्थितियां और ख़राब होती चली गई। उसी के सदमे में आर्यन और घर का एक और लड़का, दोनों जैसे बीमार हो गए। जब दोनों की जांच कराई गई तो वहाँ के डॉक्टरों ने दोनों को टीबी घोषित कर दिया। दवा 20 दिन तक चली, 25 दिन तक चली, दवा और इंजेक्शन दोनों चला, लेकिन ये लोग दवा नहीं पचा पाते थे, उल्टी हो जाती थी। इन लोगों ने कहा कि नहीं, मैं दवा नहीं खाऊंगा, मुझे उल्टी हो जा रही है, मेरा फिर से जांच कराया जाए। जब फिर से जांच कराया गया तो एक को निगेटिव और एक को पॉजिटिव हुआ। जिसको निगेटिव हुआ उसको दवा बंद की गई, लेकिन इनकी दवा चलती रही। पता नहीं वो भी सही रिपोर्ट थी या नहीं। 7.5 माह तक वहाँ पे दवाइयाँ चली। उसके बाद इसकी स्थिति इतनी ख़राब हो गई कि न ये उठ बैठ पाता था, न चल पाता था, न बोल पाता था। फिर मैं डॉक्टर से कहा कि सर, इसका 7.5 महीने के इलाज के बाद भी कोई एक्सरे नहीं हुआ और इसकी स्थिति ज़्यादा ख़राब हो चुकी है, क्या किया जाए। तब उन्होंने एक्सरे करवाया और मुझे बीएचयू भेजा। कहा कि इसको तत्काल लेके जाइए बीएचयू, इसके फेफड़े में सूजन आ गई है, पानी भर गया है, काफ़ी बड़ा हो गया है। बीएचयू ले गया तो वहाँ के बड़े डॉक्टरों के पैनल में बैठ करके बताया कि इसे अब घर ले जाओ, ये बचेगा नहीं, बस कुछ ही घंटों का मेहमान है, तुम यहाँ लाने में देर कर दिए। फिर मैं बाहर निकल करके रोने लगा, घबराने लगा। तो एक उसी में से ही एक जूनियर डॉक्टर निकले, उन्होंने कहा कि आप घबराइए मत, आप दिल्ली चले जाइए, वहाँ पे आपका लड़का बिल्कुल ठीक हो जाएगा, कोई परेशान होने की ज़रूरत नहीं, अभी वो ठीक है। थोड़ा हिम्मत मिली, दिल्ली आया। मैं चूँकि कभी पहले दिल्ली नहीं आया था, लेकिन यहाँ आने के बाद डॉक्टर संगीता शर्मा के नेतृत्व में उसका इलाज हुआ। उन्होंने पूरी मेरी जब कहानी सुनी तो भावुक भी हुई और उन्होंने कहा कि आप घबराइए मत, आपका लड़का यहाँ से दौड़ता हुआ जाएगा, 2 महीने में मैं इसको बिल्कुल ठीक कर दूँगी। लेकिन मैं 5 महीने तक यहाँ पे पड़ा रहा, चूँकि उसी समय कोविड का चल रहा था, सारे रास्ते बंद थे। मैं प्राइवेट वार्ड में 5 महीने तक लेके रहा और जब 5 महीने बाद लड़का हॉस्पिटल से निकला तो खूब घूमता टहलता और हंसते बोलते यहाँ से ठीक होकर के, बिल्कुल ठीक होकर के निकला। इनका बहुत बड़ा योगदान रहा। मैं तो यही कहूँगा कि यहाँ के डॉक्टर्स भगवान स्वरूप हैं, सचमुच में भगवान होते हैं। और यहाँ एक इंजेक्शन लगा था लड़के को जो काफ़ी कीमती था, 6 महीने तक चला, लगभग 5,000 के आसपास बैठता था वो इंजेक्शन, जो कि मैं आप लोगों के माध्यम से मैं भारत सरकार से अनुरोध करना चाहता हूँ कि उस इंजेक्शन को फ्री किया जाए, क्योंकि वो हर गरीब आदमी उसका इलाज नहीं करा पाएगा, इतना महंगा है। और कुछ दवाइयाँ हैं जो कि टीबी की दवाइयाँ मार्केट से खरीदनी पड़ती हैं, जैसे मोनोपाज मैं पूरा बाहर से खरीदता हूँ मार्केट से, जो महंगी पड़ती हैं, वो भी सरकार से कह करके उपलब्ध कराई जाए, क्योंकि हर गरीब आदमी बाहर से नहीं खरीद पाएगा। और मैं डॉक्टर संगीता शर्मा को धन्यवाद करता हूँ और कहता हूँ कि उनको ईश्वर बड़ी लंबी उम्र दे, जिससे वो समाज की सेवा कर सकें। धन्यवाद।
मैं आर्यन यूपी के आजमगढ़ जिले से आया हूँ। यहाँ पर बैठे हुए सभी ईश्वर स्वरूप डॉक्टर लोगों को मेरा प्रणाम। खासतौर पर डॉक्टर संगीता शर्मा मैम मैम को सत नमन, जिन्होंने मुझे जीवन दिया। सर्वप्रथम जब मैं बीमार पड़ा और वहाँ के डॉक्टर द्वारा सही ढंग से इलाज नहीं किया गया और डॉक्टर की लापरवाही के कारण और मुझे मेरा स्थिति खराब हो गया। जब पापा मुझे घर से दिल्ली लेकर आए और मुझे वहीं पर ही पता चल गया था कि मैं अब नहीं बचूंगा, क्योंकि वहाँ के डॉक्टर ने मेरे सामने पापा से यह बात बोल दिए थे और मैं सुन लिया था। फिर जब हम दिल्ली आए तब डॉक्टर संगीता शर्मा मैम ने कहा कि बेटा तुम बिल्कुल ठीक हो जाओगे और दौड़ते हुए घर जाओगे, तुम्हारा यहाँ पर सही इलाज होगा। और डॉक्टर संगीता मैम ने मेरा इलाज अपने बच्चे की तरह किया। लाड प्यार के साथ मुझे हिम्मत दिलाना और डॉक्टर संगीता मैम ने कहा कि तुमको बड़े होकर अच्छी शिक्षा पाओ और अच्छा बड़ा आदमी बनो और जीवन में अच्छे काम करना। जब मैं दिल्ली में 5 महीने तक इलाज के बाद अपने घर गया तब डॉक्टर संगीता मैम हमेशा कांटेक्ट करती रहीं और वीडियो कॉल करके मुझे हिम्मत देती रहीं। मैं इन्हें भगवान मानता हूँ। मैं इनका जीवन भर आभारी रहूँगा और मैं ईश्वर से ही प्रार्थना करूँगा कि ये हमेशा निरोग रहें, तरक्की करें और इन्हें लंबी आयु मिले, जिससे समाज की सेवा करती रहें और इससे लोग सीख लेते रहें। इस समय मैं हाई स्कूल में यूपी बोर्ड से 66% रिजल्ट लाया हूँ। अब मैं 11th में मैथ ग्रुप से पढ़ा हूँ और अपने स्कूल में खेलकूद में भी भाग लेता हूँ। धन्यवाद।
Next, we would like to invite on stage respected Dr. Sarabjit Chadha as the moderator for discussion on the group diagnosis, overcoming the large case detection gap in the pediatric age group. Dr. Chadha is the Regional Technical Director at Foundation for Innovative New Diagnosis. I would request Dr. Chadha to join us on the stage and give a brief session about the speakers in the session. Please, sir.
Very good morning to all of you. I think it gives me great pleasure to be here at NITRD once again. You know, I've been working with this institute for more than a decade now with esteemed colleagues and faculty here. So today's discussion, on this MSF NITRD Collaborative TB Day 2022 is on overcoming the large case detection in the pediatric age group. I think I would be preaching to the choir if I'm telling you more about what the challenge is. But as you all are aware, that TB is now one of the top 10 killers, especially in the age group of under 5. There have been several advances in the last decade or so which have actually helped diagnose more TB amongst this vulnerable age group. And the key actually is the CBNAT or the molecular diagnostic platforms. There is still a lot of work that needs to be done since children, especially the under 5, are not able to produce sputum. So alternative respiratory samples like gastric aspirates, induced sputum, gastric lavage, stool, all of these have now been validated, and WHO actually recommends that these tests should be used in this age group for better diagnosis of TB. The introduction of the ultra cartridge, which the National TB program is still contemplating to adopt under the under the programmatic settings, has also improved the TB case detection, since in this age group, you mainly have paucibacillary disease and you need more sensitive tests. Other non-respiratory samples like urine are also quite promising, especially in HIV positive and malnourished children. And we have now the Fujilam test, which is currently undergoing validation by FIND, and after it gets endorsed by WHO, it will also be recommended as one of the tests for use in this pediatric age group. Computer-aided diagnosis using digital X-rays has also been a major advancement, and very recently, in 2021, WHO has actually come up with a rapid communication for using CAD or AI-enabled X-ray systems for diagnosis of TB for screening of TB in both adults and children. While in children more than 15 years, the results are almost similar to adults, but in children less than 15 years, we find that the spectrum could be variable. So probably we need more robust systems, and we have a session today on this as well. So without further ado, I would like to invite the esteemed speakers for this session today. I would like to invite Dr. Anurag Agarwal, who's Professor Pediatrics, Maulana Azad Medical College, and Lok Nayak Hospital, Delhi. Mr. Praveen Kandaswamy, Project Leader, PATH. Dr. Laura Morito Planas, I hope I'm pronouncing the name correctly, HIV, TB, hepatitis referent from MSF. Dr. Shibu Vijayan, Medical Director, Global Health Cure AI. Dr. Alok Yadav, Chief Medical Officer, NITRD. I will need to. We'll start with the session now. I would now request Dr. Anurag Agarwal for his presentation.
So, good morning, friends. I am a pediatrician, Professor Pediatrics. So, what am I doing in a conference on the dais where such senior people of tuberculosis who are working in this field of tuberculosis over last many years? I do not know. So I'll just present my short session, which a study which I conducted. In fact, I did it with some of my students. It was regarding, so the problem in pediatrics is that how do we get a sample from a child? It is a paucibacillary disease in pediatrics especially, and obtaining a sample from a child is very difficult. So this is a problem we have been facing in our wards in OPD practice. For a gastric aspirate, a child has to be kept nil orally for the whole night. Then in the morning, a sample has to be taken, a NG tube has to be inserted, which is a painful procedure for the child. The child cries, the parents are not happy. And in OPDs, it is difficult to do it because, again, you start a OPD at around 10 or 11 a.m. and the child has to be nil orally for the whole night. He wants food, he's crying, he's hungry, he's irritated. And it's a bad experience for the family and the child. So we thought, can we do something else? Can we do something else, something which is easier for the child and the family? And therefore, we thought of the idea that let's have a non-invasive, rapid, easy method of diagnosis, which could be, can stool CBNAT be used in the diagnosis of pulmonary tuberculosis in children? So that was our basic premise. We thought, okay, let's give a try on stool. We did some reading up on the literature, what is available, and we thought, okay, let's give a try on this modality in our setup, which is very practical. And it's a pediatric, it's a multi-speciality hospital which has a 250 bedded pediatric setup, and we get a lot of patients of tuberculosis requiring all kinds of care, right from primary care to tertiary level care. So we started with this study, and the primary objective was to determine the diagnostic utility of stool CBNAT amongst presumptive cases of TB, and the secondary objective was to compare the diagnostic utility of stool CBNAT with gastric aspirate CBNAT in these children. So keeping these objectives in mind, we designed a cross-sectional study, and we took children aged 6 months to 12 years. We got a CTRI registration done, and the inclusion criteria was the NTEP guidelines, in which we had the suspected cases of TB, which was unexplained fever for more than 2 weeks, unexplained cough for more than 2 weeks, history of weight loss, unable to gain weight, and history of contact to tuberculosis. And we excluded patients who were able to expectorate. So we didn't want to do a gastric aspirate in the patients who were able to expectorate. And those patients who received ATT for more than 72 hours, we excluded. And we didn't want our sample to get diluted because of later on situations when we say that, okay, it is GI tuberculosis, that is the reason we got positive. So we excluded any suspicion of GI tuberculosis, that is pain abdomen for more than 2 weeks with ultrasound suggestive of mesenteric lymphadenopathy. And sample size calculation, we used the study of Chipundro et al. And the sample size we got was 116, but we took only 75 samples due to time resource constraints. And once we decided upon this, after taking our approval from ethics committee, we started recruiting patients, took informed consent, and enrolled 75 patients, did a clinical history and examination, investigations like chest X-ray, TST, and other relevant investigations as decided by the clinician were done, and the samples of stool were collected, stool and gastric aspirate, and they were both subjected to CBNAT and MJET. Stool processing, this we picked up from some studies, and of course we had a discussion with Delhi University team. There was a team working there also, and of course Dr. Ashwini, Dr. Hanif from our NDTB and chest clinic. So we picked up the processing style because this is slightly different from what others had done. We took a sample of 0.15 gram of stool, we took it in a loop, put it in a centrifuge, added 2.4 ml of PBS, then vortex the vegetable cells from the stool, left it for 25 degrees for 20 minutes, centrifuged it at 3200 gyrations for 15 minutes. Then the sediment was resuspended in 1 ml of PBS, phosphated buffer saline, and it's very easy to do it. Technician was doing it. I saw him doing it once or twice. After that, he was doing it on his own. And this sample was mixed with expert reagent and then processed accordingly. Gastric aspirate processing was done as per the NTEP guidelines, that is the standard. And CBNAT and MJET were again processed as per the standard guidelines. So outcome was diagnostic utility of stool CBNAT. Measurement was proportion of stool CBNAT positive in presumptive cases and comparison with reference standard, that is MJET. And we look for sensitivity, specificity, PPV, that is positive predictive value, negative predictive value, and then comparison of stool and GA CBNAT. We look for degree of agreement because gold standard was MJET. So if you have another test which is not a gold standard, so we thought, okay, let's look at degree of agreement, and for that we applied Cohen's kappa. And then Fisher exact test and chi-squared test was used to compare the qualitative variables, and p-value less than 0.05 was taken as significant. So out of total enrolled, that is 75 patients, confirmed cases were 11, that is gastric culture, MJET positive. Clinically diagnosed patients were 17 on grounds of CBNAT positive but culture negative or other clinical criteria on which ATT was started. So this was a clinician's decision, not our decision. And out of the suspected cases, 47 were not started on ATT. They were further investigated and found to be not tubercular, so not started on ATT. Baseline characteristics, significant was inpatient status. So in confirmed cases, 90% were inpatient, and malnourishment was much more common in the confirmed age group as compared to clinically diagnosed and not started on ATT. Age and gender were not significant. Cough, again, as per NTP guidelines, we found more than 2 weeks in 10 patients, more than 4 weeks in 6 patients. Fever was present in all 11 patients. So these were all aligned with NTP guidelines, what we found. X-ray findings, again, NTP guidelines were proved to be very relevant. Miliary shadows had the nearly the maximum cases who showed us confirmation on TB, and the main issue was that non-specific X-ray findings were not consistent with pulmonary TB. So whenever there was non-specific finding on X-ray, we did not get anything positive. We did not get confirmation in those. And hilar lymphadenopathy, consolidation, effusion, and miliary. So these were the 4 groups in which we got confirmed cases of tuberculosis. Montaux, same story, 10 patients, 5 patients were positive, the confirmed ones, and 5 were negative. So Montaux does not have much of a relevance, which we are all again saying in NTEP guidelines. So now this comes, here comes the, color is changed. Okay, here comes the results, stool CBNAT versus gastric aspirate MGIT. So we did MGIT and we did CBNAT both on stool as well as gastric aspirate. So GA MGIT was the reference gold standard. So in GA MGIT we got 11 samples positive, whereas in stool CBNAT we got 10 samples positive. 8 samples were common to both the groups, 3 extra were picked up by GA and 2 extra were picked up by stool CBNAT. So sensitivity was 73%, specificity was 97%, positive predictive value was 80% and negative NPV was 95%. Then comparing GA CBNAT versus GA MGIT. So GA CBNAT versus GA MGIT. Both the groups showed us 11 positive, but both missed 1 sample each. So the total came out to be 11. Sensitivity was 91%, specificity was 98%. PPV and NPV were 91, 98%. So our quality of our sample was good. That is the reason we got nearly same in GA CBNAT versus GA MGIT. Stool MGIT versus GA MGIT, we got only 4 samples positive on stool MGIT. It simply means that maybe as the bacilli passes down the gut, it gets killed or destroyed on the way, and therefore only 4 samples came out positive as compared to GA MGIT where 11 were positive. Sensitivity was just 36% and specificities are mentioned already. Now coming to stool CBNAT versus GA CBNAT. So this was our primary aim of comparison. So we got 11 samples positive on GA CBNAT and we got 10 positive on stool CBNAT. 2 were missed on stool CBNAT, whereas 1 was missed on GA CBNAT. So we compared them and we calculated the weighted kappa, that is Cohen's kappa, and which gave us 0.834, which indicates a near perfect agreement. So 2 tests were in agreement in 96% of presumptive cases, and if we do sensitivity and specificity, sensitivity came out to be around 82% and specificity was 96 to 97%. So coming to discussion, we looked up the literature and found that sensitivity and specificity of stool CBNAT was varying across various studies. And first study we found was Nicole et al. Done in 2013 in South Africa. He got a sensitivity of 47.1%. And when we went through the article, we found that the sample was stored for more than 6 months. So maybe that was one of the reasons. And sensitivity of induced sputum in his study was 64.7%. That was also not very high. Musa et al. In Egypt got a sensitivity of stool CBNAT of 83.3%. And reference standard used was induced sputum culture on LJ media. Hassan et al. In Pakistan got sensitivity of stool CBNAT at 88.9%, that was pretty high. But in his study, 30% of the patients were immunocompromised. Chipundro et al., that was where the study which we used for sample size calculation, stool CBNAT detected was 13 out of 19 confirmed cases, that is 68%. And he did not mention the storage method, so we are not able to comment much on that. Another study done in India was Memon et al., where stool CBNAT sensitivity was just 11.54%, but here they did not centrifuge the stool sample. So that is the reason maybe that they were not able to get good results. McLean et al. Did a systematic review and meta-analysis of 9 studies, and he found stool CBNAT sensitivity to be 67% and specificity to be 99%. So the strengths of our study was that both stool and GA samples were centrifuged, MJIT was done on all samples, and immunocompetent patients were recruited. Limitations were we need to do a multi-centric trial, and one of the centers is already planning one across the country, so maybe we'll have more results across the country. And lot of patients in our study were inpatients, being a tertiary level hospital, and there were less number of children below 5 years category. So to conclude, stool CBNAT had a good sensitivity and specificity. Stool CBNAT had near perfect agreement with gastric aspirate CBNAT, and stool MJIT does not have a high bacteriological yield. Malnourished children, of course, are seen more in the pulmonary tuberculosis situation. Miliary shadows and hilar lymphadenopathy were highly suggestive of TB, and Montague's test is of limited value. So implications are, can stool CBNAT may emerge as a simple, practical, point of care test in rational management of childhood tuberculosis, particularly useful in a peripheral setting. So samples are easy to collect, easy to transport, and results are, processing in lab is also pretty easy. So can this be used in diagnosis of pulmonary TB in children? We would say yes, further data is still needed. Thank you so much.
Thank you, Dr. Anurag. So please hold your questions. I think we'll take it at the end of the session for all the speakers. I would like to now invite Dr. Alok Yadav, who's also going to present some data on CBNAT testing on stool as a sample for pediatric TB diagnosis. Over to you, Dr. Alok.
Good morning, everyone, and thank you, Chairperson, for inviting. I would like to present my thanks and gratitude to all the global partners who are present here, MSF, Director NITID, Dr. Ravinder Kumar Devan sir, and Head of Pediatric Department, Dr. Sangeeta Sharma ma'am, who give me the opportunity to present the ongoing project in the Department of the Pediatrics. So I am, without wasting my time, I start this project, the project which is ongoing in the Department of the Pediatrics. The title of the project is Comparing Sensitivity and Add-on Value of CBNAT and Expert Ultra on Pulmonary and Stool Samples. As Anurag sir had already explained regarding the stool CBNAT, in our study we add Expert Ultra in the pediatric stool samples. The principal investigator are Dr. Sangeeta Sharma madam, Head of Department Pediatric NITID New Delhi. Co-investigator is Dr. Manpreet Bhalla ma'am, Head of Department Microbiology NITID New Delhi, and co-investigator is myself, Dr. Alok Yadav. So the objective of the study is to comparing sensitivity and specificity of CBNAT and Expert Ultra with gold standard culture MGIT, and comparing sensitivity of stool sample with regular age-based pulmonary sample, that is sputum, induced sputum, gastric aspirate and gastric lavage. So in this study, this is a prospect cohort study in which we are taking 200 presumptive pediatric patient enrolled in this study. Simple one-step method is used for stool processing in this study. So in the pediatric OPD, we are taking in this study, we are taking the presumptive PTV cases as per the NTP guidelines, and then we do the chest X-ray. If the chest X-ray is highly suggestive to the tuberculosis infection, then we take the two samples. One is the pulmonary sample and other is the stool sample. In the pulmonary sample, we are taking the sputum, induced sputum, gastric aspirate, gastric lavage, depend upon the age of the child, and another is the stool samples. And in both samples, we are sending the smear examination, expert MTB for expert ultra and the midget cultures. So this is the interim data of 100 presumptive PTV patients right now. So all the stool samples are processed by the simple one-step method developed by the KNCB Tuberculosis Foundation. We adopt simple one-step method for stool processing. And in the pulmonary sample, sputum, induced sputum, gastric aspirate and gastric lavage, in the pulmonary sample, the smear positive sample we found is 29, expert MTB positive 47, expert ultra positive is 49, and expert ultra TAS is 6 samples in pulmonary samples. In the stool specimen, we found smear positive in 15, expert MTB positive is 47, expert ultra positive is 51, and expert trace, ultra trace is in 7 samples. So, in this study, the age range is 1 to 14 year, mean age is 8.5 year, and male-female ratio is 37:63, and patient convenience questionnaire is 90%. So, in this study, if we add the trace samples consider in positive, then in the smear sample the positive is 29% and 15% in stool samples. And expert MTB, the positive is 47, and also in the stool sample 47%. In expert ultra pulmonary sample is 55% positive, and stool sample is 58% positive. So positivity rate is least in stool smear than in expert MTB and expert ultra. So what about the drug resistance detection? We detect 12 patients of drug resistance in this study. Concordance is found in 8 presumptive PTB cases, that is MTB, bacilli and ref resistance detected in both samples in both tests, that is expert MTB and expert ultra detected in pulmonary and stool samples. In both samples ref resistance was found, while discordance is found among the 4 patients as shown below. If you see the serial number 1, MTB is detected in all the tests and all the samples except in the expert ultra. MTB is detected, but ref resistance was found, but ref resistance is not detected. In the patient number 2, if you see expert MTB in pulmonary sample, MTB was not detected, and in expert ultra pulmonary sample also MTB bacilli is not detected. In the serial number 3, if you see, then expert TB bacilli is not detected in the stool samples, and in patient number 4, in expert MTB pulmonary sample TB bacilli is not detected. So, but one thing I noticed that in expert ultra stool samples, TB bacilli is detected in all the 4 number of patient, and 2 patient was found rifampicin resistant and 2 patient was not found rifampicin drug resistant. So, measure of diagnostic accuracy of stool sample versus pulmonary samples. So, if the proportionality of positivity rate in smear sample is 0.15, in expert MTB 0.47, and expert ultra 0.51, sensitivity of stool sample in smear is 0.45, in expert MTB 0.85, and expert ultra 0.89, specificity is 0.97 in smear sample, 0.87 in expert MTB, and 0.80 in expert ultra. PPV value is in smear sample is 0.87, and expert MTB 0.85, and in expert ultra 0.84. Negative predictive value in smear sample is 0.81 sorry, and expert MTB is 0.87 and expert ultra 0.86, and accuracy proportion is 0.82% in smear sample, 0.86 in expert MTB sample, and 0.85 in expert ultra samples. And sensitivity sensitivity is 45% in smear sample, and specificity is 97%, accuracy is 82%. In expert MTB, sensitivity is 85%, specificity is 87%, and accuracy is 86%. And in expert ultra sample, sensitivity is 89, specificity is 80%, and accuracy is 85%. So in this overall the results I found that stool smear is least sensitive test. Stool is more sensitive with respect to pulmonary sample if we do in expert MTB and expert ultra. Accuracy rate is higher in all the 3 groups. So my conclusion of this study till now is positivity rate is lowest for stool smear specimen. Detection rate of expert MTB, expert ultra for stool specimen is as good as pulmonary specimen in expert MTB and expert ultra. Patient found stool a easy way for sample collection as compared to the gastric aspirate, gastric lavage and induced sputum. Caregiver acceptability is higher for stool specimen. In stool sample, 1-step method is a easy way for sample processing also, and the limitation of the study is culture reports are still pending for the further analysis and the reports. Thank you very much for nice hearing.
Thank you, Dr. Alok. So before we go to the next presentation, which is on point of care ultrasounds, I would open the house for any questions on the stool studies which were presented by Dr. Anurag and Dr. Alok. Any questions from the audience?
Good morning. I am Dr. Ken. I'm myself expatriate doctor working in Mori town in Manipur state for HIV/TB program. So thank you for all the presentation, and it's really interesting, especially in children. Very difficult for us to diagnose TB. So stool is really quite good sample for us in the real setting to implement. So my question is, when you take the stool sample, is there any specific time that we need to take for the stool, like early morning stool sample or any time, or before eating food in the morning? Well, how do you take the sample? What time do you take that sample in those studies? No?
Stool is we do not take any particular time. So whenever the child passes stool, we take the sample.
Thank you, ma'am. Preferably, we prefer early morning samples because we are doing this study in our indoor ward. We admitted the child, so early morning sample we preferably we take the early morning sample in our study especially.
So the WHO recommendation actually doesn't prefer any time of the day, you know, when the sample can be taken. There have been a couple of small studies which have shown an early morning stool sample vis-a-vis taken later during the day with equal performance. I think what is critical is the processing of the stool sample, which makes a difference. So the Global Lab Initiative has come up with a guidance document very recently. And what clearly comes out is that the simple one-step test is one of the best stool processing methods, can be done in the field situation easily. The other one, which Dr. Anurag has also done, you know, could be considered, but I think this will require a much more larger sample size before this can be endorsed. Any other questions?
The only thing extra we used was a centrifuge, and the rest of the things are easily available in all the labs.
Absolutely. Absolutely. Any other questions?
I would just like to comment. The best part of the study was,
Hello.
which I'm finding is the ease of sample collection. You know, it does not matter when the child, whenever the child is able to pass stool. And the other thing which I feel is probably the reason of higher positivity could be because the children, they continue to swallow sputum. I mean, they are unable to cough up, but they continue to swallow. So stool could be, you know, something like a concentrated sample. This is, the background with which I had planned this, and I'm really thankful to MSF for supporting us with the ultra cartridges. Thank you so much.
Hello.
Yes.
Yeah, good morning. I'm Dr. Ajay Verma. I'm microbiologist here at NIT. So my question is with Dr. Alok. We are working together and we are doing the gene expert also. So the two questions is, one question is we are taking the stool. Any guideline for how many sample we can take? And just now one colleague has asked the early morning sample. So early morning, how it affect? And whether the 2 or 3 sample, like in the parasitology we are taking, the 3 sample should be considered because it intermittently setting the parasites. So is there activity like in tuberculosis? And another question is whether tuberculosis and stool GI problem, it is related or it is independent?
Stool?
Stool with the tuberculosis. Like many other diseases, stool frequency increase or consistency, what? So have you any observation in this? Thank you.
Thank you, sir. Regarding the first question, there is a clear-cut guidelines of WHO. We adopt simple one-step processing that is developed by KNCB, and WHO had a separate guideline. In this stool studies, we had taken 0.1 gram lagvag thumb size stool sample for the solid samples, and we put into the sample reagent bottle, and after putting the sample reagent bottle, just take this bottle for 10 minutes, and by taking 2 ml of the sample size and directly put into the cartridge for the solid samples. And for the liquid samples, we take 2 ml of the sample size and we direct put into the sample reagent bottle, and from the sample reagent bottle we take the 2 ml sample to direct put into the cartridge. So these are the clear cut guidelines of WHO for the sample processing method, SOS, simple one-step process method. And regarding the second questions, preferably we take the morning sample, but as ma'am and sir suggest that as the child swallow the sputum and sputum goes into the GI tract, so you can take any other sample also, but in our study we preferably take the morning sample as the child is admitted in our ward, so the caregiver is also there, so we take the morning sample in our study. Thank you.
Sir, I have a question, 2 observations to make on Dr. Anurag's. Sir, first of all, children as per the has a very wide age scope. So TST is useful in 0 to 5 years age group. First of all, that's my point. Second thing is that, again, as you mentioned in your study, 0 to 5 years, or rather 0 to 7 something years, is the age group which should be the target for this. Because above that, the children can be taught to expectorate sputum. That's all my.
Okay, so we'll take one last question, in considering the time constraint. Dr. Puri.
Good morning. Our patients are basically classified as microbiologically confirmed and clinically diagnosed pulmonary tuberculosis. My question is to Dr. Anurag, that what happened to those patients where they were not given treatment for tuberculosis? Though they were symptomatic, that's why they were included in this study. So what was the follow-up of these patients? How long they were followed up and they have not developed tuberculosis?
I'm sorry, sir, I'll not be able to answer this question because we did not follow up the patients. We tried to, but it's very difficult to call them back, and so much of attrition, they don't pick up your call, they sometimes don't want to answer anything. So we were not able to follow up the patients whom were not started on ATT. We wanted to, but we were not able to.
Okay, thank you.
Okay, so thank you, Dr. Anurag and Dr. Alok. We'll move to our next session. And I would like to invite Mr. Praveen Kandaswamy, who's project leader PATH on point of care ultrasound test for diagnosis of TB in the pediatric age group. Over to you, Dr. Praveen.
Good morning, everyone. Thanks NITRD MSF for hosting this event, and thanks for inviting. So though I'm a microbiologist by profession, but I'm going to talk something different, which is the radiology tool, which is largely used for screening of diseases. So I will not get into the global strategies. Of course, we know everyone wants to eliminate the disease from their respective countries, but then I will quickly get into the point of care ultrasound device. So this is a very small handheld device. Many of you may have already used it in your clinical setup, but then this is very handy in terms of when it comes to screen the pediatric patients, where you always know the challenges being around collecting the right sample, and then though while the cartridges are being validated for various type of samples, but this is something which is very essential to screen whether they are infected or not, and especially when where you have limitations around accessing these CBNAT or any other cartridge-based system. So, and also this has been listed in WHO guidelines also, where radiology is one of the tools being used, but then X-rays, again, you know the challenges around exposing the children at that age, and that is not feasible in many of those places. And ultrasound is something which is very easy, where the trained radiologist can use it across the body and can detect not just the pulmonary, even the external pulmonary and various other organs which may have already got exposed to the tuberculosis. So live imaging, that is very much essential, because unlike any other devices where you get to see only the processed images where you only see, but here you can see the live exposure of the organs wherever it is infected. Faster enough, of course, safer, of course, no radiation. repeatable. So the benefit here is like you can repeat as many as you want it to be on a particular patient. When you even call them for a follow-up of treatment, where today we generally see X-rays being taken, but then this is something which you can even compare with your previous focus videos versus the recent videos, where you can even make a judgment whether the treatment is improving in where the organs are even getting rid of any sort of existing infection. So easy to disinfect, portability, of course, battery operated, cost effective, relatively low cost as compared to any other imaging technology. So this is just the landscape of what and all are the applications for the point of care, and right from anesthesia, cardiology, critical care medicine, all those things are there. And then you can also see that what are all the disease areas also which it covers. So benefits, of course, more important for the pediatric patients is like you see the vital anatomical structure. So generally when we see even if lymph node aspiration has to be taken, the clinicians or the surgeons who are there, though with their experience they can prick and take the samples, but then sometimes it may not hit the right space where the samples are there, and then these point of care ultrasound can really guide the right location from where these samples can be taken without causing much trouble to the pediatric patient. So provide real-time guidance, of course, as I said, improve accuracy. So again, if gastric lavage, again, if someone has to take from the pediatric patient, so the ultrasound image will definitely guide them the right place from where the gastric lavage can be taken. So that is again, which is very essential for this. Decrease complications as compared to blind procedures, as I clearly said. Identified local anesthesia, again, if you have to even give anesthesia to pediatric patients, if at all that is needed, that again is possible with this. Increased patient satisfaction, of course, unlike where you see doctors may prick once or twice, and that causes a lot of discomfort among the pediatric patients, and of course the parents also are paranoid about pricking the child, and then child is also very cranky at times, so it is really very challenging. So with these procedures it becomes easy for the clinicians or the radiologists or the surgeons who are all using this tool to pick the right sample from the body. So these are some interesting publications which are there internationally available. So one is from this study, ultrasound point of care sputum free tuberculosis. So building collaborative standardized imaging banks. So this study has already got a lot of data sets, the machine learning components. So now what they are also trying to do is these data sets will also be used in terms of an AI, where apart from using the POCUS, the AI algorithm like CURE, where in X-ray you have the radiology image being read by a software. So this also is going to benefit the radiologist, or in remote locations where there are no radiologists. So this is going to help the clinicians to even know whether this has got a TB or not. So second disease again is utility of point of care ultrasound in pediatric with pulmonary TB. And then the last one at the bottom is something which I think MSF is doing at international level, evaluation of point of care ultrasound in children from 6 months to 15 years with presumptive TB. So this is something from the international study. They have even designed an algorithm to screen the lungs in various aspects. So this is called some 8 scanning procedures, which the expert from the radiology department of course can do, but gradually the other cadre of healthcare worker, maybe the nurses or the medical officers, there are customized training modules available from the manufacturers which can be followed to expose these areas, and then those images can also be processed with the help of the machine learning and the AI. So this is again from one of the international publications where you can see all sort of different tests which are available globally, right from your LAMP, Expert, TrueNat, POCUS, and ideal point of care TB diseases. But then what you can also see, the second last at the bottom, you can see though it is indicated that that is child free, user friendliness will come over a period of time when the radiologists are trained, the medical officers and the nurses are trained. But then this is very essential where the remaining assays which are already there, where you already have the challenges around picking up the right sample, may it be sputum, may it be stool, may it be urine or any other thing, where for centrifugation or for running those devices you need the functional laboratory. So I think point of care is something which where the clinician sitting in an OPD also can roll it out and can screen the baby, whoever is presented with those clinical symptoms, and can be taken further for any examinations. So challenges, of course, we know in India, PCP-NDT regulation is something which is very critical and not letting these sort of tools to be deployed. And second important is acceptability by NTP, because conventionally people are inclined towards going for more and more microbiological confirmation. But then if the testing device has a limitation where you need to have a minimum number of bacteria to be picked, but then there are clinical diagnosis also which is being considered by the program. So having a radiology software, the POCUS is also something which will add up to the overall diagnosis of the pediatric cases. That is again very important. And way forward for deploying POCUS, again, a multicentric operation research is very critical, where this can be targeted to screen this pediatric population with PTB or EPTB is very critical. Developing AI algorithm, of course, there are key players already there in the market, and they are already developing a lot more algorithms. SOPs again, because of course we know radiologists are well trained, but then when we need to give it to the medical officer or a nurse in a remote location, so a particular SOP needs to be developed. Dissemination of this again through the Radiology and Imaging Association is very important to have their buy-in. And again, of course, the last one is very critical, is having an amendment for the use of POCUS, especially for these sort of cases, is very critical, because otherwise we see only sex determination as one of the aspects, but then on the other side it has a large number of benefits where you see screening and also of course prevent a lot more infections by putting them on treatment in its early stage. I think with that I will close. Thanks.
Thank you, Praveen. We'll go to our next speaker, Dr. Raman Mahajan, who's also going to speak on point-of-care ultrasound test, and then we'll open the house for questions on this.
Good morning, everyone. My name is Raman Mahajan. On behalf of our study team, I am going to present our study about point-of-care ultrasound for diagnosing tuberculosis in children. The study was done in Guinea-Bissau in West Africa. So I start with a bit of context first. Tuberculosis, as we all know, is an important cause of mortality and morbidity among children. In India alone, around 3.3 lakh children get TB every year, which is over 1/4 of global TB burden. Unfortunately, 50% of the children never get diagnosis, and microbiological confirmation is very low in children. In MSF context, where we usually work, the diagnosis is mainly on the clinical ground, because there is very limited access to X-ray and TB culture. But as we heard in previous presentation also, there is a point-of-care ultrasound technique, which is non-invasive, bedside, inexpensive imaging tool. So it becomes even more important in setting where the access of TB culture and radiologist is low. And the POCUS is very well researched and validated in adult HIV patients, but there is very limited evidence on use of POCUS in children. And as I mentioned earlier, the study was done in Guinea-Bissau, where we have high prevalence of malnutrition and HIV. So the aim of our study was to describe the performance and finding of TB-focused POCUS for children with presumptive TB at a tertiary care hospital in Bissau, the capital city of Guinea-Bissau. So this was an observational study. The data collection took place for over 10 months, starting from July 2019. We enrolled 139 children aged between 6 months to 15 years. And diagnosis was done mainly based on clinical and laboratory assessment, and all children were assessed with Gene Expert Ultra. And this was the first time that we used POCUS and experienced clinicians, and we trained them for POCUS methodology in a field setting. It is important to note that this was an unblinded study, so the clinicians were aware about the reference standard results. So we evaluated 8 sonographic signs. 6 were typical in FASH methodology, the POCUS methodology, that is pleural effusion, pericardial effusion, ascites, liver focal lesions, splenic focal lesions, the abdominal lymph nodes. And additionally, we also add subpleural nodules and lung consolidation in our study. So presence of any of these signs indicate POCUS positive result. All the images were reviewed by a second expert reviewer, and in case there was any disagreement between local clinician and expert reviewer, a third expert reviewer took the final decision. So this table shows the demographic and clinical characteristics of our cohort. There were total 139 children recruited in our study, of which 89 were TB positive, either confirmed or unconfirmed, and 50 were unlikely TB. Over 54% children were males, 40% were less than 5 years of age with a median age of 7 years. Important to note that roughly 42% children were also co-infected with HIV, and over 60% of children were also severely acute malnourished according to WHO child growth standards. Among the TB group, TB positive group, 62% had the pulmonary TB. So what did we found? As you can see in this table, that 93% children in TB positive group were positive with POCUS, compared to only 34% in TB negative group. So the most common sign were lung consolidation, subpleural nodules, pleural effusion, the focal splenic lesions. We also find that around a quarter of children in unlikely TB group also has lung consolidation. So among the confirmed TB cases, we found that 85% has positive POCUS results, whereas among the unlikely TB group, only 34% has POCUS positive result. That means there were false positive results. There were some false positive results in unlikely TB group also. We also did a pre-specified stratified analysis in our group using the factors like HIV status, nutrition status, and age group. What we found that in the HIV negative group has more lung consolidation than HIV positive group. In the nutrition, in the severely acute malnourished children, we found that there are more likelihood of getting subpleural nodules in children with severe acute malnutrition compared to children with normal nutritional status. So we also found that same children present with significantly higher risk of POCUS positive result compared to children with normal nutritional status. We also compare the agreement between local clinicians and expert reviewer, and the agreement was fair. So agreement was between moderate to good. So kappa score lies between 0.6 to 0.9, with the overall POCUS score was 0.8%, which is considered as good agreement. So our study also has some limitations. One of the limitations is a smaller sample size. Basically the study is a part of a bigger multicentric study. The data collection of that study is ongoing in South Sudan. Another important limitation of our study that clinician was unblinded for the reference standard results. That could have some bias in the study. But our study has many strengths. One of this is first study that included pulmonary assessment of classical FASH protocol. This is also the first study that correlate TB focus sign with malnutrition in children, and also we used the POCUS unexperienced clinicians. We trained them, and the study was done in typical field setting. So in conclusion, what we found that there is high prevalence of POCUS sign in children with TB compared to children who do not have TB. And POCUS positive result was unrelated to HIV. So HIV has not any association with finding high POCUS positive result, whereas the undernutrition status was associated with finding more POCUS positive children. The agreement between field clinicians and the expert reviewers was good. So we also recommend that a more context specific study with more robust methodology and a blinded study could be done to support our findings. So the study was done in West Africa, Guinea-Bissau, but our study has some implications for India. Like in rural setting where there is very limited access to radiologist, X-ray and TB culture, the focus could have some utility in diagnosis. So our take-home message will be that in setting like rural areas in India, where access to X-ray and microbiological confirmation is limited, and pediatric TB is diagnosed based only on clinical ground, the focus could have an added value for diagnosing of TB in children. But we also recommend further studies with robust methodology to validate our findings. At the end, I would like, thanks to our study participants, their families, our field team, MSF field teams in Guinea-Bissau and Ministry of Health, Guinea-Bissau, to support our study. Thank you very much.
Thank you, Dr. Raman. I'll open the house for questions from the audience. Dr. Sareen.
Well, firstly, I'd like to congratulate both the speakers. I mean, it's something which is new, and I would say that the only issue here is the value of ultrasound in pulmonary tuberculosis. That's the only issue. After all, as a device to give point-of-care ultrasound, I think it's reasonably good device, and there will be a correlation between a tertiary care setting and a point-of-care, village level even. So the study which you have done, I think that clearly looks at areas other than the lung parenchyma. Except for that consolidation, I don't know how consolidation was picked up in ultrasound, because whenever there is between the probe and the lesion, you will not be able to get a window to really get at it. So, but of course the fluids you can easily pick up, and that is what you have tried to show. Pericardial and ascitic and pleural and all that, and of course abdominal glands and all, which we also try to do it in adults also, whenever we suspect abdominal tuberculosis or any other serous membrane involvement. So I think as a point of care tool for this specific situation, yes, it would be very useful. But as most of the TB, or rather majority I would say, is pulmonary, in that context, we will still continue to rely on sputum microscopy as a tool, or maybe newer molecular tests in sputum testing as a tool. Thank you.
Yeah, hello.
Thank you, Dr. Sareen. Dr. Urvashi.
Morning, esteemed members here. What sir has made out, of course, needs to be, there's one catch that he asked, well, how can you make a window? That, of course, you are the expert. But I wanted to bring in here is that children present differently than adults. Especially, even if you're talking about pulmonary TB, why is the yield of the best molecular methods still below 50%? Expert ultra gives us a better yield, but that, of course, is another story. The point I'm trying to make here is children have more often parenchymal involvement or mediastinal lymph nodes, which may not always communicate with the airways. Hence the catch of low yield of microbiological tests. So the best of tests, which we can say ultra, reaches say 67%, 70% in some cases sensitivity with pulmonary samples, induced sputum, GA. Specificity drops with ultra, of course that is another story. So what I'm trying to say here is I am very happy to see your results and that you were able to carry it out in a rural setting. This probably will help us with the cases we are not able to catch microbiologically. We are complaining all the time, we're looking for lab, we're looking for other methods to improve microbiological diagnosis. Probably this along with microbiological diagnosis, if the specificity is high. You also talked about the unconfirmed TB. Of course, the CRS and the follow-up, response to treatment, etc. will give you additional data if those were actually TB or they were not TB. Regarding the HIV patients that you talked of, there was not enough consolidation. That's because of the poor immune response. Their cavitation consolidation is much less than the immune competent people. So I think it all falls in, with the science that we are all aware of. And it's a beautiful study. I hope you can carry it forward. Thank you.
Yeah,
Okay,
just one very small question to Dr. Mahajan. In your study, you have shown that in confirmed TB, it was about 88% focus picked up. In unconfirmed TB, it was picked up to the tune of little more than 90%. So my query is that if you have a confirmed microbiological TB, you should be able to pick up all of them. That should be more. So just a reason, could you say that there is something which has been picked up which is not specific, not in this thing, or how do we explain it?
So we found 85% focus positive in confirmed TB, which is quite good compared to other molecular tests. The reason of this missing 15%, there's no gold standard test which give 100% accuracy. We are expecting some gap there. Among the unlikely TB, it was 34%, if I am not wrong. So 34%. So we were false positive also in our case, mainly because there were also lung consolidation found in unlikely TB. Unconfirmed TB is 90%. So we combined them in one category, so TB positive, unconfirmed plus confirmed. So unconfirmed, I agree that is more positive, more sensitive than confirmed TB. Maybe it could be related to sample size. The unconfirmed TB, confirmed TB were only 27 cases versus unconfirmed TB, there were more cases. So if you see the confidence interval, it may align together. So maybe there's no big difference there.
Okay, so I have a couple of questions, Raman, for you, and then I'll pass on to Shibu. So one was, was this POCUS AI enabled? That's one. And second, did you also compare that what is the added value of POCUS vis-a-vis AI enabled chest X-rays? Did it add any additional value to it?
So I was not there during the planning of the study, but as much as I am aware, it was not AI enabled. So we trained on, the clinician was trained on FASH methodology, and the decision was taken at the end based on the signs and symptoms they found.
Okay. So what is the advantage of X-rays? Any comparison you did, because you did the study in a tertiary hospital. This was not a peripheral setting. So maybe you would have done a chest X-ray in all these patients as well. Was there a comparison of the additional value of POCUS on X-rays?
Sorry, sir, maybe I am not aware about that.
Thanks. Shibu, over to you.
Yes, I see, Dr. So, just wanted to mention that last year we discussed this as a futuristic technology, and then good to see that some data attached to it, which is very exciting in that sense. But again, I'm not sure whether we are positioning this in the right patient cascade system. Probably we need to, taking on to your questions, this is more of a screening and triaging tool than a confirmatory tool. We are trying to actually kind of looking this as a confirmatory, where probably we might be slightly off track. And there are different use cases, especially when we look at the pediatric cases, like maybe cervical lymph node has not been, I haven't seen that information coming out of the study, whether I don't know whether I missed it or not. So there are WHO checklists available in most of the remote locations and difficult countries. Actually, they use checklists, and MSF is also have their own checklist for probably do a head-on comparison with how it fares in with checklist versus this ultrasound findings. That will give us more confidence than probably ground rooting it with microbiological diagnosis, which is slightly, I would say that we are there is a mismatch in our expectations. Thank you.
Thanks, Shibu. Dr. Virender, you had a comment?
Thank you. Though I have joined physically now, but virtually I was hearing whatever was going on. Very exciting discussion, particularly on ultrasound. But as a clinician, this is not a new tool for us. We have been using that in emergency situations for several years. So the important point is that is the pneumonia like sign on ultrasound is equivalent to a sign of tuberculosis? It is not. Is the effusion equivalent to this being TB? It is not. We are struggling with a lot of patients who get TB diagnosis based on an ultrasound of the abdomen because they have recurrent abdominal pain. You more often stop their therapy rather than start their therapy. So one has to see it, while it looks exciting, any new game is a toy for the boys, if I put it a little sarcastically. But does it deliver what we need to have? We are the ultrasound, having used both the modalities, and I'm not talking of theoretical experience, the dependence on the observer is much higher in ultrasound than it is in X-ray. And the parameters are so much difficult. To get an ultrasound machine of a resolution which will be able to pick up those kind of lesions at the periphery is going to be far more difficult. So it's okay. As a pediatrician, I'm very excited a new tool is made available. But in the larger event, the way you are trying to position it, I have my serious concerns whether it can be positioned there. It would have a definite role to play in extrapulmonary TB. If it comes to abdominal lesions, we need it. Shivu mentioned something very interesting, on which we did a study last year, which is about deep-seated lymph nodes. So if you get echogenic foci within the deep-seated nodes and hit them, the possibility of getting a CB-NAT positive in those lymph nodes is much better. So if we are looking at, on one hand, we are talking of a molecular diagnosis, we're talking of dealing with resistance, knowing on the first side. On the other hand, we want to go back to shadows. So I see as kind of a schism as to, for the progress we have made in one direction, are we taking step backs? That's the concern I have.
Right. So last question, Dr. Puri, please.
Thank you. I see this tool as a different one, not for TB. It was my dream when I was a young resident looking for the ultrasound that I should have a handy ultrasound. So it is a complement to our clinical examination, which includes inspection, palpation, percussion, and auscultation. So by adding this to our clinical examination, we can at least say that this patient requires further investigation or not. Not only it can be used in the rural area, it can be used everywhere, even in a small clinic, in a private clinic where we do not have the ultrasound machine or X-ray chest. So it is a very good tool. This is my comment only. Thank you.
Thank you. I'll just make a short comment to what Dr. Virender said. I think the discussion was also, whether this is AI enabled, how good is its fidelity, what is the value addition over and above AI-enabled X-rays. I think each of these tools will have a place. And like you said, extrapulmonary TB is also not easy to diagnose. So maybe in the diagnostic algorithm, and since we have 20-25% of extrapulmonary TB also coming, not specifically for pediatric, but also for the adult age group, this tool may also have a place. The jury is still out. I wouldn't say the decision has been taken, but I think we need some more evidence before this can be rolled out. Thank you, speakers. I'll move to our next speaker, Dr. Shibu Vijayan, who's the Medical Director, Global Health for Cure AI, on use of AI-enabled X-rays in diagnosis of pediatric TB. Over to you, Shibu.
Thanks. Thanks, Dr. Sarabjit, for the introduction, and also thanks to MSF and MDR-TB. So I recently made the switch from a public health hat to an industry side, but I just want to put some disclaimer before I get into the presentation. This is a triage tool, this is not a diagnostic tool. What WHO approved for CAD, and where QRA is also mentioned in the guidance, is above 15 years, wherever there is no radiologist is available or radiological reporting system is available. So this is not going to replace anything, any specific specialized skill set. This is going to augment and optimize existing tools. So with that caveat, I also want to put a disclaimer upfront saying we don't have a solution which is time tested for pediatric age group, which is needy age group, which is not able to spit out sputum. At least we have now stool samples coming in. So there is some hope, but again, this is a clinical decision support system, not a diagnostic tool. I just want to put it up front. So, okay, so I represent an industry wherein we use image recognition assistance through artificial intelligence. And we are a small startup started in India in 2016. And now we are scaled up to 60 countries with 1,000+ deployments. Predominantly, our solution is pivoting on tuberculosis. So what we do is that the AI system is enabled to detect X-ray shadows, which have different conditions like pleural effusion, cardiomyopathy, consolidation, cavity, so as 40 different conditions are there enabled in our version 2. Taken some of the systems, some of the specific findings of tuberculosis, this also gives us a tuberculosis probability score. Again, it's not a tuberculosis diagnostic score. Now we have capabilities also detecting lung nodules with a malignant probable score, so that we can actually further explore. And similarly, we also have chest X-ray capabilities of detecting probable cardiac failure also, looking at the lines and then at the cardiac shadow. And any X-ray, so our capability is on any X-rays and on CT scans. Any X-ray, we have solutions like our AI can read fractures, so we have musculoskeletal solutions to detect fractures. We have CT scan solutions which can detect brain abnormalities, intracerebral bleed, and then accordingly escalate and triage that for clinical action. So in pediatric, we don't have a pediatric specific solution. What we have is validated 6 years and above, which is an adult solution, which there is no pediatric specific algorithm. So as you see that in the left side, in the right side of your screen, you see pediatric X-rays are very difficult, because sometimes if you throw this pediatric image to an AI system, they will say, oh, this looks like an alien, right? So first we need to customize this thing into a adult looking X-ray. So what we have, our system have, it actually kind of normalize and crop the chest part and put it as it to look similar to an adult thing. So that's the primary capability our tool has, and then zoom it to tell the machine this is an adult looks like X-ray. So that is how the adult algorithm, the algorithm which we have trained, is running on 6 years and above. So trained on a data set of 120,000 X-rays of age groups of 6 and 15, because these are either radiologist said yes, oh this is TB, or a pediatrician or clinician said yes, this is TB, or a final gene expert or TrueNAT test done on that, or microbiological diagnosis done on. So this process of lung fields at a significant higher resolution, because this actually also augment, the AI also augment to make the machine understand, okay, these are images, which is actually kind of looks like an adult thing, and detect, as I mentioned, atelectasis, bronchopneumonia, consolidation, fibrosis, and whole sort of like, mediastinal widening also. So when we compare, there is a minimal drop in performance when compared with adult X-ray. So adult is something which we have validated and also recommended with WHO is 15 years and above. This is not recommended by WHO. So so what our internal validation says, okay, there is not much significant difference between adult reading and pediatric reading above 6 years and above. So what we have a certification for 6 years and above is CE certification, ISO certification, and MD-SAP certification. And we have deployment across all these countries, because these are all general deployment what we currently have, and we enable the capability also to read 6 years and above with a fair amount of confidence. So there are some internal findings, because I don't have a lot of robust finding here, but again, just want to share that this is still a work in progress. We are also exploring new collaborations for research on this thing. So what we see, there is a fair amount of agreement. If you look at the preliminary finding of these things, you see a fair amount of agreement with the radiologist of where the machine said yes, this could be TB, the radiologist says X, and subsequently the ground truth also been validated with subsequent test also see a fair amount of agreement, which is not, again, from a standpoint of a triaging tool or a clinician decision support system, because in pediatric it's a composite indicator of what we feel, what we think, what the test comes out of. This would have some value, but not absolute value. The same thing, this is a multicentric study with this, again all the studies of low sample size. This is 16 years and less we have done in Bangladesh, collected data from Bangladesh, Pakistan and Vietnam. This is from our own deployment. This is 2 years and above we use. Again, the same as we seen earlier, this also shows a fair amount of agreement within this thing. But again, this needs to be structured. These are just observations. This is not a study done. These are observations from the deployment. So just take it as as with a pinch of salt. So next steps, we are pursuing studies with. So as I speak, so we had a discussion with the Sion Hospital last week, and then we are agreeing to do a prospective study on looking at specifically from 6 years and above. But again, so the Sion Hospital folks are interested in looking at lower age group also. So probably next year I will have some exciting information to come and share with you, at least from a triaging standpoint. But again, as I stand here, the machine have capabilities, but again, as we ponder into the pediatric complexities, like as we discussed about how do we get a correct X-ray from a pediatric age group patient, how do we actually adjust for, say, AI has capabilities for adjusting for movements, the respiratory issues, the exposure, and all these things can, to some extent, will get extended, but again, it's not absolute thing. But it fits into the list of corroborative evidences for pediatricians or a clinician to take decisions. That's where we stand. That's my speech. Thank you for that.
Thanks, Shivu. Questions from the audience?
No, it's not a diagnosis tool. That's I initially said. So this gives us probable TB score based upon the findings. And that's not so that is a triaging system. So the further evaluation is necessary.
It basically classifies the X-ray as a normal and abnormal. That would be it.
So there is a normal, abnormal, plus within the abnormal, a probable TB score.
Only for tuberculosis, or does it differentiate, okay, that this can be tuberculosis, this can be this. It gives you a list of
So
things.
there is a list of, I mean, as I said, there are 20 plus validated findings are there that will populate. So we also have a capability of, auto-reporting. So on the right side, it will actually translate the image finding into a text, and that reports. So the clinician can actually look at it and then kind of validate it. So the TB score is a composite score of consolidation, fibrosis, cavity, all these things will give a probable score of tuberculosis, which needs further validation.
You have taken the X-rays mainly from the symptomatic patient. These X-rays were processed,
which include both symptomatic and asymptomatic. So we have used almost 5.2 million X-rays for training the system, which have normal X-rays, which is abnormal X-rays, which have TB X-rays. 1.2 million were TB diagnosed X-rays. Among that, 120,000 was gene expert positive X-rays. So this is how, engineers can actually explain. So I have engineers from my team here. But again, this is how it is being trained.
So all the TB X-rays has been picked up?
Not all, sir. So that is where it is validated against each ground truth. So as a triage tool, this cross out WHO guidances for triaging tool. That's what got, and WHO validated independently. I'll just say, so FIND was also part of it, that validation. What they use that they have a panel of X-rays. They use so they have panel of X-rays which is blinded to the system. So they run the system, the software through that, and then check for the validity. So it is being published in the Lancet. So almost all the X-ray AI tools which has been validated shown 95% plus agreement with the ground truth of whatever reported in the X-ray panel of X-rays, and which has been published in Lancet. So that is one level of doing it, validation. So which is a neutral validation done, facilitated by WHO, done by FIND. And so that's how we got into the WHO guidance. And that is for 15 years and above, not for 15 years and less.
My question is very simple. If a chest symptomatic is coming to me, and if I order all the X-ray and ask for the AI report, what percentage you will expect that they will be positive for TB out of 100?
So we expect 95%, that's what we are seeing.
How much?
95%. So that is the validation that probably you can.
So Dr. Puri, I think we'll have to look at it from a different angle. If you have a confirmed TB case, for example, you're not doing a chest X-ray as of now. If you have a confirmed TB case, the AI system, if you would have actually done an AI-enabled chest X-ray, in 95% of the cases, it would have given you a reading of probable TB, which followed up by a gene expert or any other molecular test would have confirmed it.
That's fine. Thank you. So, do you have any study in which on chest symptomatics the X-ray was done? And what is the proportion of those X-rays were abnormal? Do you have any study or any literature available?
So we have literature, I can share that with you, but again, from a field level experience also, 30% of the X-rays.
Any published literature?
So we have published literature, so we'll share that. So I'm just saying, so we'll share with the larger audience also. So 30% of the presumptive TB cases, what we have screened, this is X-ray positive in any setting. So if you look at any, if you go take without AI also, which is similar in AI and in radiologist reading also, which is we are saying probable TB flagged by chest X-ray is roughly around 30% in Indian urban setting.
Okay, thank you.
Right? Which is true for us and as well as for radiologists.
Dr. Varinder. Dr. Varinder and then Dr. Vora.
Exciting area again, and more so for pediatrics, because when we are talking of decentralized diagnosis, we have to look at the. But one of the hindrances which we recently saw in the context of child health, when we created a mobile app, is non-availability of network in the places where it matters, where you want to decentralize it. So if your AI is going to sit on a server, how do you or is it something which can be easily is small enough to be put in a machine? How does it work? How does it interact with the existing digital machines?
Yeah, so we have a good question. So certainly internet and server storing in a server is going to actually kind of increase the scale and decrease the cost. So any other thing will come with the hardware, which actually adds to the cost. We have something called a Q box, which is a compressed computer, CPU into a small box, wherein the entire algorithm is already there and it reads. And it can get, when you get to the connectivity, when there is internet connectivity, it gets updated also. So that comes with a cost. Internet is actually not essential, but it will actually bring down the cost and increase the scale. But we have solutions now with the hardware also.
So how would you compare this product with possibility of teleradiology?
Yeah, so that is where this adds value. The turnaround time is something which we see the teleradiology turnaround time versus this turnaround time from a triage perspective, much more value. So you have a quick decision making from a point of care, like if we have a gene expert in the van we are going and doing, or in the periphery where you don't have doctors, this is an assistance tool to the clinicians. So that will actually decrease the time for diagnosis. No, yeah, that's fine, fair enough. But again, so if you have a sample collection system available, this will be much more easy. But for pediatric cases, certainly this needs an assistance by a clinician to further validate it.
So adding to Sir's question, so you simply put that software in a laptop, scan the X-ray, and the laptop will give you a differential diagnosis or whatever you are.
Correct.
So that is the way it is being done. Yeah. For COVID also, sir, this software was developed, put in a laptop, you scan the X-ray, and the AI will give you whatever results.
So it can be in the mobile also. So you can actually download it in your mobile. So that's another functionality which we have put. In analog X-rays also we can actually have the reading, because you take the analog X-ray against a light box, so you click the photograph into the mobile application which we develop, you get a report similar to what it behaves in a computer.
Right.
Okay.
Dr. Vora?
This is a very interesting topic. And since I am one of the PIs who's trying to develop the similar thing at the ICMR level. So it got me thinking about this, because you said your engineers are here. I just wanted to find out whether the X-rays which you had used for your training, were they standardized X-rays or it was all the X-rays? Because you see, when you do an X-ray, depending on the machine, depending upon the technique, depending upon the various factors, you get different types of X-rays. No two X-rays would have the same resolutions, because of exposure and other things. So did you use all the different types of X-rays, or did you use a single resolution type of X-rays for this?
Honestly, I don't know the answer, but Asani, if you could actually answer that, that will be
Sir,
good.
I'll just try to butt in. Because my son is into software and I've seen him developing an app for COVID, the same AI things. And one of my friend's son was doing it for MRIs on some tumors. So, see, ultimately there is a data set available of say around 50,000 or 1 lakh X-rays on the net. there are some data sets which are free of cost, some data sets are paid, and they have a report attached to it. So whoever has reported it, that report is considered to be final. And then the software is put in, and then that AI system, whatever they do, it changes its pickup. I don't know, they use a specific term. It was a long paper of 10 pages I could not read through because it went over my head. So ultimately they train the software, and then as per the training of the software on the previous x-rays, this software will give you results on the x-ray you want. So they used around 50,000 or 1 lakh x-rays to make a COVID software for AI on x-rays. Similar story is here. So ultimately you have to rely upon the radiologist who gave the interpretation initially.
So I agree with you. You see, I'm aware of it, how they do it. They basically turn the images into a PNG image, and that PNG image is picked up. But this PNG image is basically a pickup from the original image. Now the original image, depending upon the original image, the PNG image is brought up. Because you see some X-rays come up blue, some come up yellow, some other types. So they basically turn it into a grayscale. So that is it. But the original image is important, because if the original image is very sharp, you will get a very good PNG image. If the original image is not sharp, you will not get it. These are certain things which have to be taken into account. So I was just wondering, the X-rays which have been taken up are pre-processed or otherwise?
Yeah,
because you see, in the field condition, what happens? You cannot get an X-ray of your desired resolution. All right. So we are at the moment working on all the X-rays of different types, number one. Number two, I just wanted to find out whether this methodology of determining tuberculosis, the probabilities and other things, is it based upon any locational part of the X-ray disease? For example, if you get upper lobe fibrosis, you normally consider it as tuberculosis, that sort of thing. Or whether it was because of any difference in the opacification densities of that particular things.
It's a mix of that, all these things. So it's a probable score. It's not a confirmatory score. It's again, so it's not a confirmatory. That's what. Yeah. So that's what I started my presentation saying disclaimer. This actually enables triaging, faster triaging. So Sani, if we could answer about the standardization.
So, if there is somebody who was from the engineering, I could probably talk to them afterwards also.
So Shibu, what I'll suggest is, in time constraints, maybe you can speak with Dr. Vora. I'll take one last question, Dr. Neeta.
Yeah, sorry, I had to stand and draw your attention because I wasn't in your vision. This is not; these comments and questions are not from me. We are relaying this whole process on YouTube as well as on Echo. So we have almost 250 to 300 people who are watching us, and who are attending this. So I'm asking questions on their behalf. They have given a lot of good comments. They have appreciated the session, that they have got to learn a lot from your session. And there are some questions which came around 10:47, and I'm asking you now. So one of the question is from Dr. Naresh Chawla. He's asking, is tool CBNAT MTB being added in the algorithm anywhere in near future? That's one question. Then there's another question for Dr. Anurag. Was the study on expert or expert ultra? And
it was on expert.
Okay.
And on adding, well, the policymakers sitting here will have to decide. That is not our domain.
So, Dr. Neeta, we've had some rounds of discussion. Dr. Varinder is also here, who chairs the pediatric NTG, the erstwhile pediatric NTG. And there have been certain concerns around, use of expert GX4 cartridge vis-a-vis expert ultra cartridge. Because you must have seen in the study which was done at NITRD also, there were a lot of trace calls, and some of them were actually false positive, or they could not be confirmed as TB. So I think this discussion is on, but having said that, I think stool still needs to be a part of the diagnostic algorithm, and we are hopeful as part of the National Technical Expert Group that we will soon have a policy around it.
Thank you. And there are more questions which have already been answered, so I have not taken.
Okay, great. Thank you. So I will end the session considering the time constraint. My apologies for some of the audience, who wanted to have questions, but maybe, we could take them later. So just to summarize, I think the bottom line is that diagnosis of pediatric TB is still very challenging, both in terms of obtaining a sample and in terms of diagnostic tools, which have good sensitivity and specificity. We heard about stool samples. I think there have been N number of publications. WHO has also endorsed it. There is discussion within the National TB Elimination Program as well to adopt this technology. There are simple ways to process the stool sample. It's easy, and it's as, if not better, but non-inferior to gastric aspirate testing for diagnosis of TB. The second was POCUS, the point of care ultrasound test, where I think, like I said, you know, the jury is still out. This further requires more refinement before it can actually be deployed as part of any diagnostic algorithm. It will have a place, but I think it needs to be AI enabled and will have specific indications to be done. The third, of course, was AI-enabled X-rays, which has seen significant advancement. Now we have handheld X-rays available which do not require a mobile setup, can be taken into the rural areas. The X-rays can be done very easily. There is no problem of, you know, creating those lead shields or you know, radiation protective environment. And this actually has a lot of potential in diagnosing more TB cases. My only thing was, Shibu, that we still did not see anything about under 5 children in your study. You know, WHO recommends over 15, you are doing something between 5 and 16, but I think a major gap is there in the under 5 children, where we still do not have adequate or optimal tools for diagnosis. There are several other frontiers, you know, which are progressing. Biomarkers for one, there are several studies now, but I think these need more evidence before they can actually be evaluated. And there is also this app on cough sounds, you know, which is currently being tested on adults, but I think there is a lot of potential for children as well. So I will end this session with a thanks to all the speakers, and a special thanks to Dr. Diwan, Dr. Sangeeta Sharma, and the MSF colleagues for organizing this important session. I think all of you would have enjoyed it. Thank you.
It was a wonderful discussion. Thank you all the respected speakers for sharing your valuable insights with us. Sir, wait for a minute. So we have green welcome for respected speakers. So now I request Mrs. Komal Vasisht and Mrs. Rajni Nirala to come up on a stage to present green welcome to Dr. Sarabjit Chadda, sir. Green welcome to Dr. Anurag Agrawal, sir. Green welcome to Dr. Alok Yadav, sir. Green welcome to Mr. Praveen Kandasamy, sir. Green welcome to Dr. Raman Mahajan. And green welcome to Dr. Shibu Vijayan. Thank you so much. We are moving forward for our next session, which is focused on treatment aspects of tuberculosis. I would like to invite Dr. Vijay Vinayak, sir. He is Medical Technical Referent, MSF, for his talk on field experience in salvage regimen using new drugs. Welcome, sir.
Good afternoon, and thank you so much for the opportunity. Well, the morning part we were looking at the, heard about the diagnosis, so now we come over to the treatment part of it. So we at MSF, since 1999, MSF has been collaborating with the National TB and the HIV program Mumbai. MSF Clinic in India treats patients who have limited treatment options available under programmatic conditions. Since June 2016, MSF started the compassionate use of bedaquiline and delaminate for difficult to treat patients. We received pediatric formulations for delaminate and bedaquiline since April 2021. This is a notification in MSF that we see. You see the patients referred to MSF are from public providers, that is around 69 to 70%, private providers, contact tracing, and others. If you see the graph and you see that less than 5, that is highlighted in the blue, you see that the notification rate is very less. So that is why the first part of our event, which was on the diagnosis, that itself is again driving home the same point that we are not able to diagnose more. Very few cases less than 5 years. So the diagnosis of pediatric DR-TB is very less, negligible to say, because if we say that we are a high prevalence country and then the number of children diagnosed with DR-TB is less. So most of the time these children are underdiagnosed by treating them with DSTB, then waiting for the treatment to fail, and then at a certain point starting them on treatment when it is too late. So this graph just tells you that the less than 5, we are diagnosing very little people, and that's because there are difficulties, there are intricate difficulties in diagnosing in children also. So that is why the whole point of having new diagnostics tool, the stool gene expert, the point of care ultrasonography, just to diagnose more. So in children we don't want to miss any opportunity for missing diagnosis. So trying to make that best use of technologies available using the AI, but we need to diagnose more. On the left hand side we have this cohort. We have just tried to show what the scenario is. Less than 10 years you will see that it's mostly the pre-XDR, that is the FQ resistant cases that we had come across in MSF clinic. But you see the adolescents, you have them 76%, and you also have around 28% of adolescents having XDR. In children, we luckily did not have more disseminated, but in adolescents we have 8% disseminated. In terms of treatment, in children less than 10 years we had previously treated only 6, but in adolescents we have 91% of people who have already been treated with the program. And now with the bedaquiline being given from the program, we have in adolescent, we have at least 28% who had already consumed bedaquiline course and also delaminate. The package of care in our MSF clinic in Mumbai, we have this DR-TB diagnosis, and we do nasopharyngeal, nasogastric aspirate, lymph node, fine needle aspirations. We have to send it to a tertiary referral center to get the sample done. Then we have the age appropriate counseling tools and self-administered checklist, social assessment, reimbursing transport, link with national social schemes, nutritional support, daily ration, support group meetings for patient and giver. Now the treatment is the ambulatory treatment with family-centered approach by multidisciplinary team. By family-centered approach, what I meant was that we ensure that all the family members are screened for any active disease, and we ensure that they all are followed up regularly after every 6 months, just to make sure that we have only one index case and no other secondary index case. Training of family members for dose modification for drug compounding by pharmacists. So we basically want to treat patients not as an indoor, as on ambulatory basis. So we ensure that we identify one family member who would share the responsibility of taking the medicine, and we tell them how to dose modify, especially in children, because when the pediatric drug formulations were not able, we had to modify the drug as per the child's weight. So in special cases, directly observed treatment at home, initially for 3 months by community nurses and later by family member, because in certain families we did see that even the mothers were not really very understanding about how the treatment is to be modified or given, and so we had a nurse going there to their house for the first 3 months and teaching them how. Finally it became a routine for them, and then they were able to manage. Then we also give imipenem, the group C drug, where we have to give because there is no other option. So in these cases, the patient is put on a PICC line, so that is the peripherally inserted central line. So patient on PICC line are given infusions at patient's home by community nurses identified and trained by MSF. The idea is that MSF takes the onus of starting the treatment, so we ensure that we have a nurse who goes to the patient's house twice a day, morning and at night, and ensures that there is an infusion of the imipenem given at the patient's home. Palliative care support for adolescents failing treatment. Sadly, but surely we are having patients who are now, have taken bedaquiline, delaminate for 18 months, have been given imipenem for a period of 10 months or sometimes even more, and still have not been able to culture convert, that they are still they are positive, and we actually have no regimen, no new drug to offer to them. So these patients are sadly failures, and since there is no other treatment, we need to call them as palliative care. Palliative care for an infectious treatable disease is something that we really find it very difficult to come to terms with, but this is the reality on the ground, that there are patients who, in spite of being given best treatment for adequate amount of time with the best drugs available, still do land up having persistent culture positives, and we have to call them palliative. So this is the difference that we generally see when we talk about children less than 10 years and the adolescent age group. You see in the pediatric age group, you generally do not see much of parenchymal destruction. You generally have a Ghon's focus, you have the mediastinal lymphadenopathy. So more or less the lung parenchyma is saved. But in adolescent, you come to the adolescent, and this is the picture that you see, that there is a lot of parenchymal destruction, there is crowding of ribs, the whole mediastinum is shifted to one side, there are cavitative lesions. So what we are seeing is that the adolescent age presenting to the MSF clinic or even to the MDR-TB centers are mostly having a lot of lung destructions and very difficult parenchymal. The regimens in the outcomes, so in the less than 10, thankfully, but pediatric population less than 5, they generally tend to tolerate the most worst medicines also quite well. So in case of PAS, which is very difficult for the adult population to take, but you will find the pediatric children taking the PAS, and as if they have consumed a regular dose of medicine. So in less than 10 years, we generally had a outcome which was like 8, we had cured and complete out of 10 patients. We had unfavorable outcome, that is the 2 out of 10, and there are 6 to 8 patients still on treatment. So the tolerability of treatment, 63% presented with some side effects, but generally, as I told you, the children pediatric population generally seem to tolerate this MDR-TB medicines better than the adults do. So most adverse events were easy to manage. We had to stop cycloserine in 3 cases, linezolid was stopped in 2 cases, bedaquiline and delaminate were continued in all cases. In the adolescent, things really change. Favorable and outcome cured with 71%. Unfavorable outcome, we had 22 out of 75. 41 people are still under treatment. So far, no serious PICC line complications have been observed. Treatment fatigue is very frequent in this group. Adolescent pediatric group is very difficult because they are grown-up child. They want to go to colleges. They want to go and play football. They want to be with their peers. But it's difficult with the PICC line. They have a lot of stigma with it. With the clofazimine, their color being changed. So this causes a lot of treatment fatigue. These patients have, just for your knowledge, that these patients are not the patients who were diagnosed for the first time. These are the patients who have taken a treatment regimen of 18 months from the NTEP, and then they were still failing that regimen, and then they have come to MSF. So it is 2 years of treatment earlier, and then they again have to continue for another 18 months. So treatment fatigue is a very logical thing that can happen to anybody. 2 patients in this are still in the palliative care. The challenges that we generally face is that low case finding in pediatrics. So this low case finding is what we all are dealing with, and this low case finding is because the diagnostic, it's difficult. The paucity of the bacilli in the samples, difficult to get samples. Parents finding it very uncomfortable to subject their child to the nasogastric aspiration or the gastric lavage. And so that, like what the earlier morning we said, that routine stool expert is still not allowed in India. It was very very heartwarming to see that that there is already work being done on stool gene expert. There are a couple of institutes doing stool gene experts, and we are very thankful to Sangeeta ma'am for having this challenge have come. But the treat patients. There should be a close monitoring, management of adverse events, timely referral for patient failing current regimens, availability of pediatric drug formulations, especially of delaminate, availability of psychosocial health supportive services at public and private healthcare facilities. To conclude, in Mumbai we have an acceptable, we would call that, we would have wanted 100% outcomes, but an acceptable outcomes in this special difficult to treat pediatric cohort. This was possible due to access to newer drugs that allowed tailor-made regimens by a multidisciplinary team. Robust patient support is a key factor for good adherence to treatment. Thank you so much. Thank you so much.
Thank you, sir. Thank you for enlightening us with your valuable insights. I request Mrs. Rajni Nirala to come up on our stage to present green welcome to Dr. Vijay Vinayak, sir.
We now invite our on the stage our next esteemed speaker, Mrs. Leena Meghnane. She is the India head and the global IP advisor for Access campaign in the MSF. She'll be delivering a talk on access to newer drugs, the field challenges and solutions to it. Thank you, ma'am.
So thank you very much for having me. I'm not a doctor, so straight away disclaimer. What I'm looking at is to present some of the key issues that countries face in the procurement of TB drugs, and of course India is a very important player in the manufacturing of these medicines. So I'm just going to sort of give a more global overview of what's happening, and of course vis-a-vis that in India. And I think one of the key things that the availability of these new drugs in the NTEP has been shaped by the global architecture on the R&D of new drugs, but also in, say, for example, the registration of new drugs, the intellectual property on new drugs. So I think it's really very important to understand that for experts who advise the NTP, and thank you for this very important meeting. So I'm going to give you a medical treatment provider's perspective. MSF itself is a procurer of medicines, started with, after almost 40 years, we had 2 new drugs, so, there was a lot of hope for MDR-TB patients, and we started with, the first step that MSF took was to look at compassionate use laws across the country, across the globe. India was one of those countries. India does not have a compassionate use mechanism under the CDSCO. It's under process, and we use personal use importation as a way of building compassionate use programs for new drugs. So of course, regulatory intellectual property barriers are very key for all those who treat TB. So I'm just going to start with something that today is shaping the procurement of bedaquiline and delamanid in India. The procurement of bedaquiline and delamanid in India is shaped by actually patents. So where you have a patent, you have one producer, so you can't have a tender, you just have to negotiate the lowest price possible with the originator company. You have no competition, and you can be stuck with very high prices, and I'll go into that. Where you can overcome intellectual property, you have multiple suppliers, hopefully not too many, but just enough to sustain the market, competition, and of course lower prices. This is really very key, because today NTEP is struggling with high prices on delamanid, for example, and one of those reasons of high prices of delamanid is not linked to the raw material cost of delamanid. It's linked to the intellectual property, which is a patent monopoly that shapes the pricing of delamanid and the supply of delamanid. So if you look at it, India plays an incredibly important role. It's a major generic manufacturer and supplier of affordable medicines and vaccines, HIV, TB, viral hepatitis, and cancer to LMICs, and of course other essential medicines. And of course, Indian laws and policies play a significant role in facilitating generic competition. I remember, the members of the TRG who used to advise the HIV program would ask me always the patent status of HIV medicines. So they would go into the TRG and ask the government to do something about the patent monopoly, and that led to a number of steps taken by the Ministry of Health to make HIV medicines go into generic competition in partnership with stakeholders. And of course, you have to look at how you can prevent extended monopolies, on new drugs. So just to reiterate the point, where you have competition, you can have prices cascading down, and this is the HIV antiretroviral treatments, the backbone of HIV treatment, from $10,439 in June 2000 to June 10, 2010, it's $67 per patient per year. So you can just see the impact of competition on the pricing of medicines and the availability of medicines. And this is something that drives what is available to a treatment provider in the public or the private sector, particularly in the public sector, where majority of poor people or marginalized communities come for treatment, because they do not have the ability to pay for these drugs in the private sector. So this is a very important factor. Competition is a very important factor that actually enables public programs to procure the medicines at an affordable price. We saw incredible revolutions on HIV medicines. We've seen an incredible revolution on hepatitis C. And we're actually starting to see some impact on, even cancer. The generic competition is changing the way cancer medicines are starting to become available. So just to start that conversation about TB and how we can build a better resilient supply system. So India is a member of the World Trade Organization. It had to change its law. There was no differentiation between medicines and other goods. And of course, India had to then start granting patents. Some of the first patents granted were on new TB drugs, bedaquiline and delamanid. So the good news is the patent on bedaquiline is expiring in 2023. The patent on delamanid is expiring in 2023. I think these are incredibly important landmarks in terms of what we're going to get in the pipeline of generics down the road in 2023. And of course, Petomanid is already being non-exclusively licensed to a number of manufacturers, and they have already started to file for quality assurance. So what you are seeing is, in response to the patent expiry, you are seeing generic companies starting to file for quality assurance at the WHO pre-qualification system, but also what we call the ERP, which is just to expedited system of quality assurance while WHO PQ processes are completed. So you're going to see a speeded up process of quality assurance leading up to patent expiry. And I think this is good news. What we must encourage Indian generic manufacturers to do is also make the pediatric formulation. So I would sit McLeod's, Lupin, and a couple of other key manufacturers down from the government of India and ask them, along with the adult, are you developing the pediatric? And of course, for pediatrics, you don't need lots of manufacturers. You need one or two key manufacturers taking it up. And I think this is very important that, that discussion happen with manufacturers, TB manufacturers in India. So what is civil society doing? Civil society is challenging the extension of patents on bedaquiline. At this point of time, J&J is asking for an extended monopoly till 2027. You have Nandita Venkateshan. She's challenged the patent on the fumarate salt of bedaquiline. And of course, the hearings are ongoing in the patent office. MSF has provided technical support for these patent oppositions, and we are awaiting the decision from the patent office, hopefully a rejection that will lead to, lead to generic competition in July 2023. Now, delamanid is where the prices are. Really, that's what's sort of biting everybody in terms of pricing. And then, of course, supply. The more expensive a medicine is, the more likely it is to be rationed. So it's a major cost driver. So if you look at delamanid 50 mg, more than 70% of the overall regimen costs in long regimens for FQ-resistant TB required combining bedaquiline delamanid for 18 to 20 months. And 70% of that goes to delamanid. Again, delamanid 25 mg, 65 to 80% of the overall cost of combined bedaquiline delamanid regimens for children of 10 kg and 20 kg. So this is what is driving costs for everybody, not just NTEP, but also for MSF and other treatment providers. What we see is in October 2022, as compared to bedaquiline, which was, a drug that was launched around the same time as delamanid, 600,000 treatments of bedaquiline have been taken up in 10 years, and only 100,000 treatments for delamanid in that around that 8-year period. Generic version under development in India, delamanid 50 mg, interest to develop the pediatric formulation, delamanid 25 mg. All the generic manufacturers asked us for the reference product. They need the originator product to do bioequivalence testing. And they can't get the originator product for bioequivalence testing from the originator. So this is a major stumbling block for running bioequivalence test on the pediatric. Now, these are the kind of problems that we are facing in getting the generics to, into the supply chains. And today, the originator product is either with NTEP or GDF. These are the two entities that actually have the originator product and could provide it to alternative manufacturers to run bioequivalence testing, and that is perfectly legal under Indian law. So that's something to consider, that NTP might consider that this is a stumbling block for pediatrics. Why am I saying that it is the driving force behind prices? If you look at the cost-based generic pricing, this is basically looking at the cost of raw materials. It's assessed that Delaminate is one of the cheapest drugs to produce. It could be between $5 to $16 only. This is Andrew Hill and his team at the University of Liverpool that have been estimated all the essential medicines in the WHO list and came up with the estimated cost-based generic pricing. And look at the pricing that we are currently paying. If you buy from GDF, it's $283 per 6 months treatment. Otherwise, both South Africa and Indian Central TB Division pay about $207 per 6 month regimen. So you can see that the prices are much higher than what could be under generic prices. So I'm going to quickly wind up in the last two slides. Yes, today Delaminate is used in long oral MDR-TB regimens in adults and children with FQ resistance, mostly as salvage regimen. Dr. Vijay said, a last option. But there are future opportunities with this drug, as they are with Pretominid. You have, you could combine it with bedaquiline Delaminate in short regimens. This is, looking at what is in the pipeline. You could see more data come out from the NTB trials by Q3 2023 and also due by 2025 for those with fluoroquinolone resistance. And of course, it's a very important drug for preventive therapy for people exposed to DR-TB. So all of this is in the pipeline. Studies are undergoing, and we'll be looking at, Delaminate as an important drug and not to be discarded as not something important. And so it represents an important class of medicines that we really need. So what are the recommendations from us? Please provide the new TB drugs as part of regimen short, longer, MDR, PXDR, under NTP to both adults, adolescents, and children. Generic competition is key to reducing costs and securing supply chain. And the TB program should provide the reference product for bioequivalence studies. This is a very important stumbling block for a majority of countries who are waiting for Indian generics to start supply of new TB drugs. And NTP-EP could play a very important role by providing the reference product for generic manufacturer. Global pool procurement. When a country buys a small quantity of pediatric medicines, a company will not run an entire batch for that country. If you do global pool procurement, if all countries come together to do pool procurement for pediatric formulations, then you have a higher chance of sustainable supply of pediatrics. So I would just like to underline that in pediatrics, the market has often been unsustainable. And it's really very important that we are part of the global pool procurement to ensure sustainability of pediatric formulations. And of course, India and South Africa should be consolidating the market with GDF. So this is a very important issue. Private market sales of new TB drugs are not allowed. Fair enough. This is very important. Private market sales of TB drugs has driven drug resistance, and therefore you need regulation. And therefore, the efforts that have been done by the NTEP to bring in practitioners who've been treating TB in the private sector, who've been willing to follow the diagnostic algorithm, should be strengthened. So this is very important issues on access that represent access to the new TB drugs. There's a publication that MSF put together on the prices, availability, sources of new TB drugs. It's just been published in October 2022. It's called DR-TB Drugs Under the Microscope, and please feel free to reach out to us for a copy. Thank you so much.
Thank you so much, ma'am. I now request Mrs. Komal Vashish to kindly present green welcome to Mrs. Leena. We thank both Dr. Vijay and Mrs. Leena for this informative session. Next in line is the inauguration ceremony, and we would like to call on stage our esteemed dignitaries.
Just few questions, 2 or 3. Yeah.
Okay.
Okay.
So any questions to?
Yeah. So this is a question from our chat box. You know, we have about 300 people who have logged in on YouTube and this thing. So one of the questions is that since the patent is expiring in July 23, what is the preparedness for the generic drugs in the market, like for CTD and other players?
Yeah, I think this is a very important question that's come from the audience who's been watching online. I just would like to highlight the raw materials are ready, you know. Companies have been wanting to run bioequivalence testing for the adult version of bedaquiline and delamanid. One of the biggest challenge was, which is to get the originator product to run bioequivalence testing. This is something that perhaps NTEP can really help with. Preparedness means that you have the quality assured medicine in the supply chain on the day of the patent expiry, which is July and October 2023. How do you do that without meeting the requirements of CDSCO and WHO, which requires you to do stability and bioequivalence testing? So I think for bedaquiline, originator product has been obtained and bioequivalence testing is underway. What we really need is for delamanid, both for adult and pediatric, that both WHO and NTEP come together to provide the originator product. I think by the end of 2023, we should see the generic entering the supply chain both in GDF and NTEP. So one of the first things that we could also recommend is that the tender documents be prepared, so that the market is opened up, so that India gets better pricing for delamanid from other generic manufacturers. So that's where I'm going to stop. Thanks.
There's another question. What about, sorry. Yeah. It's about the speaker before you spoke about imipinam and PAS. Both are not available with the NTP and in the market. So what is the next step? How are patients going to get these?
Yeah, so that's what actually we are fighting for, the group C drug, since after delamanid, using bedaquiline and delamanid, in case you still do not have drugs, then the group C drug imipenem comes into play, because of all the group C drugs, though being injectable, compared to the aminoglycoside, it does not have the serious autotoxicity ADR. So in case you have to use an injectable out of sheer desperation, so it is salvage, it is desperation to use an injectable for when we have decided we are going to treat by all oral. But then if we have to use an injectable from the group C drug, it might as well be imipenem, which acts on the active and the dormant bacilli both, and does not have a serious ADR of giving autotoxicity or hearing abnormality as a serious handicap. So we've been trying for the group C drug, but so far, because the problem is the logistic thing of it giving twice a day. It's a BD formulation that we have to give in the morning and at night. So that is where we have to, try to get this drug imipenem.
So just to say that when a patient requires a very expensive drug like imipenem, the NTP of course has not been procuring imipenem. It's not cost effective for NTEP to provide it to everyone who needs it. But I think there are valuable programs like the critical illness funds and others that need to be linked to NTEP for patients who do need it as part of their salvage regimen or as part of the treatment regimen. That something needs to be done about also including imipenem as part of NTEP. And I think till we have newer TB drugs that comprise a completely new regimen that allow us to treat everybody successfully, we have to agree and acknowledge that there are patients who need imipenem and that they should not be left out of the public system and left, to procure the drug. Someone today was telling me a patient's family paid 18 lakhs to procure imipenem, a penem. So I think this is very important dialogue that, patients' voices about how much they have to spend on imipenem be taken to the government. And this issue of imipenem, even though it's a small cohort, constitutes those who are most at risk of dying. So I think that issue has to be raised and acknowledged in meetings of the NTEP, and maybe programs such as the critical illness funds and others can be tapped for this. Yeah.
So, thank you, Leena, for always bringing up pediatric cause. I have often been waging a lone battle, but I hear a friend here. Thank you so much. I was wondering, one of the hesitancy which is always there, whether it is with the CDSCO or with the program, is lack of data. And lack of data, it's a chicken and egg situation. You don't allow a drug for pediatric use, then you need data on pediatrics. How do you get it? So, because MSF works across borders and say without borders, so there are uses which are happening off-label or on compassionate grounds, which do give us enough information about safety of these products. So why not collate that, so that by the time while we try and convince, and Dr. Matu is here and he's always open to suggestions on how a global procurement will be one way around to get a pediatric formulation together. But CDSO, because it's a regulatory body, would have its own challenges and its own mandate to look at. So why don't we, in the meantime, or if you have not already run it, collate that data on safety, collate the data on efficacy, which can help us fast track many of these new drugs?
So I'm going to leave Vijay to answer that question, but I just want to say that all the data that MSF generates, it shares with the WHO on a regular basis. I don't see any reason for us not to share it with the NTEP or CDSCO. And number two is this, that based on the data that came in from all the treatment providers and the different clinical trials, the WHO recommended that Delaminid be provided from 0 to, and that data has come from treatment providers like us, but also South Africa and many other places where clinical trials and studies have been done. So I think we are today in one of the most comfortable situations to use these new TB drugs. Perhaps we have more data than the older antibiotics, which were not meant and were used off-label or repurposed for MDR-TB, and perhaps we need to look at that comparison as well when we are looking at providing injectables to kids instead of Delaminid. And I'm going to allow Dr. Vijay to answer this question.
I think Leena said it, because our guidelines have actually from not giving Delaminid earlier now is agreed that that once you have a pre-FQ resistance, the first drug to be added is Delaminid. So now there is no doubt that we can use Delaminid, and it has so far been proved to be very safe in pediatric populations. There's no ADS, serious ADS.
Oh, yes, absolutely. So just coming on the issue of Pretominid, which is a very important option as well, and we should not discard it in our discussions. I wish TB Alliance had been here as well. And I just wanted to simply say that normally what is happening in R&D is that pediatric trials are often delayed or much after the adult trials, and that is the gap that we are trying to bridge on almost all drugs. And unfortunately, I wish we had more data on Pretominid, and I hope the developers are prioritizing that. Yeah.
Just to coming back to imipenem, because I used for the first time in this institute way back in 2008, 2009. And when I wrote to some patient from Shillong rather, one of my colleague commented, because it was a costly drug and there was no reports available except one report published in 1995 on 10 patients. He commented that, do you have some tie-up with the company? Because it was something new for them. Thereafter, I gave so many patients, almost 30 patients, I got good results. And again, we are using this mention this word imipenem, but unfortunately in national program, it has never been procured. Though there are patients who require them, even I use today this imipenem or carbapenem. In fact, it would have been oral. I was looking for this tebipenem, which was supposed to be a good drug, oral carbapenems. What do you think, what should be the duration of this imipenem for such patients?
Sir, actually, to begin with, we basically all would like to treat our patients with a completely all oral regimen. So no matter how good an injectable drug would be, we would generally not go for an injectable drug as the first line treatment for our patients, because all oral is all oral. We don't want an injectable. We resort to injectable only as the last place, because you should have an ADR developing to a bactericidal drug like linezolid very early during the treatment. You have an FQ resistance, or now we are getting bedaquiline resistance also. So you would have to resort to a good bactericidal drug, and the only drug that qualifies to be a good bactericidal drug then remains imipenem. So imipenem would come into play, but then at the same time having a PICC line or any injectable device to be to inject imipenem, the max that you can go it for like 10 months, 9 months, 10 months. Beyond that, since it acts on the actively multiplying and the dormant bacilli, you have decreased the residual bacillary population, the burden of the bacilli to significant levels. But you also need to have equally good acting oral drugs with it. So you can't really rely on an injectable drug for the entire duration of treatment. So
Actually, I used only for 6 months, 4 to 6 months. When the 2 culture reports came negative, I stopped it. And I got ultimately that is why I said, can we reduce further in the convenience? I never used this PICC line. And I gave this, so it was a bit difficult,
yeah,
but can be given.
Yeah, but since a lot of water has flown under the bridge since you use it and now, because now we are getting bedaquiline used patients exposed to bedaquiline. So we are basically, so we tend to use it, like you said, like wait for 2 cultures to come negative, but invariably there is a lot of so much of lung destruction, and the cultures sometimes they are not able to give, so you have to wait for at least 9 months. So that's what we have seen, that generally need 9 months.
Now, because bedaquiline is also failing, as you said.
Absolutely.
In such cases, we require some background, some good injectables.
Yeah,
So in that case, we have to work up.
I'm so
Right.
sorry to cut you short, but I think
Okay.
I'm going to tell the organizer that put imipenem on the agenda for the next TB day, because it's really very important, I think. So Dr. Chadha had one last question, and then we wind up the session.
Thank you, Leena. Excellent presentation, and I must commend MSF's role in bringing down the cost of antiretrovirals. So you actually gave a very nice landscape and scenario where we expect to see a drastic reduction in the cost of the new drugs. So my question is, when is that going to happen? When can we see a $6 to $12 cost for a course of Delamanid or bedaquiline 1? To pediatric formulations, and we have experts like Dr. Virender in the group, are still not available for majority of the drug-resistant TB drugs. So what is MSF doing about it?
The second part I didn't get. Sir, come again.
So the pediatric formulations are still not available. I think maybe because it is not economies of scale, right?
Exactly.
So what is MSF doing about it, and what is it that as part of the NTP or government and other stakeholders, community, can be done to push this?
Yeah, so I think what we are seeing is a gearing up of the supply chain by generics themselves, who are producing the raw materials, and they're starting to do the quality assurance, and where they are hitting a stumbling block is getting the originator product for the pediatrics. So that's one roadblock for the pediatrics. Number 2, I wanted to simply say that coming back to the issue of lowering prices, it has to be not just tendering at the national level, but we need to consolidate procurement under GDF. So we can all benefit from bigger volumes coming together. And lastly, I would like to say with pediatrics is that civil society pushed for the registration of the pediatric formulation, which had been sort of being neglected by Otsuka and Viatris. And what we've seen is a breakthrough, that they have filed the registration dossier and it has been registered. So I think now it's up to NTEP how widely they widen the diagnostics, which we talked about the stool gene expert, and most importantly the XDR cartridges. And we need a faster algorithm for diagnostics. We've got an XDR, 159 XDR machines lying across the country. We need the microchips to go into them so we can give it to patients a faster diagnostic. So that's where we are. And I'm going to stop here, and thank you for the session.
Thank you, respected speakers. It was a wonderful talk. And next in line, we have inauguration ceremony.
We would like to call on stage our esteemed guests for today.
there is a slight change in the program because our chief guest has arrived. So we'll be stopping for the inauguration, just a quick inauguration. And I was just overhearing all the discussion which was happening. I mean, the Arpita Aryan story, those two kids. Aryan was the one who landed from, as you have heard in the morning. इसको बच्चे आगे कर लो ना, just ताकि आपका time. So he had total drug resistance. So that time bedaquiline, delamanid, they were not available for children. So I had no other option but to start with imipenem based regimen. We gave him meropenem, and obviously the child is responded, he is cured, and now he spoke in front of us, and that's almost like 4 years. But the thing is, obviously, the father just told me that he is under a debt of 18 lakhs because he had to buy majority of the drugs like PAS, as Dr. Neeta has highlighted. So we seriously need to look at issues of procurement and availability of these drugs under the program. So now I'll pass it on to the Dr. Kanishk.
So we are starting with inauguration ceremony. First, I would like to invite our chief guest, Dr. Randeep Guleria sir, former director, AIMS, New Delhi. Next, I would request our guest of honor, Dr. Ashok Shah, to kindly grace the stage with your presence. I request our esteemed director, Dr. R.K. Diwan, sir, to kindly join us.
I wasn't expected to be here.
I would like to invite Dr. Farhat Mantu, General Director, MSF, India. I would like to invite Dr. Sangeeta Sharma, Head of the Department of Pediatrics, NIT-RD, New Delhi. Now I request Mrs. Komal Vasist to come upon a stage to present green welcome to our chief guest, Dr. Randeep Guleria sir. To present green welcome to Dr. Ashok Shah. Present green welcome to our esteemed director, Dr. Ravind Kumar Diwan sir. Green welcome to Dr. Farhat Mantu, ma'am. And green welcome to Dr. Sangeeta Sharma.
I now request all the esteemed dignitaries on the stage to kindly proceed for lamp lighting ceremony, sir. We now request our esteemed director, Dr. Ravindra Kumar Diwan sir, to kindly come to the dais and give welcome address. Thank you, sir.
Good afternoon, everybody. And it's my pleasant duty to welcome all of you in a formal manner, though we are having deliberations since morning on the stage. I extend my sincere welcome as well as gratitude to Professor Dr. Randeep Guleria, the former director, All India Institute of Medical Sciences in New Delhi. All of us know that how he has been a leader in the entire country in our fight against COVID. And he became a celebrity in those periods, and not only celebrity, a sense of hope and courage for a society which was probably beset with the biggest challenge and danger that we had encountered after independence. Thank you so much, sir, for gracing this occasion. It brings a joy to all of us that you are here amongst us, because we know we are discussing issues regarding tuberculosis, and with MSF, who have kindly consented to organize this event with us. And tuberculosis is also an area in which you have done groundbreaking work, and you are one of the persons, a leading light of pulmonology and all the chest diseases. Thank you so much, sir. I have extreme pleasure in inviting Professor Ashok Shah as our guest of honor. He has been a teacher to almost all of us in the field of pulmonology. Anybody who is doing anything related to chest, whether it's diagnosis, management, epidemiology, investigation, and future techniques, etc. I think most of us started learning with the Professor Ashok Shah how to think about treating or even thinking about chest diseases. Thank you so much, Professor Shah. I have extreme pleasure in inviting Dr. Farhat Mantu. I have been knowing Farhat for the last 15 years. She has been the Human Resource Manager, then Director, and now Global Director of Medicine Sans Frontier, an organization which is absolutely unique in its nature. Though as of now, in 2022, as a Director of National Institute of TB and Respiratory Disease, I can count that there are major stakeholders who are working in our fight against tuberculosis, which includes the Union, the Central TB Division, represented by Dr. Mottu here, and then you see the FIND. But Medicine Sans Frontier is unique because it works on a special principles of equality of human beings, that every human being, irrespective of ability to pay, should get the best possible treatment. And that does not only include diseases like tuberculosis or diseases which poor people suffer. Any disease, even in times of conflict they reach. And because I can call myself an NITRDian as well as an MSFer in some way, because I have done some missions, I am deeply impressed by the kind of professional the disease is raging, and they have their missions addressing these problems as and when the national programs are not sufficiently strong to deal with tuberculosis. Thank you so much for your presence, Farhat. Your presence itself adds a luster to here. Thank you so much. And then I thank all those people who have taken time out to gather here, Professor Sangeeta Yadav, Professor Anurag Agarwal, Professor Varinder Singh, a leading light in pediatric tuberculosis, Professor and Dr. Rupak Singla, Dr. Sarbajit Singh, and Leena. They are there, as well as everybody else who is there. All of you are important in their fight against tuberculosis. And Vijay, who brought his experience from Mumbai, it is so unique. And not only the experience, its ability to address and challenge every issue which is related to tuberculosis and which is not confined in the bureaucratic jargon of whatever are the guidelines, and still able to find courageous solutions to those things. Thank you so much for all of you being present here. I hope the deliberations make us think in a new manner, as well as bring kind of a new clarity in various areas which we are looking forward. And this year the theme is pediatrics, especially pediatrics, but it does not mean that we are stopping at pediatrics, because last year our theme was different in areas of tuberculosis. Whichever is the theme, we will address all of those themes, and let our collaboration between the MSF and ITRD broaden and strengthen further. Thank you so much, sir. Thank you, everybody.
Thank you so much, sir, for your kind words and allowing a platform for such discussions with all the faculties who are an expert in their fields, and for us to learn from their experiences, sir. I now request our MSF Director, Dr. Farhat Mantu, to come on the dais and share her thoughts with us, please.
Good afternoon, everybody. Dr. Diwan, my esteemed colleagues here, both from MSF and from different stakeholders who are passionate about TB. A very warm welcome. We have had some conversations since morning already about it. But I'm going to refer to a question that was asked to Lena. What is MSF doing about pediatric TB? In addition to what Lena alluded to, there is one thing we want to do, is actually to make sure that we talk about the hope around addressing pediatric TB. I understand every day in our clinics around the world, we see kids, small children, adolescents coming to our clinics. The good part is they respond to the treatment much better than adults. But at the same time, they are the ones sometimes who are completely untraceable, not detected. So a group under 5 in India, around the world, is still a group that is voiceless, and through this platform, we want to bring voice and attention to that. Now, why? I'm not going to talk about any statistics today here because it is like preaching the preached. All of you must have been contributors to different reports we see at national and international level. We as MSF want to make sure that when we look at TB, we look at it holistically. We do not only look at the diagnostic part of it. We do not only look at the treatment part of it. We look at social rehabilitation. We look at patient care. We look at person-centered care. We look at access and affordability. This is something that is going to affect us, and it is not just a disease of poor. It is something that affects everybody across the lines. And we believe, as MSF, by bringing in different stakeholders together, we want to keep the dialogue going. We want to put attention, especially for the policymakers, on the areas that need attention. There is so much to do in the area of TB, and the choice of talking about pediatric TB this year was based on the experiences. I'm sure in this room, you may be a parent, you may have a small brother or a sister, you may be an aunt or uncle. Let us not look at statistics as number. Let us look at human beings behind them. And you heard 2 very inspiring stories in the morning from 2 of our patient activists. Thank you for sharing your story, because I know the amount of stigma that is there in the society around it. We have come a long way, but we have a long way to go. When we talk about the society in India, we talk about still, if you are a girl, you would not talk about TB because it would make your chances for marriage questionable. If we talk about TB treatment, the changes it brings to your color. We are a society that all these things are really that are detrimental for us to seek help, seek treatment. So what we want to do is we want to normalize conversations around TB, and we cannot do it alone as MSF, and we are extremely thankful to MDR-TB to giving us the space and platform to bring everybody together, and actually the policymakers listen, hear what are the experiences from the field, and try to see how we can get them in the national protocol, how do we get them integrated so that we empower our frontline clinicians, how do we empower our patients to know their rights. So through this platform, we would really like that this dialogue continues. This year we talk about pediatrics, but maybe next year we talk about something more. But every year we should talk about progress, and I think that's what we want. A very big thank you, especially Dr. Sangeeta, because you and your team has been pivotal in making and curating the content for the day. I know it's a Monday, so it must be very difficult for you to spare your time, especially Dr. Devan. I know that as a director of the institute, to prioritize your complete full day here is a big thing to ask, and equally to all the people in the room and our online audience. So please keep the dialogue going. What we need is like our small steps towards the elimination of TB. The first step to start is to talk about access and affordability. And that is where we want to put our attention. Thank you very much.
Thank you so much, ma'am. I now request our guest of honor, Professor Ashok Shah, Professor of Pulmonology at VP Chest Institute, New Delhi, to share his thoughts with us.
Professor Randeep Guleria. Professor Ravindra Diwan, Dr. Bharat, and Dr. Sangeeta Sharma. Many dear friends and colleagues are all over here. Welcome to them also. It's nearly, I think it's about 140 years now, more than 140 years since Robert Koch discovered the tubercle bacilli. And we're still struggling with it. It's a very smart bug. First of all, it combined with the ancient scourge that we have, diabetes, and created havoc over there. Then came along the Second World War, and we had the epidemic of smoking, and tuberculosis combined with smoking. Then came along the new kid on the block, that is AIDS. It went and made friends with AIDS and created the deadly duo. Then with all this, we are hearing terms like, we learned how to inactivate our drugs. All the drugs that we came out with, we thought tuberculosis was eliminated. We found out that streptomycin became useless in 40 days. When Hinshaw did the first trials on Hinshaw, he found that it was a single drug was of no use at all. So of course, human service was done by BMC and all that. And we find that this drug is now, we have terms like MDR, XDR, and complete total resistance. And that is why it's important that such gatherings take place. We renew our pledge to eradicate tuberculosis. It still continues to be, as in John Bunyan's Immortal World, captain of all these men of deaths. So that is why I feel that these kind of things, we renew our pledges, and with the Prime Minister's personal push to eradicate tuberculosis, I'm sure we'll make some progress at all. Thank you very much for inviting me.
Thank you so much, sir. I now request our chief guest, Dr. Randeep Guleria, to kindly come on the dais and grace the occasion, sir.
Thank you. Good morning. Dr. Ashok Shah, professor from Patel Chess Institute, and as has already been mentioned, a teacher to many of the faculty out here. Professor R.K. Dewan, Director of the Institute, Dr. Farhat Mattu, Director General of MSF, Dr. Sangeeta Sharma, dignitaries off the dais, and I see that the who's who of tuberculosis management are present, and therefore it's indeed an honor to see all of you. And I'm sure that today's meeting, with your deliberation, this will be a great success. At the onset, let me really congratulate the National Institute of Tuberculosis and Respiratory Disorders and MSF for actually holding today the TB Day and taking up a theme and trying to do something for tuberculosis. It's something which is really required, but something which we don't do as aggressively as we should. As has already been mentioned, TB is an ancient disease. It's been there as long as humanity has been there. And even if you look at data from skeletons which are 500,000 years old, Homo erecticus, the TB bacilli was even detected at that point in time. So it's a disease which has been there since humans have been there on this planet. And it's always going to be a challenge to eradicate tuberculosis, and we have that challenge in front of us as far as India is concerned, to do it by 2025. But the important thing to remember is that when we look at TB control and how TB was controlled in the Western world, it was not only with medication. As a matter of fact, tuberculosis started coming down in the Western world even before all the drugs came into place as far as treatment is concerned. And therefore, I think when we talk of bringing TB down, we have to have a holistic approach. Sanitation, public health, awareness among the public, addressing issues of stigma that was mentioned, and of course, medication. But unless we do that, we will not be able to eliminate tuberculosis from society. And that's why I think organizations like MSF and others are trying to do a human task and trying to do a lot which tries to address all of these issues. As physicians, we tend to focus on treatment of tuberculosis. But treatment alone will not be enough. We will have to look at a lot of other things. India has come a long way. The first sanatorium started in Rajasthan way back in 1906, and then of course we had the BCG vaccine coming in 1948. the tuberculosis control program, the RNTCP and the DOTS program, and now we have come a long way with the national program, the NICSHE. But I think all of this needs a big push, and I'm glad that organizations are coming together to see what we can do. There have been major progress, and if you look at data, it does suggest that overall cases, incidence and mortality has come down. We've had a setback because of COVID-19. Because of COVID-19, the data does suggest there was decreased detection and increased mortality in as far as tuberculosis was concerned during the 2 years that COVID was there, and therefore there is a need for us to really sort of rebuckle ourselves and recharge ourselves to see what we can do to come back to the decline that was there as far as the pre-COVID data was concerned. What are the challenges that we have? I think we need to look at a lot of issues. One, as was already mentioned, drug-resistant tuberculosis. How do we address that? 500,000 people every year develop drug-resistant tuberculosis. Overall morbidity, mortality is higher in them. Treatment cure rates are low. What can we do to prevent drug-resistant tuberculosis? And the whole issue which we don't discuss as aggressively as we should is latent tuberculosis. What are we going to do as far as latent tuberculosis is concerned? We have almost 40% of population in India which has latent tuberculosis. Chances of them developing active TB is only 5 to 10%, but that's a huge reservoir which is there, and unless we get rid of that reservoir, tuberculosis will not be eliminated. So how do we really tackle latent tuberculosis infection in our country? And I think that is another challenge. And how do we increase case detection? And I think another very important issue, which sometimes we don't discuss as aggressively, and I'm sure MSF is doing that, how do we get all stakeholders on board? That is including the private sector. Still a large number of TB patients go to the private sector, and there is obviously issues as far as proper treatment is concerned. Although it is a notifiable disease, I'm not sure that I could confidently say that all TB cases are getting notified. I would say a large number of them are being treated in the private sector without notification because of, again, stigma, lack of awareness, and so many other things which are related to society, and that also need to be addressed. Finally, I'd just like to address one more issue that I think we need to push for, and that is research in areas as far as TB is concerned. Better diagnostic tests. We still need to have better diagnostic tests. We don't have good diagnostic tests even for pediatric tuberculosis for that matter, or for extrapulmonary TB. Even for pulmonary tuberculosis, how do we combine the chest X-ray with sputum examination using artificial intelligence, neural network data, and there is a lot of research being done to see how you could use that in terms of early diagnosis using portable X-ray machines which could actually go to rural areas, and I'm aware of programs being done even in Haryana, that there is a program being done for TB elimination of that state, and other states are trying to do that. But it has to be done with early case detection, and how can we make it easier to do, simpler to do, and there's research that is needed for that. TB vaccine, there is a lot of trials going on. We are at AIIMS are doing a trial on TB vaccination among the close contacts to see how effective it is. So what can be done as far as vaccination is concerned? And of course, that one was discussing before this inauguration, better drugs which are cost effective as far as treatment is concerned, research into developing all of that. So I think we should also have a push as far as good quality research for tuberculosis is concerned. Unless we do that along with the management strategy, I don't think we'll move forward. So going back to the basic 4 pillars, detect, treat, prevent and build, I think we need to do all of that from policy point of view, from implementation point of view, and from research point of view. Unless we do that, I don't think we will be able to achieve our aim of TB elimination by 2025. I would like to just end by wishing all of you the very best, and I'm sure that this conference will have a lot of deliberations which will be useful, and I hope that it can be taken forward into some actionable points. Thank you very much.
Thank you so much, sir. We now request Dr. Sangeeta Sharma, HOD, Department of Pediatrics, to kindly deliver the vote of thanks.
Yeah, it's indeed pleasure to be standing here and offering vote of thanks. Sir, we are much obliged to you, Professor Randeep Guleria, because I mean, being the former director at All India Institute of Medical Sciences, and now the whole world literally knows you, and we used to feel proud to be known to you. So that's the stature which you carry, sir. And Professor Ashok Shah, my interaction with him has been now for many, many years, though I was not his direct student, but I've learned a lot from him. And also Farhat Manto, I mean, words literally fall short. Kind of the support you landed to us, your MSF team, I mean, the names are many, and each one in the MSF team deserves a mention. If I start the list, I think I'll be standing here, because they have been literally, there behind me as their backbone. And also my director, Dr. Ravinder Devan. So without his support, this event would not have been possible. And he's always there for us, whenever we are planning something academic or something like a research, he always encourages us. So that is really creditable to you, Dr. Devan. And I would also, after this, I would like to thank my two children who came all the way from Azamgarh. I mean, Arpita and Aryan, my hats off you, because it's just because of you that we are standing here. बच्चे, आप अगर हैं तो हम हैं, आपका इलाज कर पाए, ढंग से कर पाए, तो इसीलिए हम यहाँ पे खड़े हैं. So hats off to you. You came all the way when I rang you up. So my heart really, I feel a lot of gratitude. And my colleagues, my seniors, I mean, Dr. Sanjay Matto, who is the Additional Director General TB Control and in charge of our pediatric TB program, Dr. Sarabjit Chadda, Dr. Varinder and me. Either he is the chair or I am the speaker, so we are, we have that relationship. So thank you, Dr. Varinder, for sparing your valuable time, because being the chair of the National Group on Pediatric Tuberculosis, that's really great. So, and my colleagues, my seniors, Dr. Sangeeta, Anurag Agarwal, and the list goes on and on and on. And finally, I would like to thank the faculty, the residents who I hope must have learned and will learn through the day's proceedings. So I would like to end over here by concluding my sincere thanks to each one of you to have come here and graced the occasion. Thank you so much.
Thank you so much, ma'am. Next, we have a panel discussion on overview of WHO and NTP pediatric tuberculosis guidelines.
Let us announce that this inauguration is over. Thank you. Thank you so much. Thank you, everybody.
No, it was my take only that we are, lagging behind. So it's not her fault. I take the fault on my shoulders. So now, so now we'll be starting with a scientific session. That is the panel discussion. And for this panel discussion, I would like to invite Dr. Sanjay Matto, who is the Additional Director General of Tuberculosis at the Ministry of Health. And he is in charge of the pediatric National TB Elimination Program, the pediatric component. And Dr. Varinder Singh, who is Professor Director at Lady Hardinge Medical College and associated Kalavati Saran Hospital, and also the chair of the National Technical Expert Group on Pediatric Tuberculosis. Dr. Professor Urvashi Singh, we all know her. She is in charge of the TB division at microbiology at All India Institute of Medical Sciences. Dr. Vinod Ratagiri, who is come all the way from Hubli, Karnataka, and he'll be the central IAP representative. And finally, Dr. Vijay Vinayak Chavan, we have all heard him in the morning, so we want to take the help of your experience further. So without wasting time, so I'll start with our panel. So as you are all aware, we have heard Dr. Guleria also mentioning that the NTB strategy, you know, the 2025 milestones. So we are really lagging behind. So the milestone as regards to reduction in the incidence rate, we have just achieved 10%. And the number of deaths, we are far behind, that is only 5.9%, and 48% in the reduction of the costs, TB costs. So this is the status. And now coming to the progress as regards to the United Nations General Assembly high-level meeting targets as regards specifically to children. So over here, only 1.9 million children, they have been notified with TB as the case detection and treatment. That is out of the target set of 3.5 million. And only 15% of the target 1.5 million have received the MDR-TB diagnosis and treatment. They are on the second line treatment. Now coming to the preventive part, only 1.6 million of the target set of 4 million, that is 4 million children under the 5 years of age had to be put on TPT treatment, but only 40% target has been achieved, and the worst is over 5 years old, as Professor Guleria highlighted, that we seriously need to look at the prevention targets. But there is a good news, we are well over the target, more than 100% coverage as regards to HIV-TB. Now, we are all aware of this graph, the pediatricians and my colleagues sitting over here. I don't need to reiterate, the risk of getting the disease after infection and death is maximum in the early 2 years of life. Then this risk decreases a little, and then it further rises after a trough, and it remains at a constant level throughout the adulthood and later on in life. So now coming to the global burden, the estimates are that 10.6 million people suffered from TB disease, out of which 1.2 million, that is 11%, were children. And now coming to the deaths, 209,000 children died, out of which 80% children were under the age of 5 years, and 96% of these deaths, they were of those children who did not receive any TB treatment. So India contributes maximum. We are 30%, 31% contribution to this global caseload as regards to children. And it is estimated that 10 to 11% is contributed by children. Because of their low immunity, it makes children more vulnerable. Now my question to Dr. Mattu is, we are all aware of this graph. We have been seeing this graph time and again being published in the TB reports, the annual TB reports of our country. That is which shows that the case notification as regards to children, it remains at something between 6 to 7%. So there is a notification gap that is of 4 to 5%. So Dr. Mattu, I mean, my question to you, you being at the helm of affairs in the ministry as regards to children, so what steps are being envisaged in the ministry to improve this case detection gap so that it decreases?
Thank you, ma'am, for asking this question. First of all, thank you for inviting me for this workshop on the TB day, and thanks to MSF also for organizing this event along with the NITRD. Dr. Guleria sir and other persons, the esteemed experts who were there in the inaugural session, they were mentioning that how old this tuberculosis is, and it is being said that even this bacteria was seen in the dinosaur also the fossils. So the history goes very long. And when we are having this management of tuberculosis, basically we are having the three perspectives. One is the patient's perspective, then we are having the clinician, and the programmatic management of the disease. So how the governments want to treat the disease. So there the three aspects are there. Because it is a public health problem, it is continuing for longer time, so we want to have this management by the government side. That is why the government is investing, and we are running a program, National TB Elimination Program, for this particular disease. Now coming to the where we are situated, you have already mentioned that as per the global TB report, we had the estimate was almost 3.27 lakh TB cases were there in the pediatric, and as per that report in 2021, we were able to notify 1.8 lakh TB cases were notified in the program. So still we were having almost more than 40% of the TB cases in the pediatric age group are in the community. So that is one challenge that program is facing. This is one program. Now how the program is moving, as you asked that what we have invested. So we have done some very good steps has been taken by the government side. From microscopy, what we are doing, we are providing this upfront net diagnostic facility, which is the nucleic acid amplification test. It is more sensitive. So in pediatric tuberculosis, because a sample is very important, so we are providing this upfront molecular testing is one thing we have moved up. Now we were using earlier this solid culture was being used for the DST. Now we have moved to the liquid culture DST facilities are available throughout the country. We are having very good network of the laboratories which are there. Other than this, to identify the DST, we are having the line probe assays also, which identify the genes particularly for which are available for the certain drugs. And accordingly, we can decide that these LP are available for the first line also and second line drugs also. So these are the other things which we have provided in the program division.
So my question to you is how to increase this notification?
Yeah.
We are still at 6%, 6 and 7%. There is a gap, you know.
Yes.
So any measures, inter-ministry involvement or improvement of the niche so that notification goes up?
Yes. So actually, and if you are seeing this treatment aspect also, we are providing this child-friendly formulations in the drug-sensitive TB. In DR-TB also we are having certain time, but not all type of, like in bedaquiline we are not having. But we have already had this Delaminid also for less than 6 years. We have got approved and it is available under the program division. Now coming to this aspect, that what are the challenges and how we are going to cover up those challenges. So as far as the patient is concerned, patients usually want to have this diagnostic facility nearby their home residence. And when we see it is the PHC or the sub-centers are the nearby, but the pediatric tuberculosis, we are not having those services at that level. Usually they are situated at the district level headquarters. That is one of the biggest challenge. Then extraction of the sample is also one of the biggest challenge, because either it is when we are having less than 8 years of the child, they are not able to produce sputum. Either it is to be extracted either induced sputum, or we have to have the gastric lavage or the bile is to be done, where we need the experts, the pediatrician are to be there. And which are available either district or it is in the private sector. So to increase up the notification, what we are having one MOU was done with the Indian Academy of Pediatrician, where we are giving the training to the pediatrics experts and the clinicians who are providing services in the private sector. And the NTP training is being done, that how we can have this management of the tuberculosis. That is one aspect. Then other than this, we have trained this public health team also, along with this private pediatrician, where this we can have more and more pool of the experts, so that this diagnosis can be made. Then we are exploring like how this other than this sputum or the bile or the gastric lavage, we can have this stool maybe utilized as a sample to increase the notification. So these are the other things which we are taking as a to increase the notification.
Thank you so much, sir. So now coming to the next part. Now, you know, we have a case detection gap also. We are in line with WHO. WHO shows that there is an overall case detection gap of 56%, and less than 5 years is almost 70%. And same is true for our country also. But over the prevention gap, we are lagging behind. WHO, 1/3 children, they did not have access to the preventive treatment. Sorry, they had access to the preventive treatment, while in our country we were able to provide TPT to 24%. So now my question is again to you, sir. So are there any measures being taken to decrease this case detection gap and also improve the prevention services?
Yes, actually, again, I'm going to, with the Dr. Guleria sir's comment, like, along with this finding the active TB case, we have to look after this LTBI cases also.
Okay.
So we are having this TB preventive treatment, and we are giving the big push to this particular aspect in the tuberculosis. And in children, basically, this TPT was being rolled out very early, like in 2017 onwards, we are having this policy where we were having this, if children, they are having HIV, they are giving straight words, they are to be given this TPT. Then we are having children who are not having the HIV. In those, if they are family contacts, one active TB case are there. After ruling out the active TB, they are also eligible for the TPT, and we are giving those.
So we
now
are
we are having gap.
the
You are saying that the mechanism are there. For this, the over staff, which are the senior treatment supervised under the program, they need to make the family visits. And they are recording information on the family contacts on the treatment card also,
Yeah,
when they are having.
that's
So
a
these
good
are
thing.
certain steps where we need to see the monitoring need to increase by over the managers, the district level manager, state level managers. Why this? The recording on the this treatment card, if the all the details of the under 5
Contacts,
or
yeah.
the family contacts is available or not. If field supervisors, the treatment supervisors, they are regularly making the visits. Ideally, every month they have to make one visit to identify such cases and then to start.
So what you are highlighting is that in the Nikshay portal now, there is introduction of a system where all the contacts will be entered. So that will automatically improve the TPT uptake.
Yes, we are having TPT module also. We have this on the Nexus system. TPT module has been started, and we have trained over all the specialists and at the field level, that how this information is to be recorded on all the contacts, not only because earlier it was only PLHIVs and the children who were to be put on the TPT. Now we have included adult contacts also, and some vulnerable groups, like persons who are on the chemotherapy or cancer therapy.
So we have expanded the age groups, rather than just limiting to
Yes.
less than 5. Now we are offering TPT to anybody who's a contact with a positive case. So Dr. Ratagiri, my question to you is, as a representative of Central IAP, is there any facility or any initiative being taken by the Indian Academy of Pediatrics to help the program?
Yeah, thank you, madam. On behalf of Central IIP, I thank you, especially Sangeeta madam and the other organizers, MSF and other team. So basically, the Indian Academy of Pediatrics is a big organization where it is covering more than, say, we are having 32,000 plus members. And it is a committed organization to the improvement of the health and the child well-being. In this regard, even Government of India has taken the advices from them and involved in many of the activities where we are able to tackle many diseases and help to improve the children. In that aspect, tuberculosis is also one which we have taken, and I really thank Dr. Sanjay Mattu sir and Professor Varinder Singh sir, who made this MOU, which is possible with our Indian Academy of Pediatrics. With that help, the motto was to improve that gap of 56%, 70%, whatever we are lacking in diagnostic approach. In this, the goal was, this workshop goal was to improve the notification, include all those health providers in that Nikshay
So
portal.
we are training our pediatricians also with the help of Indian Academy of Pediatrics.
Yes,
so
sir.
that's very
Yeah.
heartening to hear.
Yes,
now,
madam.
So
And one more thing, madam, just we have now with the MOU 300 programs we are planned, but we have completed almost 200, and more than 12,000 pediatricians have been trained in this program.
So that's very
is a
heartening
success.
that 12,000 pediatricians from our country have been trained. And I mean, we have literally gone to almost like nook and corner of our country training the pediatricians and conducting training or training exercises. So next is the global health priorities. So we have this graph which we have been looking at for now so many years. This is the end TB curve, which most of us sitting here must have already seen. So I'm concentrating now only on the part which is red. That is that until and unless we introduce newer drugs, newer vaccines, newer diagnostics, we won't be able to achieve the target which is expected out of us to end tuberculosis by 2035. So, and now also the target of spending 2 billion every year, we are just spending 0.9 on these vaccines, drugs and newer diagnostics. Now we have a roadmap as regards to which has been highlighted by the WHO as regards to children, that if we adopt these 10 strategies, we'll be able to hit the target of ending tuberculosis in children by 2030. This is the famous roadmap of children. So my question to Dr. Virinder is, so do we have anything like this in plan for a country?
You see, country position almost mimics the global roadmap, except that we have targets which are more in the recent future. We're not talking of 2030, we're talking of 2025. We did have a setback because of COVID. That was something which nobody could have thought of or planned for. So given that, we may be set off in achieving our target. I'm not going to be pessimistic today. We still have 3 years to go. We have to make progress and achieve. And we must, while we must be concerned at the pace, at the same time also acknowledge what has already been done.
Yeah.
So a lot of effort has been made by the government, and nowhere in the world you have a prime minister leading a program and saying this has to be done. So when you have an advocacy from that level, it moves the machinery and it helps. So while anything new always is exciting, but sometimes what is new is just looking at your own tools in a new way and using them more efficiently and perfectly. And we must look at that also as a component of as we go further, and not only look for what is a new thing in the pipeline, a new diagnostic or a new treatment.
No,
that will come.
Yeah.
But
my question to you is there a roadmap which we have defined for our children of a country?
Yes, we have.
Yeah, that's my question. So now coming to the next part, we have, 2022 has been very exciting. There have been 3, one consolidated WHO guidelines, particularly for children and adolescents, and the operational handbook also released in 2022, and the consolidated guidelines for drugs sensitive tuberculosis. So all these have been released by the WHO. Now my crux of my panel would be on focusing on the comparison of the WHO recommendations and the NTP guidelines in the management of TB in children as regards to the present status. So now discussion points, obviously we'll be focusing on the diagnostic approaches, treatment regimens, newer drugs, MDR-TB regimens, and obviously tuberculosis prevention. Now coming to the diagnostic approaches, now WHO has defined that children with signs and symptoms of pulmonary tuberculosis, expert ultra should be used as the initial test for detection of tuberculosis as well as rifampicin resistance, not only on sputum, nasopharyngeal aspirate, gastric aspirate, but also on stool. Now over here, we are still following this algorithm, and in this algorithm, we are offering NAT, but nowhere there is mention of stool ultra as a test and stool as a specimen. So my question to Dr. Urvashi, to you is, because you being the microbiologist and also closely associated with the diagnostic part under the program, so is there anything to tell us about the data that we are in the stage of implementation of this strategy for our children of our country?
So let me bring back what was covered in the morning. I'll just touch upon that there are ample studies on stool. The lacunae why we are actually discussing in the NTEG and we may be doing it soon to incorporate in the national algorithm. But I'll first touch upon the data that is there. So several studies have been done where so GA and stool have been compared and meta-analysis have actually compared indirectly. Very few studies where both have been done in one study. So the stool ultra, comes close to the results with gastric aspirates.
Okay.
That's what Karen Steingart study says. So as far as comparison with microbiological reference standards is concerned, they come close to about 50%, a little lower. So the gastric aspirate does better, goes above 60%, especially in very young children, followed by, around 60% the percentage varies. Stool falls a little short. When compared to comprehensive reference standards, both fall short.
Okay.
Which of course is one point I wanted both you and Dr. Varinder to bring out. How are children different from adults? The basic difference is in the immune response and the clinical presentation. So not all children will have lesions in the lung which will communicate to the airways and hence will be missed by even the best of methods. And those are the reasons why, against the comprehensive reference standards, all these tests do fall short.
Okay. So that's a very, very important message. So Dr. Varinder, hearing Urvashi, what do you think? Are we in the stage of adopting this for our program?
No, I haven't finished. So I'll come back after sir.
Okay.
So,
Sorry.
Just continuing from where Urvashi left, it is very important to see, again, look at any new test in the context of what it brings to the table. Now, if you look at the two presentations made on stool today morning, one by Anurag, the positivity rate was so less as compared to your own study, which was so much higher. 11 out of 77 and even 46 were not even TB, and you had 47% sensitivity. What are we looking at? How are two hospitals in Delhi which deal with this same milieu producing such a wide difference in results? Is it technique? Or is it this old story of one elephant and 9 blind men, each one holding to one part of the elephant and considering that as being the absolute truth?
Yeah, because
I think that is the reason why we put pediatric TB all jumbled up into one basket. It is not. You have primary TB, you have progressive TB. When you come to adolescent, it behaves like adults.
And
having worked here and also in a medical college, I know out here what you see is adolescent TB. You see more cavitary. When you go to places like where Anurag works or where I work now, you see more of those lesions which Urvashi was alluding to. So these tests are therefore going to be limited. What it excites you is it's a doable. We had a hurdle of to collect gastric aspirate is difficult, stool is easy. If we can get a way that our peripheral labs or the system of transport of a specimen is improvised, then there is a place for.
No, but I think patient, the parent, in our study, what we found was that the parent acceptability was very high. I mean, it's a convenience factor. And also, parents are quite apprehensive to introduce that tube in the child. So this was very convenient.
Stool is non-invasive. You don't have to do anything.
No, I'm talking of the tube, the gastric aspirate.
Is more acceptable?
No, that's not acceptable.
That's what I'm saying. That's an invasive method. Stool is a non-invasive method. It is no brainer that it would be acceptable.
So that part, one part which I found very, comfortable to work with the parents was because of the acceptability of the stool as a specimen. And now coming to ultra, do you want to add something, Urvashi?
So I was just alluding to the global literature, and then we have done studies with FIND. At AIMS also we have a FIND study which we concluded where we did ultra and stool, and we were comparing the 3 different methods. So I think the catch, why the program, the main 2 reasons why we are still discussing, 1 to have ample data, 2 to know which is the best of these 3 methods, because the publications have used different methods, SOS method like you've used, and there are other 2. 3rd, to worry about the trace calls. So
Yeah, that's
those,
important.
several studies have published
Yeah.
the trace calls, but what the WHO concluded in 2017, they said in children, a trace call, children, extrapulmonary and those with immune compromised status, you could actually respect the trace call. The trace call is worrisome when you're dealing with an adult who has had past treatment, who may be having non-viable DNA, but not in paucibacillary TB, for example, in children, in extrapulmonary, or in those people living
So
with
that's
HIV.
a very important message, that ultra, if you're having trace and RIF resistance, I mean, that's a issue.
I'll deal with RIF resistance shortly.
Okay.
So why the trace call actually comes in is because the improved sensitivity, we have 2 targets.
Yeah.
But the rifampicin detection with trace call cannot be relied upon. So
Yeah,
trace
that's
call, you
true.
always have to give rifampicin indeterminate. You need to
Yeah.
repeat the sample or follow up the patient. So rifampicin resistance, you cannot actually rely on.
So discussion tells us that still we are not in the stage of getting this updated. Now coming to the next part, that is again WHO has said that TB of the lymph node and TB meningitis expert ultra should be offered as the first test for diagnosis of tuberculosis and detection of rifampicin resistance rather than culture and phenotypic DST. And for HIV positive to use blood as a specimen. So now coming to for disseminated tuberculosis. Now under the program, we are lagging behind. We are still offering NAT, and we are not doing blood NAT as of date for diagnosis of disseminated tuberculosis, especially for our seropositive children. So any take on that you would like to tell us? Are we in that stage to adopt these 2 strategies?
So it goes quantitatively with the CD4 counts. So if the CD4 count is less than 100, say 60, you can easily detect. Simply because the macrophage is laden with the Mycobacterium tuberculosis will be,
No, I'm talking of adoption of blood as a specimen.
So yeah, so what I'm trying to allude to is the evidence that's available. It was used in studies published in Lancet, I think, where they were able to pick from PL-HIV, and on an average the CD4 count was about 64. So in fact, what we offer in our lab is also we do we do blood culture. We offer to do blood culture for suspicion of NTM or MTB in PL-HIV and also in children. So it's as simple as that. We lyse the macrophages, we grow them in the culture.
My
it's not. I'm just saying it's not common knowledge that people can actually culture. Similarly, it's not common knowledge that NAT could actually be put to use on blood.
Yeah.
But the blood will have to be pre-treated accordingly.
Yeah.
And also, sorry, just last. The actual methods of preparing the blood for NAT is not still standardized and not widely available, but it is doable and will definitely help. Thank you.
You've answered my question, the one which was going to ask you, that our prior knowledge that we should take that part of extrapulmonary TB sample that does not have the blood part to improve the sensitivity. So we are still working upon over there.
So basically, blood contains hemoglobin, which can be an inhibitor of PCR, so it has to be dealt with in the processing.
So these are
we need
different.
To deal with
this is like this cartridge would be different from the other
No, it's
one?
just the processing will have to be
processing
modified.
method would be different if we are looking at blood as a specimen.
Yeah, we'll have to spin down the macrophages, deal with them, something like that will have to be done.
Okay. So now next, you would like to add?
Just a brief point. We seem to be going on a very, very micro place, and I see some residents here. Please do not go back with this idea that blood is a specimen to be used across for diagnosis of TB. We are talking of HIV with very low CD4 count, where possibly there is a role where you would have basilemia. Otherwise, blood as a specimen for TB is not what we are discussing. Thank you.
Yeah. So we have these integrated decision-making algorithms which have been put on the WHO recommendations. So these algorithms, as you are all aware, there are two types. One at situations where the chest X-ray is available, and the other one in those areas where the chest X-ray facility is not available. And these are scoring algorithms to make the diagnosis of pediatric tuberculosis. So my question to you, Dr. Varinder, is that we have an algorithm for which includes a chest X-ray. But are we planning something, algorithm for our remote areas, you know, where the X-ray, provision of an X-ray is a problem? So are we looking at an algorithm without a chest X-ray for some special situations?
Allow me a couple of minutes, because if I give an answer in a binary yes and no, it will not deliver what is to be said. We must go back in history and see how the diagnosis of TB evolved. We started with scores. We had Kenneth Jones, Nyers, and that's what our textbooks were full of.
Yeah.
We threw that out. Why? Because it was all the time trying to creep onto that score to make a diagnosis which was never validated and which was always questioned. Now, that is one part of the story. Therefore, scores have their own limitations. I'm not saying the current, what is the status of the current score, which I'll come to. Why did the pediatric TB stay left out of public health approach for years? Why did it take us close to 15 years before it could be talked of? We were one line in the guideline under special situations.
Yeah.
Then we were offered one paragraph. I'm talking of JMM reports where several times I was member, and we were said, okay, this time you have a paragraph to pediatric TB.
Yeah.
And I said, I do not want pediatric TB as a special situation. I want pediatrics, which is 15% to 25% of the population, depending on what you look at, under 12 or 18. You can't neglect it.
Yeah.
It has to be spoken in the same breath as we talk of TB elsewhere. Just because it's difficult to diagnose, it cannot be kept out. We cannot shut our eyes to it. So having come this far, what allowed us to join the bandwagon was speak the language of public health. Speak the language of chest physicians, which I was able to learn when I joined this institution. Before that, I did not know what they speak. Having learned their language, you can piggyback and take the bandwagon of pediatric TB along with. Moment we move out, and it has its own strengths. Today we're talking of upfront diagnostics. We were the first country in the world where for pediatrics molecular diagnostics came before it came for adults.
Yeah.
So that was because we started speaking, stopped staying in silos. Moment we go back to again these scores, we will get into silos. We will move away from UDST. We will move away from knowing where rifampicin resistance is. We have to, WHO also says, either adapt or adopt or develop. We do not have to be just a conduit of what comes our way. We have to see what works best for our situations. They bring a lot of information, they give a lot of guidance, but it has to be seen. And the last point, which is very important, is if you go back again in history, the first guideline for TB, pediatric TB came in 1907, then came in 2000, then 2012, then 15. And between 15 and 22, we have 7 guidelines, many of them even have not been published.
Bilkul.
How does that translate into a training program and reaching the last mile? If we keep on changing, so change should happen when it is actually going to make a difference in the life of people.
When it is pertinent.
And when it is pertinent, not for every small thing.
Yeah. So, mind you, this also by the WHO, it's a new interim recommendation, conditional recommendation with very low certainty of evidence. So, I mean, and WHO is looking towards collection of data before such a thing can be adopted, so, and as you said, we pediatricians have been really very, I would say, strong-worded and strong-mouthed, that wherever we have gone, me and you, we have been shouting at the top of our voices. So, but we have come a long way. I remember in 2003 was the first time, 6th and 7th August 2003, we held the first meeting over here in my institute. Then from 2003 to 2012, there was nothing. And at that time, the director, Dr. V.K. Arora, had asked me, कि प्रॉब्लम भी होती है, ये करने की क्या ज़रूरत है मीटिंग, यू नो, द फर्स्ट टाइम दैट इज़ इन 2003. So luckily we have come a long way, and now obviously the world community realizes that pediatric tuberculosis can no longer be ignored, and I'm very happy for that achievement, that we are still, you know, we are now in the mainstream. So coming to the next part, that is the treatment regimens. So the treatment regimens, we have all heard, you know, we have seen the NEJM, the 2 trials, that is the SHINE trial, which highlighted that children 3 months to 16 years should now be offered with drug susceptible tuberculosis. Non-severe TB should be offered 4 months of therapy. And the other one, that is the study 31, in which children or adolescents more than 12 years should be offered the rifapentine and the moxiflox based regimen, again a 4-month regimen. And finally, the third treatment shortening regimen is for TB meningitis, that is the 6 months of uniphasic regimen, that is 6 INH, rifampicin, pyrazinamide and ethanamide. So, but over here in the program, what we are offering is for a drug susceptible TB, we are offering 6 months of regimen, and for MDR-TB we have, for TBM we have 1 year of therapy. You know, to increase the compliance, I do agree that the time is there where we should be looking at shortening of the treatment regimens. But is the time appropriate? Do we need, again, you're smiling. I think I got my answer.
You see, everybody has to get this answer. My smile just answers to you. So I'll quickly sum it up. When it comes to shortening of regime, the SHINE trial, any shortening of regimen is something which is worthwhile, decreases the cost for the program, decreases the stress on the family, and adherence is better. So it's absolutely something you wish. But one has to see the results in the context of our situation. When you look at the SHINE trial, I am working with Professor Diana Gibbs on shortening of TBM regimen. So I was on the trial steering committee of SHINE trial, and so I can tell you, they themselves are saying it has to be done where you have the best possible way of looking at a minimal TB on an X-ray. You and I and many of people here in the audience who deal with TB and particularly with pediatric TB know how much is the difference between inter and intra-observer assessment of X-rays.
Yeah.
So how would that definition of minimal TB happen in a periphery? Because guidelines are not going to be for a tertiary level organization. The guidelines are going to be for everyone. So if the program says 4 months for everyone, are we ready? Do we have that capacity to diagnose minimal TB in the periphery? As a step forward for implementation of these recommendations by WHO, the same group has come up with an atlas of reading X-rays. So we are looking at something which is not immediately doable, even though the group is not directly saying it. And what is the program doing? Under the national training program, which has been devised by us and being run by IAP now, we are working on these very lines where you are educating everyone on what is suggestive TB, what is not suggestive TB, and the X-ray diagnosis. Once we have made inroads, possibly there will be a place for SHINE trial. When it comes to TBM, that comes from not from any RCT. That comes from programmatic data or a large experience from South Africa, and that should be respected because it's coming from a place where they have good documentation, they have situations which are quite similar to us. So therefore, we should not have any xenophobia. We should be open to the fact that there may be a global learning. At the same time, if you go back and dig back, what you see is they have made a historical comparison. And the historical comparisons have one big difficulty, and the difficulty is, along with the TB treatment, what evolves is how you manage the TB complications. And in deaths of TB or overall management of TB, these play an equally important role. What they have looked at is the mortality and not the relapse. And mortality data shows that it is as good as with a longer regimen. But my question is it is not done in a controlled situation. You are looking at historical data where the practices as it is, where people have used, the mortality has gone down. So we cannot say draw this parallel and say this is largely because of shortening. But this
You know,
is something we are going to look at in a
my
maybe a phased trial.
concern, just to add over here, my concern when I was interacting with the WHO colleagues was that, how can we offer a regimen of 6 months for such a dangerous condition like TBM when we do not know the INH resistance status? We are giving without knowing whether it is INH-A or CAT-G. They have just said for drug-susceptible tuberculosis.
That's a fair point, considering that ethionamide and INH both
because
are the major component.
that's one thing which I found very absurd. So now coming to the newer drugs. So newer drugs and DRTB regimens. Now over here, as we are all aware, WHO has recommended bedaquiline and delaminate for children of all ages. So now coming to our program, we have BDQ, which has an approval for more than 5 years, more than 15 kg. Delaminate, recent approval, more than 1 year, more than 10 kg. So still, we have to give injectables to our children less than 1 year. And also, if it's in a shorter MDR-TB regimen, then again injectables for children in the age group of 1 to 5. So my question as a field question to Dr. Vijay is, because you have worked in Mumbai, so my question, sorry to keep you waiting, you've been, sorry about that. So my question to you is, what is your field experience using these drugs? Are you comfortable in the age groups which we have not yet got approvals for?
Yeah, absolutely, because the kind of patients that we were getting, though not many, because less than 2 years we had one, but we never found any problem with giving delaminate with this. We got it through a compassionate use program, and it is actually much safer to give an oral delaminate than to give an injectable. Now, if you are dealing with a child, and I agree that so far there are not many studies with ototoxicity, but imagine an ototoxicity being given to a child, and where will his speech develop from? So,
yeah,
so he's not going to participate in your audiometry, which is very difficult to get it done. So I do not understand that, we really cannot compare an injectable aminoglycoside with a serious ototoxicity ADR.
So, you say it's safe. So what do? You take a approval from both the parents?
Compassionate use,
okay.
yes.
So now coming to the last part, that is the TB preventive therapy. Over here we are all aware, because of the shortage of PPD-RT23, we are moving towards CTB skin test. The advantages of that test, we know that there is no cross-reactivity with prior BCG vaccination or with MOT infection. Now my question is that are we in a situation where we can adopt this test? Because I know that field analysis has occurred as regards to children. It has been approved for adults, but what about our children? Are we looking at that? Dr. Matto?
Thank you, ma'am. And as you rightly mentioned that we are having challenges of this PPD-RT23, and it is a shortage. So we had the IGRA, but IGRA was having this cost factor was the other thing. Now CTV, it has been approved by the DCGI. Yeah. It is approved, and now we are having a validation and cost evaluation study by the ICMR. As soon as it is available, we are going to make a procurement and it will be implemented.
So it's approved
with regard
for children?
to the use in the pediatric age group,
No, it's not
because the ICMR validation, they said that this data was inadequate when they were doing this sampling and the validation study was being done. So it is still in process, because data is being collected, and after that this validation will be done. So as of now, this CTB is available only for more than 18 years of age.
Okay.
And as soon as this ICMR do the validation for pediatric age group also, we are going to make procurement for that age group also.
So coming to the last part, that is the TPT regimens. We are offering as per WHO. Now the regimens, they have increased. We are still short of 2 regimens, that is 3 RH and 1 HP. So, my take, Dr. Vrinder, I would like to ask you, are we prepared to accept 3 RH?
You see, there are a lot of concerns about symptomatic screening, missing out on some active cases, and using RH as a combination in place of H alone. We cite global evidence again to say that those infected do not have enough bacillary load to create a resistance pattern. But here we are talking of a situation where the diagnosis itself may not be so well done. And given those situations, perhaps protecting rifampicin may be a good idea. If there is a compromise, which I see, then I see a compromise with rifampicin and H because of its adherence advantage, 12 dose schedule, and it's still 3 months.
So what about 1 HP? Because in
1 HP
emergency
we still
situations,
do not have adequate data.
Adequate data. So now with this, the last slide, that is for adults and children living with HIV, 36 months therapy has been with INH has been highlighted by WHO. And the last thing is that we are also providing this, that we give 6 months prophylaxis after completion of TB treatment to our HIV children. So the status of this, are we looking towards implementation of 36 months of INH for HIV?
Actually, ma'am, this was discussed in the National Technical Expert Group, and after this, it was a collective decision was taken by the expert group that we are not going ahead with 36 because there was some implementation challenge, and
that is true.
There was some challenges like what will be effectiveness and other things were the concern. So as of now, a program is advocating only 6 months of, and as a policy decision, it is only at present the 6 month of INH or 3 HP if it is available in the geography. That is the as per policy and guidelines now.
Okay. So we end our panel over here. It's a big thank you. But before I end, I want each one of you to just be brief with one liner. One liner. What do you suggest? What are you working for? One liner.
Easy and better diagnostic tools. We are missing quite a lot of children.
Okay. Yes, sir.
So, ma'am, I am working for basically the patient. It is a patient-centric approach. So, how I can make these services, diagnostic, treatment, and the preventive services easier and usable to the patients. That is my motive.
Dr. Urvashi?
How to reach each patient, how to ensure complete treatment.
Yeah.
I wish for efficiency, whether it's an old tool or a new tool. If we do not change our methods of using it and are not efficient, they will fail.
I wish there should be a better intersectoral coordination between private sector and public sector, which is lacking what we have seen in our programs.
And if you ask me, I want a holistic approach. You know, we are not just pediatricians standing here looking at children to manage their clinically, to manage tuberculosis as a clinician. What I as a clinician want is a holistic approach where the child, once I treat, is amalgamated back into the society, back into the education system, and becomes a useful and a productive member of this society. Thank you so much.
Thank you all the speakers. It was a very interactive session. Sir, wait for a minute. We have a green welcome. I request Mrs. Komal Vasisht to come up on a stage to present green welcome to Dr. Sangeeta Sarma, to Dr. Vijay. Green welcome to Dr. Virinder Singh. Welcome to Dr. Sanjay K. Mattu. Green welcome to Dr. Urvashi B. Singh, ma'am. And green welcome to Dr. Vijay Vinayak, sir. I would like now to inform everyone that we are breaking for a lunch for an hour. I kindly request all the, yeah.
Because we are already running short of time. I mean, 45 minutes, if you can be back, that would be really nice of you.
Yeah, we will regroup in the hall after 45 minutes for next sessions. Welcome back. Welcome back, everyone. We are now resuming our sessions for the day. For the first post-lunch session, I would like to call upon stage our Honorable Director, Dr. Ravind Kumar Diwan, for his talk on the role of surgery in pediatric TB. Welcome, sir.
So good afternoon, everybody. So having the privilege of being the director and thoracic surgeon, I have somehow introduced surgery also, when we were discussing tuberculosis. Actually, in our institution, there is a pediatrics ward in which there are 30 or 40 beds. And generally, some case of empyema or requiring surgery, 12 to 14 cases are always admitted. So we have an experience about it, with which I would like to share with you. And very briefly, some points have to be considered. The problems in children are somewhat different as compared to adults. In adults, the surgical intervention is generally restricted to or generally involves management of complications and sequelae of pulmonary tuberculosis. While in children, though these complications are seen in adults also, but in children we have to do for several other reasons. For instance, lymphadenopathy in the primary complex that may require a surgical intervention for diagnosis as well as to prevent compression on the airway, then secondary damage to lung. And just as in adults, the aims of surgery may include elimination of mycobacteria, restoring lung functions, and preventing or minimizing complications. And major clinical presentations for which we have to do some surgical interventions include extraluminal nodal compression or intraluminal obstruction. Similarly, post-tuberculosis pulmonary destruction. I will show you some of the X-rays, etc. of these patients on the way. And tuberculous pleural disease. In fact, this is the largest number, and probably in no other hospital you will find children with chest tubes going around. And we see a large number of patients who are having empyema, the primary cause being tuberculosis, and then a bronchopleural fistula, and then an empyema formation, and they require some kind of management. Generally, the management is on the same lines as in adults, but there are some subtle variations which I will point out. So, major airway obstruction, the nodal compression of airway, which is most commonly, because many of you might have seen X-rays with total left side opaque hemithorax. And many times we believe that this is because the left lung is destroyed. But we have seen the reason is a large lymph node presenting in the left vein, compressing the left main bronchus, which is causing the lung to collapse, and it remains collapsed. Over a period it becomes destroyed. So if at that time somebody had addressed the problem of lymph node, probably we would have avoided a pneumonectomy, because later on when the patients present to us, we end up doing a pneumonectomy. Proximal compression in trachea or main bronchus has been seen, and occasionally we have seen asphyxia also. I had a child who had presented with like a foreign body, and we removed from the main tracheobronchial tree a lymph node which was eroding into the airway. So this also happens occasionally. While distal compression causes atelectasis and obstructive emphysema. Life-threatening asphyxiations, as I said, urgent bronchoscopy interventions may be needed, and surgical decompression may be needed. This bronchoscopy is also important in children, because in children as well as in adults, but if you are contemplating any surgical interventions, the bronchial tree may also be involved by tuberculosis. And if you do any pneumonectomy or lobectomy, at the proposed site of your stump formation, if there is any active infection, the patient will develop bronchopleural fistula and go into serious complication. So surgery for tuberculosis in children is rather less than that in adults, but if you are contemplating it, it has to be contemplated with greater care and better selection of cases. And chronic obstruction can cause atelectasis or lobar obstructive emphysema. Then there is a risk of superadded infections which cause respiratory compromise. And as I mentioned, delay in surgical intervention sometimes leads to lobar destruction. And surgery is more dangerous, as we can see that in child, if we are sacrificing a lung, probably the prognosis will be worse. It is both worse as well as good. Children do very well after major surgery because of their inner reserves, but at the same time they are at a risk of going into respiratory compromise if patients are not selected carefully. Post-tuberculosis pulmonary destruction, when they are not suffering from active tuberculosis and have received multiple courses of treatment based on imaging. Now what happens, a patient who has been fully treated with TB gets cough or expectoration again, and many times our physicians end up giving them ATT again. On the contrary, they are suffering from superimposed infections which have to be treated by pyogenic bacteria, and sometimes if the disease is localized, they are very well treated by lung resection, and common symptoms are hemoptysis, cough, expectoration, and recurrent left lower tract infection. It may require up to a pneumonectomy depending on the extent of disease. I may again emphasize that we make all efforts to prevent or not do any lung resection surgery in children, but occasionally there is no other hope except to do it. For instance, this X-ray or CT scan, I'm sure, and Vijay is nodding his head, this patient will definitely require a pneumonectomy if his symptom control is to be achieved. Now this is a post-tubercular bronchiectasis. Again, you can see these large cavity-like structures, and we see very often, and these people keep on suffering. Many of these people I had seen that they got this disease in childhood because nobody advised them surgery. They come to me when they have become young adults, and sometimes even 50 years old, 70 years old. If you take history carefully, they had suffered this disease in childhood because childhood bronchiectasis is very common, and it can be tubercular, post-tubercular, also and non-tubercular also. But majority of these people have taken anti-tubercular therapy in their earlier years. Now, tubercular pleural disease, I think this is the commonest reason for admission for a surgical cause in any TB hospital. It can be active pleural tuberculosis with effusion, which is treated by aspiration. I think children are very resilient. Sometimes we don't require major interventions. We had children in whom we have just put in a needle repeatedly 3 or 4 times, given ATT, and they got well. They did not even require an intercostal drainage. But the mainstay of treatment is a properly done intercostal chest tube. All of your pediatricians, you must be asking your surgeons to put in an ICD. I think this procedure, which is very simple, is done in a very, very inefficient manner in many cases across the country. I think 2 or 3 principles of an intercostal drainage tube, it should be done especially in a child with a person who is reasonably experienced and skilled in putting a chest tube. The child should have minimum pain, adequate local anesthesia should be given. The tube should be placed very freely. The diameter of tube should not be larger than the intercostal space so that it does not cause any pain. And the tube has to be fixed very well and maintained very well. Especially in the context of pus, the tubes have a tendency to get blocked, and then the person keeps on moving around with the tube and it is not draining. There's no point keeping a tube which is not draining freely. So that tubes need to be changed frequently. And as I will show, an operation called plurocutaneous window, which by all world literature is contraindicated in children, is occasionally very useful even in the children age group. Then loculated empyemas are generally treated by decortication and occasionally by plurocutaneous window. But surgery is offered to symptomatic cases only when there are large pus collections. One question which is repeatedly asked, suppose there is a small pleural effusion, patient has been treated and there is a fibrothorax. Does it need to be operated? No. Unless there are collections in between and there is no severe respiratory compromise, these patients should not be operated upon. And many of these cases we have seen down the line, their thickening also decreases, especially in the childhood age group. So there is a scope for improvement. And so surgery, now there are 2 paradoxes. Surgery should not be delayed unnecessarily, but at the same time surgery should not be offered prematurely. Now this is a X-ray right opaque hemithorax treated by intercostal drainage tube alone. So well-functioning good chest tube can cure a child. But the point to be understood here, if you see the intercostal spaces, they are very small. The child is very small. And we have had instances where a chest tube has been put in, and because the person did not have adequate control, it ended up damaging mediastinal structures and caused a death also outside this institution. So this chest tube insertion in a child should be done in an operation theatre by an experienced person. Never allow, because generally all over our country, chest tubes are placed by the junior most person. They should not be allowed in children. And child gets well. Another right opaque hemithorax fully filled up with pus and treated by chest tube drainage alone. So chest tube alone, a good drainage, works very well in children. And Dr. Sangeeta will attest that sometimes we see children in her ward where there is a chest tube draining and we say, okay, maybe this child may require surgery. But we are just patient, and 2 weeks, 3 weeks down the line, they get well without any surgical intervention whatsoever. This is one area I may say, if I have planned surgery in 100 cases, I actually end up doing only in 50 to 60% cases. Children are so good, if their drainage is effectively done, then they may not require surgery. Their healing mechanisms are better. Now this is another case which we managed by chest tube alone. This is a photograph of VATS decortication. On the left side, what you see, we call a device which is put to, when we make a thoracic trocar, this thing we put in to keep the window patent. This device has been recently available so that we can put in instruments as well as telescope through this and do a complete decortication. Nowadays, majority of decortications in our institute, especially in children, are done by video-assisted thoracoscopic approach. Earlier, the norm was open conventional decortication. In children, generally, many of the cases can be done. Only thing is, in children, sometimes the intercostal spaces are too narrow to put in any trocar. But nowadays, those problems have also been solved by this industry. They have developed these equipments which will help to retain a good amount of trocar through which instruments can be manipulated. Now this is one case of large tuberculoma which actually required, he was being treated for a long time. This is one of those x-rays from 1990s, was being treated for a long time and was continuing to be symptomatic, sputum negative. We ended up doing a right pneumonectomy. This is how the x-ray looks after pneumonectomy, and the patient did well. Now, you see, I talked about PC window illocer flap. This is a 13-year-old girl who had come with a chronic empyema, was also labeled as multi-drug resistant tuberculosis. I said nothing, she's very serious, sick looking child. We just did a window thoracostomy. And even the window thoracostomy sutures, because of infection, had given way. But because we ensured a good open drainage, the same child, after 8 months, she walks into my OPD with a completely healed window, fully expanded lung, totally asymptomatic. So this operation can work wonders in selected good cases. Window thoracostomy, it was originally known as illocer's flap. We have modified it slightly in terms of that we do it in the axilla, stitch the pleura to the skin after resecting 2 or 3 ribs, and keep the, what happens once you have made a window, there is no need of a chest tube, and patient is able to dress himself or herself, look for herself. There is no nurse or doctor required for removing the tube, putting the tube again, putting a suction, etc. And it works wonder. We have our own large series in which we have shown that 70 to 80% of cases of chronic tubercular empyemas can be managed with this alone if they are not fit for decortication. And now, another thing I want to say that all chest lesions are not tuberculosis. Now this X-ray, because of the lesions, I don't know why this was being treated as tuberculosis, and then somebody did a rigid bronchoscopy, and you can see now it is clear that while doing a bronchoscopy, one caused a pneumothorax and one can discern a foreign body. And by the time this is done, this foreign body had to be removed by a thoracotomy, and then the lung fully expanded. So we have seen that children of sequestrations, bronchogenic cysts, hydrated cysts, etc. being treated as tuberculosis. So I think in children, as in the morning, we discussed so much about diagnosis of TB, and probably to start empirical anti-tubercular treatment, which you must have been resorted to quite often, may be absolutely contraindicated, maybe contrary to patient's interests. You have to pursue the diagnosis by CT scan or something else, and maybe you will get a different diagnosis. In this institution, though I have operated upon several cases who have received multiple courses of ATTs and then to be diagnosed as a carcinoid, bronchogenic cysts, sequestrations, or pleural mesotheliomas occasionally, or pleural benign tumors, or as a dermoid cyst. Everything has been seen, but which has been treated as tuberculosis. So one point I wish to say that all chest lesions, just because an X-ray shadow is present, are not tuberculosis. This is a right destroyed lung in a 10-year-old child. I mention it because this patient actually came to me from South Africa, and nobody would operate upon this patient. And this patient did very well, right pneumonectomy was done. It was 9 years ago, the child is doing well. So occasionally we may have to go to pneumonectomy in a child also. So what has been our experience? Though we are in the business of thoracic surgery for 20-25 years, but my colleagues collected data over last 5 years, 2017 to 22. Total we did 534 cases for tuberculosis, any case, out of which pediatrics are 37, that is 6.9%. We know that pediatrics is 12% of the population, but in those who requiring surgery are less. If we just take the data of this institute as a representative sample, then children is less. Males were 20, females were 17. Loculated empyema in 34 cases. VATS decortication 1, open decortications 28, majority earlier we were doing open, and a window thoracostomy in 5. Post-TB destroyed lungs 3, and complete resolution of all the symptoms was seen in 95% of cases. So it is, whenever surgery is done, these are some of the YouTube videos, if some of you want to keep this slide, in which all the procedures that we do, whether it is window thoracostomy, decortication, lobectomy, pneumonectomy, they have been demonstrated in photographic form. So in conclusion, thoracic surgical interventions in children have gratifying results, but surgery in a pediatric age group is a calculated decision. Many children do not require major interventions and can be managed by minor procedures alone. Early thoracic surgery opinion is important for best possible outcomes. Thank you so much. I'll be happy to answer questions if any. Of course, this is a topic that you not encounter very often. And anyway, thanks, thank you.
Thank you so much, sir. Your experience in thoracic surgery and tuberculosis in general, spanning over more than 3 decades, is an invaluable asset to the organization. Now I will like to call Mrs. Komal Vashisht to kindly present green welcome to. Next, I would like to call upon stage Dr. Sangeeta Sharma. Dr. Sangeeta Sharma, Professor and HOD, Department of Pediatrics, for her talk on adolescent TB, a cause of future infertility. Thank you, ma'am.
We are running late, so I was waiting at the backstage to save time. So without wasting time, this is a concept which I realized when I joined this institute, that adolescent female girls, they experience some menstrual dysfunction, and it could be a cause of future infertility. So this menstrual dysfunction has been reported in adolescent girls, which if not addressed early could lead to future infertility. So the objective was to see the effect of pulmonary, extrapulmonary tuberculosis with or without genital involvement on menstrual function in adolescent girls. So the duration of the study has been 8 years, and it's a prospective study on adolescent girls who were diagnosed with tuberculosis attending the pediatric OPD or admitted in the ward. And the demographic profile, the clinical details and the menstrual pattern was noted. Being unmarried, this is important, no attempt was made to do a vaginal examination or endometrial sampling in these girls. And menstrual blood was sent for CB-NAT or now obviously TrueNAT and liquid culture DST wherever it was possible. And ultrasound abdomen was done in all these girls to rule out or rule in genital involvement, followed by PET or MRI wherever indicated, and CA125 antigen to differentiate between tuberculosis and CA ovary. So in total 265 girls, we found that the age of menarche was 12.4 years, and majority obviously they come from poor socioeconomic status. Only one girl was seropositive and all were unmarried. So most important is to correctly categorize these children, whether they are without genital involvement, that is as a part of pulmonary or extrapulmonary tuberculosis, or they have genital involvement in the form of tubo-ovarian masses or involvement of the endometrium. So ultrasound, as I said, we did in all, we are doing in all the cases to rule out genital tuberculosis or rule in. And the commonest finding, as you can see in this ultrasound, is this cystic mass, the ovarian cyst which has solid as well as cystic areas and fluid levels, as seen in female genital tuberculosis. PET scan, PET CT, obviously, now PET and for CA as well as tuberculosis. In tuberculosis also there is uptake and it shines. But the differentiating feature is what you have in malignancy, you have CA 125 levels which are more than 500 or in 1000. But in these girls with tuberculosis, maybe you have a PET scan which shows enhancement, increased FDG uptake, but the CA 125 levels is there usually within 100. Now MRI, wherever it was indicated, like in this case, the cystic lesion with internal debris, same thick enhancing walls with bilateral adnexal tubo-ovarian masses. So most important was to categorize these girls whether they had with genital or without genital tuberculosis. With genital tuberculosis, we have had just 10 girls, so majority of them, they were without any genital involvement. But without genital involvement, they still had, a component of menstrual dysfunction. And we have reported this MDR, female genital tuberculosis, as a preliminary report, in which 2 girls out of the 6 reported, there were 2 unmarried girls. And now coming to the menstrual dysfunction, this is important because literally all, as you can see, total with abnormal menses was 244, and there were only 21 children, that is only 8% of the total cohort which had normal menses. So majority, they have either they go into primary or secondary amenorrhea or oligohypomenorrhea. So the 21 girls who had normal menses, they were those who were started ATT within 1 month of developing TB symptoms. So this is very important. And menstrual blood, for us, it was cumbersome because neither the parents nor the girls were comfortable to collect the menstrual blood. And 14, 12 and 33 girls with primary, secondary or oligohypomenorrhea who were put early on ATT, they had regaining of their periods, periods returned back the earlier on adequate treatment. So this is very, very important. The response is partial if you start the treatment late. And the girls with genital involvement or bilateral extensive pulmonary tuberculosis or disseminated TB like TBM or DR-TB, they had poor response. There have been very few studies highlighting this concept, and the most quoted is this Tripathi and Tripathi, who observed that amenorrhea in majority of these children. Similarly, Samal et al. Had the similar findings, but over here the thing was different, that they even had a chunk who had menorrhagia. But in our case scenario, menorrhagia was very, very infrequent, literally not even a case. So, and we have also published this initial study, the menstrual dysfunction in non-genital tuberculosis. Over here there were just 42 girls. This was just a pilot which I just started to do, and the same problems they were encountered. Now, so what is the etiopathogenesis of this menstrual dysfunction? It is quite understandable. If you have a genital involvement, then obviously there would be destruction of the endometrium because of the involvement of the endometrium by the formation of the tubercles, etc., and destruction finally leading on to something like a Escherman picture if you don't treat at early, and obviously as a cause of amenorrhea or infertility. But what is the reason of having amenorrhea or oligohypomenorrhea in those girls who have no genital involvement? So this pathogenesis, which has been highlighted by Kumar et al., they say that mycobacterial antigen, it has an anti-gonadotrophic effect. So that could explain the, the menstrual dysfunction in these adolescent girls. So the take-home messages are that there is very high prevalence of menstrual dysfunction in tuberculosis, both pulmonary as well as extrapulmonary, which may be responsible for future infertility if not thought of early, so we need to treat them. And the more the severe the form of the disease, like drug-resistant cases, miliary TB, tubercular meningitis, they are associated with early onset with more severe menstrual dysfunction, and early diagnosis and start of timely effective treatment results in early resumption of normal menses, which may prevent permanent damage to the genital organs and future infertility. So I would like to end my talk over here with these references of our publications. Thank you so much. I think because of paucity of time, we are shortening without question answer session. Sorry about that.
Thank you, ma'am. Moving on to our next session, focusing more on the preventive approach towards tuberculosis, I hereby invite Dr. T.P. Ashraf, Professor of Pediatrics, Kozhikode Medical College and President of Indian Association of Pediatrics, Kerala, for his talk on TB-free air for every child movement, Kerala chapter. Over to you, sir.
Dignitaries, distinguished faculty, esteemed experts, my friends and colleagues. I am here. First of all, let me thank the organizers, MSF, as well as the National Institute of TB and Respiratory Diseases for this wonderful opportunity. I am here to tell you a story. A fascinating story of TB-free air for every child in Kerala. That is an initiative by Indian Academy of Pediatrics, Kerala State Chapter, well supported by District State TB Cell as well as the Central TB Division. We IAP always fights for protecting child rights, and we consider TB-free air is one of the rights for every child. It is an advocacy campaign where IAP Kerala raises the voice for children. It is an action campaign where IAP Kerala tries to ensure uniform, high-quality standard of TB care to every child. It is a commitment of IAP Kerala to provide all technical support to state to roll out any interventions to improve the child health. Expanding the programmatic management of TB preventive therapy, that is PMTPT, to children more than 5 years was the first initiative under TB-free air campaign. TB preventive therapy was scaled up to children and adolescents up to 15 years in the Kerala state since November 1st, 2020 onwards, even before the national guidelines with the official permission of Central TB Division. A test and treat approach was opted for offering TB preventive therapy to older children and adolescents. Under 5 years, we will screen out the disease, then start the preventive therapy. But the older children, we used IGRA to diagnose latent TB infection. We all know treating an otherwise normal child for 6 months with a preventive therapy is a difficult task, especially in the adolescent age group. So we opted for 3-month INH rifampicin regime with a prior approval with the Central TB Division. The first step was the technical working group with 20 members from IAP to develop an operational guideline for the TB preventive therapy. That was approved by the Central TB Division in November 2020. IGRA was procured. 46 laboratories already having facility for the ELISA was selected for the IGRA testing. Before initiating TB preventive therapy in the age group of 5 to 15 years, X-ray have been made mandatory. 104 designated X-ray units in the public sector as well as 110 units in the private sector were mapped. X-ray in public sector for rolling out diagnosis was already made free. A provision to reimburse for the private sector also made. Fixed drug combination is also there, which was provided by the government of India for the 3HR that is used for the preventive therapy. Indian Academy of Pediatrics took the responsibility to help for rolling out active TB among children and adolescents. In Kerala, the population is 3 crores 30 lakhs, and the number of pediatricians is around 2,700. And 95% of them are IAP, Indian Academy of Pediatrics members. 1,000 of them were trained through the online mode by 20 trainers of trainer. IAP took that commitment also. All the manpower in the system of the NTEP were trained. Tabletop diaries were provided to practicing pediatrician. Systematic demand generation was done with the help of TB survivors as well as the film actors including Padma Shri Mohanlal. Target provider oriented IEC were organized, and moreover an expert committee in every district to take decision in doubtful cases virtually also formed. And 1st November 2020, that is the formation of Kerala, the program was launched by our governor. We pediatricians are also always fond of the developmental milestone. This is because of the lack of time, I'm not elaborating. This is the operational milestones of programmatic management of TB preventive therapy in Kerala. These are the guidelines. Household contact under 5 years, we will treat. Household contact in the age group of 5 to 15 years, test and treat. Children, nephrotic syndrome on steroid like immunosuppressive drugs, dialysis, test and treat. And this is the guideline we published. The weight band is given there, just a look. We are running short of time. The existing network for the diagnosis is used for the sample collection and sending into the district labs under cold chain for the IGRA. IGRA positive children were referred to pediatrician for rolling out active TB. All treatment initiation and follow-up was done initially at the treatment unit level, and now it is decentralized. Cases where was a clinical dilemma, we referred, I already said that, referred virtually to the district pediatric TB expert committee. A treatment supporter was assigned to every child, which is already there in the network. Children initiated on TPT were linked to the treatment support groups based on need. Treatment adherence support and system to detect, manage, document adverse reaction were organized at peripheral level with the active involvement of the primary health center. Monthly clinical assessment were done by pediatrician, and July 9th, 2021, there was a joint review meeting. Technical working group members in the Academy of Pediatrics and WHO representatives participated in that meeting. And this is the statistics. I'm not elaborating, just a look. There is a concern. If we are opting for INHS rifampicin 3-month regime, there may be more adverse effects, but according to our statistics, it is low. This is the statistics in the age group of 5 to 15 years. All other professional organizations are involved, including IMA, Pulmonology Critical Care Association, Private Practitioners Association, all of them. These are the lessons learned. Expert committee at district level met virtually. Program managers appreciate the presence of such committee in solving clinical dilemmas. The coordination for the beneficiary list preparation, scheduling testing days, collecting samples on particular day, transporting the cold chain to hub laboratory, and performing IGRA test need a good system. Now we are going to introduce CTB test. IGRA may not be needed. As the waiting time for IGRA test increases, the interest for eligible beneficiaries and clinician on TPT decreases and contributes to lowered IGRA test coverage. Robust follow-up mechanism shall be in place to ensure treatment adherence, especially among teenagers and working class. Every service provider need be trained periodically on updates and frequently asked questions on TB preventive therapy so that no conflicting opinion reach the beneficiaries. Initiatives to reduce out-pocket expenditure on investigation to roll out active TB and blood tests among programmatic management of TB preventive therapy beneficiaries are needed. Treatment support system and private sector engagement are essential for TB infection management also. JEET project has played a major role in establishing a system for PM-TPT at district level and act as a supporting team for field staff. Way forward, decentralization is the key to the success of programmatic management of the TB preventive therapy. CTB can help in reducing the waiting time for diagnosis and expansion of PMTPT to vulnerable groups. Actually, it is a teamwork by the state TB cell as well as the IAP and many other professional organizations, but any work needs some leaders. These are the leaders, Dr. Narayanan and Balachandra Vasti, President and Secretary of Indian Academy of Pediatrics, and Dr. Sunil Kumar was the State TB Officer, and Dr. Ragesh Vasti, Consultant WHO, who led the effort. Thank you all for a patient hearing.
Thank you, sir, for enlightening us with useful insights. Sir, we have a green welcome for you. I request Mrs. Komal Vasish to come upon a stage to present green welcome to Dr. We are open for question answer session. Any questions regarding this session? Okay. Next, hereby I request Dr. Kuldeep Singh Sachdeva, Regional Director, International Union Against Tuberculosis and Lung Diseases, Southeast Asia, for his talk on experience on TB preventive treatment. Welcome, sir.
Thank you. First of all, I acknowledge support from NITRD and MSF and thank them for inviting me to talk. So TB preventive therapy was rolled out post sort of UN declaration, high level UN meeting on TB in 2018, wherein they sort of said if you have to end TB from the world, then you also start introducing a component of TB preventive therapy, and they set targets for member states, all countries, on how much they should achieve in next 4 years. So they said at least 30 million people received preventive treatment by 2022, including 4 million children. So this is a sort of a global target. And then also within the prevention, they also said look for development of new vaccines, airborne infection control to sort of prevent TB. Following that, most of the countries started thinking about how to roll out TB preventive therapy and what methodology and what guidelines should be adopted. And the global priority on preventive treatment coverage was that you have to at least reach 90% saturation by 2022. But as you will see, most countries are still struggling to roll out TB preventive therapy. But the good thing is that they have learnt and experienced over last 2 to 3 years. India has been slow to scale up, but now almost all states of the country have rolled out TB preventive therapy. They have learnt valuable lessons and should be able to quickly reach that 90% saturation level in another 1 to 2 years. Much of the hesitation on TB preventive therapy is like hesitation on many newer things is, does TB preventive therapy work? How long it protects? Do we need to repeat TB preventive therapy in household contacts? Will this TB preventive therapy increase incidence of drug resistance, which already many countries are struggling to address because you are only using 1 or 2 drugs, which is anti-TB drugs? Is it safe among healthy individuals? Is it safe in pregnancy? Can they be used with antiretroviral drugs? So these were some of the most common questions leading to hesitancy initially in rollout of TB preventive therapy. But there are evidences that answer to all questions is yes, it does work. It does protect for at least 5 to 7 years. You may need to repeat maybe after some time, but we will generate evidence as we roll out TB preventive therapy. It's safe in healthy individuals. You don't get any additional increase in drug resistance. It's almost near zero levels if you use TB preventive therapy. It's safe in pregnancy. It can be used with antiretroviral agents. So, while answer to all of this is in the positive, still to sink into and convince each and every individual in the periphery takes some time, and that process thankfully is now over, and we are now on the way to sort of realizing our saturation levels. There are guidelines on TB preventive therapy which has been developed, and NITRD has been instrumental in supporting the national TB program and development of those guidelines. So I think over the course of the day, most of you have known these guidelines. Dr. Ashraf also did refer to these guidelines. So common symptomatology, the symptoms which we use 4S symptoms for screening. HIV, you don't need to screen if you are HIV positive. So then these guidelines are in existence for HIV for almost 20-25 years now. So I'm not reading out these guidelines, but if there are any questions, I would take them subsequently. Who is eligible in children for TB preventive therapy? So all children less than 5 years of age who are household contacts of a pulmonary TB patient are eligible. All HIV positive are eligible. Now we have also sort of made adults who are household contacts of a pulmonary TB patients as eligible category, so which includes children in the age group of 5 to 14 years, or as Dr. Ashraf said, 5 to 15 years. I mean, it's all semantics. So 15 is less than calendar year 15, which is 14 years and 365 days. So when I say 14 years, it is 14 years, 365 days. So we talk the same language, but in a different way. So these are but what you have to do is you have to rule out active TB before offering TB preventive therapy. So there is an algorithm to rule out active TB. You also have to rely on chest X-rays as a screening tool. That's one. Then there are guidelines that for children less than 5 years, you need not test them for latent TB infection. More than 5 years, you test and treat. Having said that, the national guidelines say that if you don't have facility for testing, you go for treat only. If you have facility for testing, then test and go ahead. So what they are trying to say that non-availability of a test for latent TB infection or non-availability of an X-ray chest in field situation should not be a hindrance to roll out or scale up of TB preventive therapy. And the treatment option, again, Dr. Ashraf has pointed out, is either INH for 6 months. They used rifampicin INH for 3 months. You also have rifampicin and INH weekly dosing for 12 weeks. I'm not going into details of how many milligrams per kg body weight, but then all those are available in public domain. Our project at the Union, we are implementing TB preventive therapy in 7 states of the country, so which is Himachal Pradesh, Madhya Pradesh, Maharashtra, Chhattisgarh, Jharkhand, West Bengal and Assam. And within our project in last about 18 months, we have sort of screened about 39,000 children, household less than 5 years, and initiated about 26,000 children on TB preventive therapy. That's over last 18 months. Between 5 to 14 years, screened about 95,000 and put 62,000 on TB preventive therapy. Having said that, when I refer to the 18-month period, first 6 to 9 months were actually spent on more on preparatory activities, addressing the initial hesitation of providers, the program manager, etc. So the actual period of implementation practically is about a year or so. And in our experience, we have seen that initially there were losses at each step of the care cascade. This is for the last 3 months, but if you see initially first 6-7 months of implementation, the losses at each steps were huge, and they had been addressed systematically subsequently based on our experience in the program implementation. So if you look at less than 5 years, so out of 10,000 ineligible contacts, still the number of child contacts screened is about 82%. So still there are about 18% losses, which earlier, even under the program, because this has been a programmatic policy for almost 20 years, just about 25% of eligible child contacts were put on treatment. So thankfully, we have crossed that stage. With the dedicated program, we are now able to reach a good number of patients. As you say, 80% of eligible contacts are now put on TB preventive therapy, against what you achieved in last 20 years was just about 25% of eligible contacts were being put on TB preventive therapy. So that's the benefit of having a dedicated program and a dedicated personnel to implement a program. So these learnings will go to the national program to scale up provision for additional resources in the form of human resources, provision for, they already have guidelines in place. Between 5 to 8 age group, again same, the 5 to 14 years age group, out of 27,000, approximately 20,000 or 21,000 have been put on TB preventive therapy, which is also close to almost 77 or 78% of eligible contacts have been put on treatment. So within children less than 5 years, it's easier to screen child contacts of an index TB patient than the adult contacts of an TB patient. So dropout in child contacts is much lesser compared to the dropout in adult contacts. This is because here a parent is taking a decision on behalf of a child, and parents are generally sort of easy to convince that you need that treatment for them. Adults, they decide on their own, and so there we are still facing the challenges. So a lot of learnings on adult side. So today's discussion is more on the childhood contacts. And these are how many TB patients we identify during screening. So not many TB patients are being found when you actually are doing a screening. So say in children less than 5 years, when you screen about 10,000 children, the number of cases which you found is just about 8. So you are not getting many cases, but if they are symptomatic, then their chances of having a TB is very high compared to what you find in the general population. So if a child is symptomatic between less than 5 or 5 to 14 years, then the chances of them being positive is almost close to 40%. So if you have say 10 symptomatics in childhood, you will get about 4 who will have TB. So that's the benefit of screening. But if you go to general population, you screen 10, you will get 1 or maximum 1 or 2 as a TB. So positivity rate among household contacts, if they are symptomatic, is the chances of them having TB is very high. So there is a value in screening them for TB and then putting them on TB preventive therapy. The treatment outcomes here is that you don't break down into TB or you complete your treatment. So completion rate with the longer regimens 6H is about less than 90% or 89%. With 3HP or 12 doses regimen is 95%. Intuitively, we also expect that shorter the treatment, shorter the duration of treatment, you will be able to sort of retain them more on treatment. So at which gets proven and on the adverse reactions also we have seen there are not many adverse reactions observed even with 3HP, though they are not very systematically recorded in the field even now. So the conclusion is that shorter regimens are well accepted, the adherence rates are high, the completion rates are very high, and as far as possible the program should go into shorter rifampicin and INH, which is given once a week for 12 weeks. In 5 to 14 year age group, they're almost the same kind of outcomes. Again, shorters are well accepted. So programmatically also, even though the cost of the treatment or the drugs per se may be high, but programmatically you save a lot of cost in the form of better adherence, less intensive monitoring. So it's more that you can reflexly implement a program in a much better way with a shorter regimen. So what the major learnings again are coverage during household visits. For children it's very good, which is more than 95%. You go to adults, it will fall drastically. Counseling, yes, effective counseling helps a lot, and this we have learned over our initial period of 6 to 8 months when the uptake was very, very low. In first 6 months, first 3 months, we could only put 2 children on TB preventive therapy. So, but having learned that counseling helps, we have trained our people to how to talk to a family, how to counsel them. That has played a very crucial role in scaling up TB preventive therapy. But there are still issues in initiating TB, because the whole model is that you visit the household of a patient, index TB patient, counsel them at their household, collect or treat test to rule out TB within their household, etc. But when it comes to initiation of TB preventive therapy, the program started insisting that they go to a primary health center, get a prescription from a medical officer, then they'll be put on TB preventive therapy. Again, there are models that we have introduced a model of teleconsultation, etc. So if they have to go to a stage where they have to go back having received all services at their home, and for the final step, if they have to go to a primary health centers, there was a huge dropout. So again, the lesson is here that you have to introduce, either authorize somebody to offer them treatment once they have ruled out TB there and found them suitable to be put on TB preventive therapy, or introduce some mechanism of teleconsultation, or find a local physician, which probably Kerala model may have done it, involve private practitioners or local physicians, and not the government physician who can say, okay, go ahead, and give them the TB preventive therapy. So the loss, at the final step of putting down of TB preventive therapy can be handled there. Adherence in children is good, again, because parents get convinced. Success rate we have seen is quite good. Issue of tablets versus syrups is always there. So I think MSF will take it up. You need to introduce syrup formulations in some weight bands and some age groups of patients for TB preventive therapy. And that's a lot of advocacy is going on this, and there are some pilots also going on how we can introduce syrup formulations for TB preventive therapy where they need. And Dr. Sangeeta Sharma knows well how much of oral drugs is a challenge in your practice when it comes to treating them for TB, the younger children. Availability of testing services is proving to be a major challenge. Doing an IGRA test in the field is very, very difficult. You have to draw a blood sample from a child at their household by a phlebotomist, which is not easy. I mean, less than just 5 years and above, and you have to draw a blood sample. That blood sample has to be processed somewhere in a laboratory in the field and then sent to a main laboratory where they do the final testing. So you also have a huge sort of quality failures at this level, at the level of collection of blood sample, at the level of first processing in the field, and then the turnaround time, which the program says that from blood collection to final result should not be more than 96 hours. Though now we have sort of negotiated this pathway, it's happening within 96 hours now. Initially there were huge challenges, but we must think how can we actually, Sci-TB may be of help because that's a skin test. Drawing a blood sample in the household of patients and turning around a test result is a major bottleneck. Availability of IGRA and affordability of IGRA is also a major bottleneck. And that is why the scale up is also low, where you insist on test and treat, and turning around a test is so difficult. So the country as a whole will not be able to scale up TB preventive therapy to 90% saturation unless we find a solution to it. Sci-TB is one solution. Other is we have sort of engaged with laboratories which provide a turnkey solution. You share the address and the coordinates of a client. I'm not calling them patients who need to be put on TBT. They will visit the household, a phlebotomist will go there, counsel them, collect sample, ensure quality assurance, and turn back the results. So that's the only thing which is sort of an experience, is that you have to engage with a turnkey laboratory. If the program tries to draw a sample, then send it to a laboratory, then there are two parties involved. Again, the success rate and dropouts again increase. So that's another lesson on the implementation. Supply of drugs from the program side is proving to be a major challenge. Till date, very little, few doses of INH and rifampicin have been made available, which is in few thousands, roughly about less than 50,000. And even availability of INH has not been regular. So that again will prove to be a major challenge. Even the district program managers have to learn that INH is a very cheap drug. It costs less than ₹1 per day. They can buy it on their own, but they don't buy it on their own. So that's a challenge. Again, we have to address those issues. Retrieval mechanism, if somebody is not convinced and they are sort of lost to follow up or not willing to continue, is again proving to be a challenge, and we have to again build up an escalation matrix and sort of employ good counselors for those difficult to retrieve cases. Adverse events, not many reported under the program, but we suspect that not many are actually seriously looked into. People are not actually inquiring into adverse event, but reflexly, no serious adverse events have been reported. So if there are minor, probably they are taken care of. Reporting under the program portal Nikshay is still not finalized, so they are still working on the module, etc. What the partners are doing, they are collecting reporting under an Excel format and sharing it with the national program. Again, but the module is currently ready, is being pilot tested. Hope this learning of last 18 months, maybe another 6 months to go, will help us to sort of reach that, now move on very quickly from here on and reach that saturation level of 90%. So in conclusion, the preparedness of state and districts is very essential to scale up TB preventive services. Engagement of community health officers and ASHAs to ensure services are available without interruption, because they are the people who are available from the program. The projects will phase out, say 2 years from now, and you have to find dedicated resources to sustain these activities. Syrup may need to be introduced. 3 HP regimens have shown a better adherence and successful outcomes. Adverse event management, recording, reporting need to be sort of stressed upon and see that it actually happens on ground. Nikshay entries need to be made real time to avoid huge backlogs. As we scale up, the numbers are multiplying. The numbers will actually outnumber the number of TB patients which you get every year. You get about 25 lakh TB patients every year, and we expect to put about 50 lakh persons on TB preventive therapy every year. So this is double the national program. So there has to be a serious thinking on how do you address such a huge workload and provision for such a huge workload. Thank you for your attention. If there are any questions, I'll be happy to take. Thank you. Thank you. I'll stay back.
I now request Mrs. Komal Vashisht to present green welcome to Dr. Sachin. Thank you, sir. Next, we request Dr. Akshi Kalra, Project Lead Find India, to share with us her insights to share with us the discussion on joint efforts for discrimination of TB.
A warm good afternoon to everyone, and I would like to take this opportunity to thank MSF and NITRE team for inviting me and giving me this opportunity to share our experience of implementing JEET project, that is Joint Effort for Elimination of Tuberculosis, Scaling Up TB Preventive Therapy. I think our esteemed speakers, Dr. Sachdeva and Dr. Ashraf, have already spoken about the background about this PMTPT, Programmatic Management of TB Preventive Therapy, and our background is more or less around the similar point. But by now we all agree that if we are talking about TB prevention, TB elimination, prevention is something which is going to be very crucial in the next 5 years to come to be able to achieve the targets we are setting for elimination of tuberculosis. So I would skip the background. I'll directly come to what this project has been envisaged for. So to address the TB infection burden, this Global Fund grant supported project JEET is being implemented by Find India and 2 implementing partners, TB Alert India and Karnataka Health Promotion Trust as sub-recipient for the period from April 21 to March 24. Our target is basically the 3 activities. The first, we are focusing on intensive household contact tracing. We are focusing on offering contact screening and testing for infection and or ruling out active TB. So our learning from the last 15 months has been that ruling out active TB is utmost crucial. Even if we are not able to offer IGRA at the same time or not able to do any other testing, but ruling out active TB remains very important, because we have identified about 2 to 3% of active TB cases among asymptomatic household contacts. And I'm not referring to just children, this is overall among all the household contacts. And of course, then the linkage to treatment and adherence support. So G 2.0, so basically 1.0 was mostly referring to the private sector PPSA intervention, patient provider support agency. G 2.0 is specifically targeting on the TB preventive therapy. Under FIND, it's operational in 22 districts across 4 states, Andhra Pradesh, Karnataka, Punjab, and Telangana. Project started in 21 after the training on PM-TPT guidelines, which were released in 2021 July, which Dr. Sachdeva was referring to. IGRA testing is being provided into 2 districts. So as Sir mentioned, there are 2 models. One is test and treat, where IGRA is being offered under the grant, and then something called screen and treat, where we're ruling out active TB and then putting the beneficiaries on TB preventive therapy. So in 2 districts, it is a Bagalkot in Karnataka and Mehboob Nagar in Telangana, where IGRA testing is being provided under the grant. In these districts also, we are rolling out 3 HP regimen for the first time on a large scale in the programmatic conditions. And this has been rolled out recently in April 2022, while in the other 20 districts, INH is being provided. So I just wanted to take a minute and kind of describe the project workflow. So we get the data from Nikshay, and we get this from the district NTP officials. We have a cadre who takes out the list of pulmonary TB cases. So we have went ahead slightly from the guidelines, which talks about specifically microbiologically confirmed TB cases. We're also considering clinically diagnosed TB cases. So basically, we take out the list of all pulmonary TB cases. There's a person telecaller who calls the patients and tries to schedule a home visit. Once the home visit is scheduled, there's a TPT coordinator who takes the agreement from the person and goes to their home, trying to screen all the household contacts and mobilize them for health checkup. So this health checkup is basically one for evaluation for contraindications, and second, to rule out active TB. Here, this visit happens over multiple visits. I mean, the screening happens over multiple visits because not at one point of time we are able to reach out to all household contacts. Once all the household contacts are mobilized, a visit is made to the doctor, a medical officer, and right now we are trying to engage the CHOs, that is community health officers. The evaluation is done, and here we divide into 4 groups. So if you see the first group, here we are talking about asymptomatic less than 5 years. For them it's direct. They are directly put onto TB preventive therapy. When we say symptomatic less than 5 years, they are also directed to the health facility for diagnosis and further management if it's an active TB case. When we talk about symptomatic more than 5 years, then we are referring them for X-ray testing. The X-ray testing is being both outsourced to a public sector laboratory at a fixed subsidized rate, which is being funded by the grant, and also from the public sector laboratories. So the X-ray voucher is generated and is given to the patient's family member, and then they are linked to the health facility for further management in case TB is suggestive. Even if TB is not suggestive, first evaluation is done by a medical officer so as to ensure that this is not TB. In case it's asymptomatic, which is for age more than 5 years, we are doing 2 kind of interventions. So one, we say in the pilot geographies, which I was referring as test and treat, that Bagalkot district and Mehboob Nagar, where we are offering IGRA testing. IGRA is provided. So if we are able to confirm that bacilli is there or IGRA is not available, we directly go for screening by X-ray, and if TB is not detected, TB preventive therapy is given. So as you would here see, for us it remains very important if its TB infection is also detected to rule out active TB. So once even IGRA is positive, we want to again put on X-ray to ensure that this is not an active TB case, because ultimately IGRA would only be max to max telling us about an infection, but not completely for disease. And if it's a different geography, that is screen and treat, we directly put them for X-ray, rule out active TB, and then if it's not TB, then the TB preventive therapy is initiated. This process is done for all the household members, and for that, after that, there is a TPT coordinator who kind of supports the beneficiaries until 6 months in case of INH and for 3 months until in case of 3HP. So far when I talk about for children less than 14 years, between 1 year of our implementation, and as Sir just mentioned, Dr. Sachdeva before this presentation, is that initially we all had our hiccups. We were learning, there were a lot of planning and preparatory activities. We have so far, if you would see, I'll show you in a subsequent slide, how things have progressed over a couple of years, couple of quarters, that the improvement in terms of how we are able to even cover the household contacts. So overall, we have about 38,000 household contacts between the age group of 0 to 14 who have been screened, of which about 24,386 have been put on treatment. Between October to November, we have additionally put about 9,000 out of this cohort in on TB preventive therapy. As I mentioned in my previous slide, on 3HP, we have put about 197 household contacts belong to the age group of 2 to 14 years. And the rest have been put on INH between the same period, that is about 25,000. So here you would see, as I was referring to you earlier, that the first was the kind of preparatory phase where we were only able to put 35% of household contacts, and I'm talking about only children here, on TB preventive therapy, which improved over the quarters. We were able to now move to 44 and now 84. And if I was able to show you for October to November, it has reached about 93%. So the compliance is improving. We are also learning from this, but for things to scale up, as also again, I'm quoting my previous speakers, it is important that we have to ensure that these diagnostics and treatment are available uninterrupted in an uninterrupted manner to be able to scale up the TB preventive therapy beyond the project mode. So when we come to the outcomes, for 6H, so far we have seen 84% of the contacts completing treatment, and we have about 90 contacts currently on TB preventive therapy. For 3HP, we have seen about 93%, and these are just the household contacts who have completed treatment recently. And about the rest, all are on treatment. So we do not have any active case identified of who's on 3HP, and neither there is any loss to follow. So definitely it indicates that a shorter regimen has its own advantages, but I would like to here just highlight that the pill burden remains a concern. We are asking for, right now we do not have FDCs available for children. So what they're having is a loose tablets for rifapentin as well as INH, which isn't very easy for consuming for a child, even if it's on a weekly basis. But yes, adherence is definitely better on 3HP regimen versus INH. So some of our innovations under the JEET project, and I would say we are still learning. So we are covering a mix of geographies. Some are rural, some are even tribal, and of course the metropolitan cities. In rural and tribal, we are trying to kind of link with the 104 mobile medical services for evaluation of household contacts in the tribal areas. We're also involving mid-level health providers, which are similar to community health officers, who are supporting us to kind of screen the household contacts, evaluate them for contraindications as well as for active TB, to be able to ensure that we are putting right contacts on treatment. We've also initiated something for like a Ziploc covers for each household contacts, because whenever we used to go to the household contact to kind of follow up with them for the treatment adherence, we used to realize everybody has kept medicines together. It was very difficult for us to find out if somebody has actually taken or not, or if somebody has taken, how many tablets were missed, or how many tablets were taken. So we kind of segregated by pack wise, and this is a very small, simple innovations which really helped us to effectively monitor the number of tablets being taken by each household member. We also worked out with NTP team to kind of get the IDs developed on Nikshay Aushadhi, and this kind of really helped us in managing the drug-intended supply, because this remains a huge challenge. Now, when we are talking about scaling up in 195 districts together with the 2 other partners, it's a huge quantity of INH, or let's say 3HP we are referring to. And proper indenting and forecasting is definitely very important. We also have started some adherence-related SMSs. So one of our important learnings under JEET has been that IEC material plays an important role. This is something we are talking about all our asymptomatic healthy individuals whom we are asking to stay on treatment for 6 months. So kind of to be able to sensitize them why this is important remains absolutely important. And we've also started some innovation in terms of video calling of the household contacts with the medical officers. This especially we have tried in the urban population, where we have challenge of a huge private sector, especially cities like Hyderabad, Bangalore, where we are seeing that the private sector presence is huge and it is difficult to cater their attention to be able to screen the patient or evaluate the patient's family members at the time which is convenient to the family. So some of our challenges, and I think most are common with the discussions which were just scheduled before my presentation. One is private sector's reluctance to provide TB preventive therapy to household contacts. For this, we now have a separate cadre who is onboarded to sensitize the doctors and conduct CMEs and visits, one-on-one visits at the district level. We still foresee this is going to take much longer time because private sector doctors are not very convinced with the provisioning of TB preventive therapy for the household contacts of TB patients. Also monitoring of refills and outcome. I think just concurring with the previous discussion that greater involvement of community health officers is of utmost importance, and we have also initiated trainings at the sub-district level in consultation with the states. Ensuring uninterrupted supply of TPT drugs is very, very crucial. I can state the current status that we do not have INH 300 mg. So what is being supplied is 3 tablets of 100 mg to the household contacts. It becomes very difficult to kind of give 3 tablets a day for 6 months to any household contact. I'm talking about adults here, but for children, of course, ensuring uninterrupted supply is of very, very crucial thing. And this again and again becomes a challenge for us because 3HP procurement is still being planned. And there is limited availability of medical officers considering the time constraints and their vacancies. So I can quote in the 4 states where we are implementing, about 30 to 40% of the positions are still vacant. And where there's a mandate that we have to go through or evaluate everyone through a medical officer. So it's important that we keep on innovating and think of innovative solutions to be able to screen every household member. So we are trying, as I said, about video calling or through fixed day approaches, wherein we have fixed some timing with the medical officers on an alternate days, where they're able to cater to the household contacts of family of TB patients to screen them and evaluate them. We are also taking support of STS at the district level. And again, now we are trying to work out with the community health officers to be able to effectively screen the household members for TPT initiation. So just to kind of bring away from the TB preventive therapy, some other additional ongoing efforts by FIND on the pediatric TB is, one is on the TIFA, TB Implementation Framework Agreement. It's in the 4 states where we are working on improving the non-sputum sample collection at the sub-district level. We're also working on development of roadmap for pediatric DR-TB in 3 states and also finalization of training modules for pediatric TB and capacity building of the trainers. This is being funded through J&J, and there's one Unite to Act project, which is a global fund funded initiative where community-based treatment support is being provided by TB champions to all the patients on treatment regardless of their age. So thank you so much for this opportunity. Open for questions.
Thank you, Dr. Akshi, for sharing us valuable insights with us. Now I request Mrs. Rajni Nirala to come up on a stage to present green welcome to Dr. Akshi Kalra. Moving forward to our last session, I would like to call upon our first speaker, Dr. Satish Kumar, Country Director, Sathi, to deliver his talk on Asian perspective regarding catalyzing pediatric TB innovation, CAP-TB project. Over to you, sir.
Good afternoon, all of you. Thanks to NITRD and MSF team for hosting this important focus of pediatric TB. So I would like to share a brief experience of catalyzing pediatric TB innovations CAP-TB project that was implemented in 10 countries in India, in the world. And in India, it's a private sector focused one. And in the African countries, 9 African countries, ECPAF, Elizabeth Glaser Pediatric AIDS Foundation, implemented the project in the public health sector. But I'm going to present only on the India setting, that is the private sector experience. So this project was actually implemented between 2018 to 21, and we had 2 implementation models. So you can see that the larger one, district-wide technical approach, where we cover all the pediatricians in the district, and in that there is a small proportion of sites called evidence generation sites, where we partnered with them to see the entire pediatric TB cascade, how it is being done and how it can be improved in the private hospitals with the private pediatric facilities. And this was done in Maharashtra, Telangana and Andhra Pradesh, 3 states. In each state 5 districts, altogether 15 districts this project was implemented, and this was done in partnership with IAP at the state, those 3 states with IAP state chapters and the district chapters. So during this project period, we have also supported doing the National Pediatric TB Policy Assessment with CTD, and try to track the progress on that. The report is also kept outside, so when you go outside, maybe the entire folder is also kept there, you can take it up. And also we supported the development of collaborative framework of integrating the TB services with the RBSK and RKSK program. So this book is also available in the CTD website on how the pediatric TB can be integrated with the RBSK, RKSK program. So I will brief the findings from the evidence generation activity that happened at 82 sites during July 2019 to August 21, almost 2 years of the project period. So we did a phased approach where we started with 6 districts and then gradually increased to 15 districts. So we started with 57 private pediatric sites and increased to 82 sites. So each of these sites are pediatric hospitals. Majority of them are pediatric hospitals or multi-speciality hospital with pediatric setup is there. So we did the mapping and we identified and we partnered with them. So how we did that is, in these 15 districts, we mapped almost like 6,000 private facilities. Among them, almost 2,614, 3,000 facilities were providing pediatric services, and we assessed 2,600 of them. And we found around 192 of facilities are either willing to provide or capable of already providing comprehensive pediatric TB services. And we partnered with 82 on an average around 6 to 8 sites per district. We partnered with them. On the map, you can see one example of how we have done in Ahmednagar. Ahmednagar was one of the district. So we can see, each of the blocks are given where more pediatric sites are there. The cluster is there, you have shown, and where we have established the sites, 14 sites we have established in Ahmednagar in 7 talukas, where 8 rural sites and 6 urban sites. So the most important thing is we wanted to have this study done across the district in such a way that both district headquarters and sub-district pediatric sites are also involved and covered in this project. So that way we can understand the experiences of pediatric TB diagnosis and treatment across the district. And similarly, other districts also we had partnership like this. So you can see how we did the project is we did first important activities after the signing of MOU. In each site we identified one staff as a hub staff who was called as hub agent, who has to do a screening of every child who is coming to the OPD through intensified case finding process using that screening form. And among them who is identified as presumptive TB, then the chest X-ray and sample collection was done. So the project supported the chest X-ray and the sample collection funding from our project. So that way every presumptive TB child can be done immediately with the X-ray on the same day. And if chest X-ray is found to be abnormal, or if the doctor wants to do sample collection even without chest X-ray, the sample collection was done on the same day. And if the doctor wants to get an expert radiologist opinion, we had an expert radiologist to whom the X-ray was sent, and then the doctor gets the opinion from the expert radiologist. So all these 3 activities were funded by the project. Then after that, if a sample is sent to the NAT centers, both CBNAT and TrueNAT. In Andhra Pradesh, they had more TrueNAT machines. You all must be knowing TrueNAT was first scaled up in Andhra Pradesh. So the NAT investigation was done. And then anyone found to be TB positive, both microbiologically and clinically diagnosed, then the program FDC was given. Initially, the private sector FDCs were given prescribed by the private sector, but the program supported the access to public sector FDCs. After the FDCs were given, the pediatricians were trained. Actually, when this project started in 2018, the National Pediatric TB Guidelines first TOT happened in Mumbai, and we supported the project national TOT, and we also supported the state TOTs, and then we did the district trainings. Because of that, the pediatricians mostly were already trained or sensitized during this 2019 project project period. So the most important thing is facility-based contact tracing. We requested pediatricians to also do facility-based contact tracing of every child. Whenever a child is found to be positive, other family members' history were asked, and then they did the facility-based contact tracing, and further home-based contact tracing and TPT initiation was done. And this was done at the time of 6 INH prophylaxis period. Yeah. So this is the ICF screening tool. So you can see the left side of the form where every child, when they come, they are screened by a paramedic staff, and if any of the symptoms are yes, even if cough is yes, difficulty in breathing, fever, night sweat, any of the common symptoms for which a child comes to the OPD found to be yes, then the hub agent marks it as yes and then sends to the pediatrician. The pediatrician fills on the right side and asks for specific symptoms, and if it meets the criteria of presumptive TB, then it is labeled as presumptive TB, then the child will be evaluated further. And we provided a nominal incentive of 2,000 to 4,000 rupees to each of the hub agent, so that all the children would be screened in a diligent manner. And also incentives helped in doing a chest X-ray on the same day whenever a presumptive TB is identified. In addition to giving during the training process algorithm and other information given, we also developed this treatment regimen chart and the TB screening poster, and we stuck these posters in all the sites. In fact, we gave these materials to all the 2,000 pediatricians in the 15 districts. We gave them in that way. So IAP led state and district trainings and one-to-one sensitization visits periodically, and sharing the IEC materials helped to stick to the guidelines and following the guidelines. So whenever a child is identified as presumptive TB and abnormal X-ray is found, or even lot of times doctors wanted to do a sample collection even before X-ray results come, so they took the sample and then sent it for CBNAT and TrueNAT investigations. Almost 50% of the children who are identified as presumptive TB, sample collection was done, and the samples were sent for testing. These are the samples that were collected, that is lymph node biopsy, nasopharyngeal aspirate, lymph node aspirate, expected sputum, induced sputum, gastric lavage, CSF and pleural fluid. And so the project provided financial support of around 500 to 2,000 rupees based on the type of procedures. We have in the MOU itself, we have agreed on that, so we paid for that service so that the patient don't need to pay. And sample transportation also helped the evaluation with NAT. And we also partnered with pathologists, because the most important challenge we found is that child with FNAC, lymph node swelling sent for FNAC. Most often the sample is taken, but cytology is done, but CBNAT or NAT test was not done. So we engaged the pathologists also in the district, so that no sample is missed out for the NAT testing. And our overall positivity rate was only 5% of the samples came to be positive, but it was very high positivity, around 20 to 30% positivity came on from the lymph node samples, whereas the gastric lavage, induced sputum, these sputums sample positivity rate was 5%. The summary of the the overall done 2 years of data study is that almost like 11,68,000 children came attendees during the period. Among them, the screened were 72% were screened. In the initial project first year, a lot of children were not screened, so there were challenges. But later on, the screening of every child was done, and during COVID days also, because the project the peak of the period was during COVID, so several of the children there was missing also. But on the whole, 72% children were screened. Among them, any kind of symptoms which are non-specific symptoms came to be 63%, that is 5.3 lakhs, because any child come with cough and fever is is symptomatic. So that is 63%, and with the screening numbers, if you see, 0.4% of them were identified as presumptive TB. That is 3,499 out of 8,41,000 screened came to be identified as presumptive TB, and among them 10%, that is 395, close to 395 were found to be TB positive, which is 0.04%. So we found that a number needed to screen to identify a presumptive TB in a common Indian private sector setting in 3 states. We found around 240 children have to be screened to identify a presumptive TB, and around 2,000 children have to be 2,129 to be screened to identify a TB positive from this experience. So literally we can see a private sector pediatrician sees around every day 30 to 40 OPD. In a month, 1,200 cases they see in their OPD. So if a private sector pediatrician can identify possibly 1 case in a month, if we go with this, then possibilities of high load pediatric centers can identify 1 TB case in a month, or at least 6 cases, 1 to 2 6 cases in a year they can identify. So if with that, if we go, then if a district has around 100 pediatricians, definitely they can identify 100 to 200 pediatric TB and notify. But if you see the data in a district, maybe 50 to 60 cases average is reported in a district of pediatric, pediatric TB reported. So this is a very great learning for for us to take, focus on the pediatricians' engagement so that all pediatricians can report the cases. Coming to treatment initiation, we identified 11% of the presumptive TB STB positives. In that, 99% were started on treatment and 89% successfully completed treatment. 5% lost to follow-up and 5% death was also reported. And majority of the TB cases identified were less than 6 years. One of the important thing is by engaging pediatricians in a systematic manner, we found that this project was able to identify less than 6 years children in a good way. So almost like you can see 51% are less than 6 years, and the rest of the 51% were above the age group. So that's the most important findings came here. It's not actually less than 6 years, less than 10 years were identified, which is 14 in that way. So increase in the proportion of pediatric TB cases also initiated on public sector drugs. You can see the graph. Year 1 when we started, 79% of the pediatric TBs were given on public sector drugs, but over a period of time the doctors switched to public sector FDCs, and it increased to 90% and 89% during the period. So we can see this slide where each of the private FDCs and public FDCs is there. The first FDC is INH rifampicin pyrazinamide combination 50, 75, 150 is the public FDC, but there are a lot of private FDCs are available, and these are still available in the market. So most of the time pediatricians prescribe the private FDCs, but after the training they understood the government drugs FDC is a standardized dose, and they switched to the public FDCs. So advocating with the public providers, the pediatric providers, and linking them with the government FDC helped to improve this. This actually came out as a case study in the recent WHO guidelines booklet, and they have published this also. And so thanks to IAP for actually promoting this use of public FDCs in all their trainings. And after that we did the reverse contact tracing of these the child index cases, and we found that out of them 45 are eligible and 33 were started on the IPT. So there were initial challenges. The most important challenge in the initial days were that families were not interested to start the IPT, but we have heard a big experience already on IPT from the 2 presentations earlier. But if we believe that if the pediatrician recommends the IPT, talks about IPT to the families, then in the household visit and contact tracing visit and talking about IPT, the acceptance will be much better, because they feel child is healthy, why should I start IPT is a question they always ask. So if pediatrician initiate it, it will be a good one. So that is all about the experience from the 82 sites. So when we are doing this project, COVID came, so we had challenge to understand, how to increase the numbers in the district. So we tried to, we got the data of the entire district pediatric data last 4 years. We analyzed to see who are the practitioners who treat children in the district. So you can see that the age group, wise graph 0 to 5, 6 to 10, 11 to 14 years. So you can see 75% of the children in 0 to 5 years were treated by pediatricians, and the rest are by general physicians and others. Majority of the Ayush practitioners are the local practitioners whom we visited to understand whether they treat children. Fortunately, no, 0 to 5 years, lesser age group, they are not treated by Ayush or local practitioners. But as the age increases, the other practitioners increases. So you can see the pediatricians proportion coming down and the general practitioners proportion increasing. But as the age increases, definitely the Ayush and local practitioners visits increase as such. So we understood the practice, and also one of the important others is ENT doctors. ENT doctors see a lot of lymph node swelling, so we have engaged them also over a period of time. So with this analysis of the 15 districts for 4 years, we understood whom to be targeted in that way. So what we did is, even though it was a COVID period, so we tried to engage with the other practitioners to increase the district level pediatric TB numbers. And so we can see that out of close to 1,200 private pediatric facilities in those first 6 districts, we found almost like with rigorous follow-up, almost 563 facilities reported at least one time presumptive TB, and 431 facilities reported at least one time TB cases. So that has actually also increased from 2019 to 20, and in 2021 first 6 months data we have presented. So even during COVID phase with the follow-ups, the all practitioners reporting TB cases increased. And this is one case study of Karimnagar district in Telangana. We want to share that the Telangana state performance is out of 100 TB cases reported. In Karimnagar district was 3%, but with the follow-up of every private pediatric practitioner in Karimnagar district, the 48 out of 153 facilities reported pediatric TB cases, and that baseline was 1%, meaning before the start of the program, and it increased to 3%. So it happened that all pediatric practitioners were engaged and they reported the cases. So the learning from both the models, where you work with the selected doctors as hub sites and you work across the district also to increase the coverage of pediatric TB. So we learned that if we want to increase pediatric TB in a district, we need to have both approaches. One is a targeted approach with a selective pediatric TB hub sites, and the other one is cover all the pediatricians, pediatric practitioners in the district, so that you really saturate the coverage and increase the numbers. And when we, the basic learning from this I want to share is that we know in the country now PPSAs are there. Like all of us know, PPSA are the implementation agencies who work with the private practitioners. But we see that they are not able to strengthen the pediatricians' engagement at this point of time, and also not every district has private radiology center, private pathology center, and pediatricians as subsites. Currently, there are pediatricians are not engaged as subsites. Currently, there is no private radiology centers and then pathology centers there every district. So if we have to build a model, first we need to map and identify all pediatric providers, engage few sites as hub sites, and define the partnership arrangement with them for pediatric services, and sign MOU with a few private pediatricians as hub sites, and private radiology centers, and also pathology centers as FNAC centers. Currently, I can quote one example. Maharashtra state, when the project was transitioned, Maharashtra state added gastric lavage as one of the model, and now they are going to sign MOU with pediatricians. In Telangana, they have listed the radiology centers for X-ray, MRI, like that. But not all the states have come out with this model and budgeted in this way. So if you have to really do this pediatric TB scale up in private sector, each state, each district should have pediatricians as hub sites, private radiology centers as one of the partner, and pathology centers as partners. Otherwise, there will be definitely delay would be continuing in that. So after this project was over, now we are currently working in another pediatric TB project in a small scale under the TIFA project. We are seeing that even though PPSAs are not there, but these facilities are not there, so hence really it's not getting implemented. So, we see the challenge is there. So the key learnings for partnership is that engage pediatricians to increase the 0 to 5 year age group notification, engage high load pediatric sites as private hubs in every district, engage different type of providers for increasing the district pediatric TB coverage, and partnership with IAP at district and state level, and also other physicians and ENT doctors and pathologists would help to saturate the coverage. And for PPSAs, we need to advocate to include pediatric TB as soft targets, not the performance-based target, because PPSA has a lot of challenges, currently in the implementation, fund flow issues. So instead of putting the pressure on performance-based, at least add pediatric TB as a soft target under non-performance-based target. And we need to have guidance to establish pediatric TB hub sites in each district because there is no budget allotted for these private hub sites. We need to have the budget. This project, as I explained, we had a budget for X-ray sample collection. So similarly, each district should have it. And partnership with IAP is required beyond the training. What we have heard from Dr. Vinod sir here is that IAP is training the pediatricians in each district. In 200 places they have done already, and another 100 they are going to do. But with IAP we have to go beyond the training, where we need to have one nodal person identified from pediatricians, IAP in each district, and then they can identify and recommend few pediatricians from each town and city, so that we can have a standardized rate for each procedure, sample collection procedures, and we can follow the same procedure uniformly in each state in that way. And they can also participate in periodic review meetings at the district and the state, so that we can see really in each district how the performance of pediatric TB can increase. So these are some of the learnings I want to leave with the recommendations. Thanks to all the children and the SCAP TB pediatric sites and all the stakeholders of TB program for the support. Thank you.
Thank you so much, sir. I now request Dr. Kanish to come up on stage and present green welcome to Dr. Satish Kumar, sir. Thank you, sir. Coming on to the final talk of the evening, we now have a recorded lecture by Michael D'Souza, Project Director, CAP-TB, Elizabeth Glaser Pediatric AIDS Foundation, on global challenges and the lessons we can all learn from India and Africa. Thank you.
Good afternoon, everyone. My name is Michael D'Souza. I'm working for the Elizabeth Glaser Pediatric AIDS Foundation. I'm talking to you from Geneva. This is actually a recording because I thought it was safer to record the presentation to avoid any risks linked to internet. But I am currently listening to the MSF-TB days, and I will be available for questions at the end. What I want to present are lessons learned from a project called Catalyzing Pediatric Tuberculosis Innovations, funded by UNITAID, that lasted for 4 years. This project was implemented in 9 African countries that you see here on the map, so it's namely Côte d'Ivoire, Cameroon, DRC, Uganda, Kenya, Tanzania, Malawi, Zimbabwe, and Lesotho, as well as in India. For India, key features of the lessons learned will be presented by my colleague Dr. Satish from our partner organization SATI. For the 9 African countries, I will be presenting evidence and lessons learned regarding integration and decentralization. So integration in non-TB entry points, decentralization to lower tier facilities, as well as elements linked to intensifying household contact investigation for TB, for children who have been exposed to TB index cases. First of all, everything started with trainings, and I do say that it's a key feature, and it was very important that I mentioned this. Through the project, we run trainings that are allowed to train around 7,000 healthcare workers and community health workers. These trainings were key to increase the visibility and the attention given to pediatric TB, as well as strengthening the confidence of the clinicians to screen, diagnose, and treat tuberculosis. The trainings were developed using material available through the WHO, through the union organization, and then also on national material. It's very important to know that ECPAF works extremely closely to the Ministries of Health. So it was extremely important that we always work with the Ministries of Health, using the materials that are available, updating them. And it was also very important to make sure that the trainings were provided hand in hand with people from the Ministries of Health. This was important both in terms of buy-in and access to the clinics, and as well as in terms of sustainability, because these people remain even at the end of the project. Another element important for sustainability is that towards the end of the project we worked with the union to update the training material that is available online. So you see here the URL. So basically with the union we updated the training material regarding pediatric TB. It's still available online in English, French and Spanish, and it will remain there until there's more updated material coming up. Most likely this year or next year it will be done by WHO, now that the WHO has reviewed the training material, the guidelines and handbook linked to pediatric tuberculosis. A key feature that I wanted to highlight regarding the trainings, I mentioned already that it's super important to involve national counterparts, both in terms of sustainability and in terms of direct implementation and buy-in from colleagues when we were providing these trainings, and sustainability after the end of the project. We were looking also at whether it was more efficient to provide training on-site or off-site. So off-site is when you rent a facility and you bring people there to be trained. And it was obvious that in most countries it was much more efficient to conduct training on-site. So basically going to the sites in the afternoon when there's less patients and training people there. Another key element was to make sure that there's a good synchronization between the trainings and the supervisions. So because it was hugely important that trainings are not a one-off thing, and that they are followed by supervisions 2 weeks after the initial trainings and in 2 months, etc. So it was important that the same people with the same knowledge of what was provided during the training are the ones also conducting the supervision. Now I want to present some elements regarding, if we don't look at the first column, which is linked to contact investigation, and I will talk afterwards. The middle column and the last column really talk about the integration. Integration means finding children with tuberculosis in non-TB entry points, PET, and then so we had screeners who were present in waiting areas at the triage, looking at whether children presented signs of tuberculosis. If they did, they were brought to the clinicians where the clinicians were further investigating to potentially make a diagnostic of pediatric tuberculosis. We also looked at decentralizing, making sure that TB care is not available only at the higher up level, but also in middle level district hospitals as well as lower level healthcare facilities and dispensaries. If we look at this slide, which comes from India, I thought it was quite interesting as well to present. The first element means really that there is a need to collaborate with other projects that exist. So in India, we collaborated with community work, with work provided in schools and at community. We looked for children who might have signs and symptoms of TB in nutrition points, in MNCH, in private clinics, obviously in India, at home when we did contact tracing. If children were found to have signs and symptoms of TB and they were TB presumptive, they were then brought to the facilities where samples were collected, either through gastric lavage, induced sputum, etc., to be then diagnosed. If the children were found to have TB or be eligible for preventive treatment, then the children were started on either treatment or TPT. A key element was to adapt the screening material. You all know the 4 questions that are standard for TB, but we felt it was very important that for children they are adapted. So there's obviously cough and fever, there's also night sweats, which you know, but we added difficulties of breathing, we added history of close contact with TB, we added neck swelling. When I say we, actually, ECPAF proposed, but all these elements were reviewed by experts at WHO and in other organizations to make sure that they really corresponded to elements that would really increase the sensitivity of this screening. We conducted the screening in various entry points, and you see here in all the columns a lot of entry points. You don't need to read it, all the numbers. But what I want you to look is at the last 2 lines, those that have these elements rounded at the bottom. It's the numbers needed to screen. So basically how many children you need to screen before you find 1 case with tuberculosis. If you look at the column in blue, that's household contact tracing. I will discuss it a bit more afterwards when I talk about household contact tracing, but basically you see that in this, you only had to screen 43 children before you found 1 case with tuberculosis. Whereas when you looked at hospitals, you needed to be a bit more, but still, like, doing screening for TB in IPD was extremely efficient and had a very high yield or very low numbers needed to screen, as you only needed to screen 91 children before you found 1 child with tuberculosis. If you look at absolute numbers, most children with tuberculosis either came from OPD, just under 6,000, or from IPD. So it was, we can say from this that it's hugely efficient to look for tuberculosis in IPD for sure, but also in others, like in HIV, maybe you don't have an absolute number that is so high, you only have 500, but still it's extremely efficient to look for children with tuberculosis in HIV entry points, as well as, you know, in nutrition entry points. I want to show this graph only very quickly to discuss one element, is the screening in mother and child health entry points. Obviously, maybe it's obvious, but we really needed to document that. In most countries, children who attend MCH are actually not sick. They are healthy children who come for vaccination. And in these, the yield of screening for TB wasn't very high. Yet, for example, if we look at Kenya, Tanzania, and Zimbabwe, which are countries where MCH also attend children who are sick, the yield for screening for tuberculosis was much higher. So the conclusion really is that if you have to prioritize, if you are limited in terms of funding, you need to screen in entry points that see sick children. We wanted to see whether all this was efficient and whether it was worth it. So basically, we run a pre and post analysis. From all the sites that we supported, for 144 sites, we had data before implementation. And then we collected data from these same sites during the implementation. We see that before the implementation, there were more or less 191 children found with tuberculosis per site per month. This increased to 280. So basically, thanks to the project, the increase was about 46% of more children were found to have tuberculosis. If we look at the capacity of the project to decentralize TB screening in lower tier facilities, looking at these same 144 sites, we see basically that the project didn't have a huge impact on higher facilities, like central hospitals, university hospitals. Basically, there was no improvement. But then if you look at the lower tier facilities, the capacity to find children with tuberculosis, to screen them, to diagnose them, to then put them on treatment doubled. Actually, per month, per site, before the project, only 71 children was found with tuberculosis in lower tier facilities, and this doubled to 139 children found with tuberculosis during the project. So, what can we learn from this? It is very impactful to screen for children in lower tier facilities. That it is extremely important to make sure that there is a linkage. I mentioned before that there was screening provided in entry points, including non-TB entry points. But at the end of the day, children who are found to be presumptive or who are found to have TB needed to go and see a clinician who knew about TB. So it was hugely important to make sure that we escort these children or their parents through the clinic to make sure that they are not lost. For example, through OPD, then to the diagnostic, then to the TB clinic, and then for initiation. And then in blue, obviously, what I mentioned before, that we really found that if you have to prioritizing entry points where you see sick children is where you find more children with tuberculosis, and then your intervention is much more efficient. Another key feature that I mentioned in passing, but when I say that we conducted screening in waiting areas and the triage, we worked with lay workers. We found it hugely important to have staff trained specifically on screening for pediatric TB, who are positioned there in non-TB entry points, talking to the parents, asking questions for screening, and then would refer children who they believe had signs and symptoms of tuberculosis to their clinicians to actually further push the diagnostic. Another key feature I want to discuss about is contact investigation. Again, it was presented in the last union in October. So basically, you can have two types of contact investigation. You can either do it at facility, so you basically ask the patients who have tuberculosis to bring their children so that they are screened, or you do at the community. So you ask the patient to give you the address, and then you send community health workers to the homes to screen everyone there. And then once children were screened, if they were found eligible, they would be started on preventive treatment. If feasible in some countries, in most countries it was feasible to start them on 3 months of RH. In some other countries it wasn't feasible, then it would be 6 months of INH, or also depending on whether the children had other drugs that didn't allow them to be put on RH. We also provided transport vouchers, either for the family to actually support their coming to the facility where they could be screened, or at least to the community workers to make sure that they don't waste money while going to the community, and then they are willing to go to the community and go potentially more than once to really make sure that they find the children. I mentioned before that contact tracing can be done either at a facility or at community. What we tried was really to support the ability of community health workers and clinical health workers to conduct appropriate and optimal contact tracing. In most countries, we were able to support with additional staff. Not in all countries. You see, for example, that in country 1, country 6, and country 9, the small V is in black because it basically means that we were not able to increase the number of staff. In other countries, like country 8, we provided a lot of staff to help with screening, to help with contact tracing at the community. In result, we see actually that in countries where we helped, I mentioned before country 8, in countries where we helped staff to do contact tracing at the community, it really increased the capacity to screen children at the community. See country 8, from 1,400 children who were screened after having been in contact, almost all of them were actually screened in the community. At reverse, in countries where we're not able to provide staff, and all the screening was actually happening in the facility, then obviously most of the screening is actually happening in the facility with very little happening in the community. Actually 3% of the contact tracing done in country 9 was done at community level, and all of it was done at facility level. The question then is whether it's more efficient. So we actually looked, you remember the numbers needed to screen, and the column in blue before what I told you that actually the NNS of contact tracing was very low. It actually varies a lot by country. If you remember, it was 43, so you needed to screen 43 children in order to find one positive case. Now, for example, in country 8, in country 2, sorry, you needed to screen many more children, 188 children before you found one case. But in country 8 and 9, you only needed to screen 10 and 15 children before you found one child. And if I just go back very quickly to the previous slide, you see that in one of the countries, now I can't go back to the previous slide, but you see that in country 8, we remember that in country 8 we were supporting contact tracing at the community, whereas in country 9 we were not supporting contact tracing at the community. It was all happening in a facility. So it really, and both have the same yield. So it really depends on making sure that you adapt to the reality of the country. In some countries you need to go to the community to find children. In some others, parents are willing to bring their children to the facility to be screened. What we saw is that this intervention hugely improved our capacity to initiate children on preventive treatment. Again, we looked at sites prior to the intervention and after. In red, you have the status of the number of children initiated on TPT per month before the intervention, and in green during the intervention. And you see, for example, huge increases. This one in country 3 is amazing. There was an increase by 15 times more children who were initiated on TPT thanks to the intervention, during the intervention, compared to before. This is due to increased capacity to look for children and increased attention to pediatric TB and attention to screening for children with, or to screening for children who have been exposed to index cases, and the confidence of clinicians to actually start TPT. In some countries, we actually, as I mentioned, we're also able to start children on 3-year age, which we don't have data because we were not allowed to do a strict analysis, but we do believe that putting children on 3-year age has increased the willingness of children to be started on preventive treatment and the adherence to the treatment. So if we look at a few key elements regarding this element of contact tracing, we saw that it was extremely important to introduce dedicated human resources, be it volunteers, ex-TB patients. For example, in DRC, the volunteers were actually ex-TB patients, and it was hugely important to have these people. We saw that it was also important to provide food and transport for the community health workers to go to the facilities, and in some countries for the parents who bring their children to the facility themselves. Another element that was really important was to actually introduce contact registers and TPT registers to make sure that there's a good interlink between the community workers or the people who provide the screening at the community and the TB focal points, the TB nurses in the facilities. Another element that I want to highlight is the sensitization and the work with the community and community leaders. In many countries, it's not obvious that you actually, it's worth it to bring children and give them drugs while they don't seem to be sick. So a huge work was done on increasing the awareness. These are posters from Côte d'Ivoire, developed together by ECPAF, UNITAID, and the Côte d'Ivoire Alliance for tuberculosis, telling that if people work together, if parents bring their children to screen them for tuberculosis, if index cases bring children to be screened for tuberculosis and avoid contamination from one to the other, it's feasible really to find children and to increase their protection. Very quickly, I want to mention what happened in India. Again, most likely Dr. Satish will talk more about this. The model implemented in India was slightly different in the sense that it was reverse contact tracing. So basically, from the index cases that were found with tuberculosis, 367, almost all of them we were able to go back to their homes to look whether they have siblings there, to look whether the potential adults who had tuberculosis and gave it to these children who were found to have tuberculosis had also been in contact with other children. From these other children that were found to have been in contact with tuberculosis, 73% of them were initiated on preventive treatment. Another element that is specific to India is that actually people are eligible to have direct benefit transfer when they have tuberculosis. And almost all of them who requested for these benefit transfers received them. So what I can say is that contact investigation was really critical to confirm when a case had tuberculosis and to look for children through contact investigation has a really impressive yield because we only needed to screen 43 children before we found one case. Yet it's time consuming, it's heavy in terms of human resources, so you really need to make sure that there is people available to do that screening in TB entry points, available to conduct the contact investigation. And then, as I mentioned, we saw that in countries where it was feasible to implement a shorter regimen like 3RH, most likely it increased the number of children put on treatment and their adherence to the treatment. So I want to finish here. I want to really thank Unitate for the funding and the support they provided, as well as the Ministries of Health, the staff and the civil organizations with whom we worked, and obviously all the ECPAF colleagues, both in countries and in headquarters in Washington, DC and in Geneva for the support that they provided. Thank you very much and goodbye.
We are open to questions from Dr. Satish Kumar sir and Michael D'Souza if any of the audience would like to ask any questions. Finally, I request our esteemed director, Dr. Ravindra Kumar Diwan, to kindly share his thoughts and words of wisdom with us and to conclude this evening. Welcome, sir.
Thank you, Prerna. Okay, so it's the fag end of the day, and yet I see an enthusiastic audience here, which is showing the commitment of MSF as well as NIT-RD to work towards the cause of generating knowledge, research, as well as awareness, information, and advocacy for treating tuberculosis. I think whatever we have learned throughout the day, it has been substantial. It started from the diagnostic challenges, the treatment challenges, and covered various aspects of the challenges we suffered, we see and we face during the programmatic implementation. It's an ongoing journey. Our association with MSF, I hope it will grow further and further. We will address other areas of tuberculosis also, like palliative care, rehabilitation care, surgery, or even diagnostic challenges in other specific dedicated sessions. As I have discussed with Dr. Farhat, I again extend my sincere thanks and gratitude to Farhat for making this collaboration between NIT-RD and MSF firm and strong, and other partners who have joined, the PATH, USAID, other people have also joined, and senior professors who have come, Professor from Kerala, sir, you have come, and so I'm thankful to all of you that you care to join and take active part in the deliberations. There was a lot of interest, as we can see in the beginning, when we had very intense discussions. And I can tell you that NIT-RD, since at least 2003 or 4, has been involved in various forums to consolidate, to refine, to give suggestions to the National Tuberculosis Control Program. It has reached this stage that it is still evolving, and this phase when the Prime Minister has given the call for ending TB, it has added momentum to it, and our meetings are much more frequent. And Dr. Mattu is not here right now, but Mattu has already promised that most of these changes which are in the thoughts, in the mental horizon of people here are going to be implemented soon. They are just consolidating research. For instance, TPT has already been rolled out. Similarly, BCG revaccination, there was a meeting earlier. So things are working on a mission mode, and I understand from bureaucrats and politicians in ministry, they are also taking a stock in a day-to-day basis. But we as medical professionals and people who are concerned professionals in other specialties who are working towards this goal have a duty to let the thing things should take shape in an absolutely scientific and academic manner, and we should not be sometimes steamrolled, but just because an urgency to achieve something which is of a political nature. I suppose we have to keep the patient's interest in mind. And MSF and those people who are working in very distant areas and sometimes say tribal belts or areas infested with Maoist violence or war-torn areas, they bring an entirely new dimension to what kind of challenges are faced. We may talk on theory many things here, but how to make them implement in actual practice. And this kind of interaction with a person who is working in a field, whether field of the nature in which MSF provides or field which our normal government system provides, which is different from every state to state. It is very different. The kind of interactions that all of us come together and talk to each other, we form our friendships, associations, and further collaboration. Sometimes a research idea may come forward, sometimes a new idea, absolutely new way of looking at things may come forward. So these are very enriching, and on behalf of the NIT-RD, I thank you all. Have a good day. Thank you so much. Great.
We have tea and refreshments in the lunch area. Thank you.